was X in population Y over a period of time. So if something occurs very regularly with your intervention, it is possible your intervention has caused it. But it's not always the case. The next theory is what we call the counterfactual. And I have a slide more on it, because this is actually the basis of what we can use. So the counterfactual framework looks at the difference between two otherwise identical cases, the inference basis for experimental and quasi-experimental design. So counterfactual, as I told you, is what is not factual, what is sham, what in mainstream science we call the control. For people who have been giving me assignments for evaluation, I always ask, where is the control? That's the counterfactual. For example, I'm going to evaluate the impact of cast, but you have done cast everywhere. So I don't have the counterfactual. Yeah? So we looked, remember the phases we went through, some districts where they did, so because we need that counterfactual. Yes, we have passed the regularity as a theory, but that counterfactual is needed. In most cases, in programs, it is not there. The third one is what we call the multiple causation, a combination of things which are causing the same outcome. Yeah? And then the generative, and then the next one. Let me go to the table so you will be able to follow properly. So this is a table. I hope you can see it where you are. So this table is looking at the theories I've told you of trying to say that something caused something. The first one is regularity. The next one is the counterfactual. The third one is multiple causation. And the fourth is generative. These are the attributes. So what do you require for regularity? The requirement is that one of the requirements is that something is happening many times in an independent environment. Yeah? But when it comes to counterfactual, you can see you need a control to cut the long story short. For multiple causation, you need sufficient numbers of the event occurring in an independent environment. Now, these words are a bit theoretical, and that's why I told you, that's why people had left this impact evaluation alone. Because the words, they don't seem to make sense. So the requirement, that independent environment, where do you get it from? Yeah? You are implementing, let's say, the latest innovation we have is what? Is cast. So I will keep referring to it. So you are implementing cast. So you need it in an independent what? Environment. Such that you can be able to tease out. So you can see, when we did the evaluation of cast, we went through all these things. Some places we use regularity, counterfactual, where we have some districts which have not implemented, but also we look at the numbers. Yeah? So if you went in cast 1 and found more cases, cast 2 you found more cases, cast 3 you found more cases. So it is likely that actually this intervention is working. Yeah? Then we have the strength and the weaknesses. For example, the weakness of regularity is that there are difficulties in explaining how and why to construct the validity. The weakness of counterfactual is generalization and the context. And of course, the absence of the counterfactual. You don't have the control in most cases. And even when you have the control, yeah, the control is not similar to your intervention. For example, one of the interventions we are evaluating is the childhood TB intervention. Yeah? That intervention, the districts which were selected to implement it, yeah, were the districts which were poorly performing. So if you want to go and find a district to control, you are now going to be comparing a poorly performing district to a well-performing district. So the counterfactual is not real. Yeah? And then the rest can be as you can see them there. I hope you had time to read through the slides. Now, causal patterns. This is also another concept that I want us to look into this morning. How do things cause others? Yeah? There are patterns. One of them you will have a situation where one intervention causes one outcome. But it could also be possible that one intervention is causing two outcomes, and that second outcome is interfering with the first outcome. Yeah? Then you can have multiple interventions causing one outcome. So when you are given an assignment to evaluate the impact of an intervention, you have to go through a process where you think through all these possible cases. Yeah? We want to improve case finding. Yeah? Then we have CAST. The outcome is increased case detection. The intervention is CAST. Which other things are likely to cause increased case detection in a district Y? And you have to list all of them and control for them. For people who worked with on the CAST evaluation, you will see actually the paper is finished, it's going to be published, it has been accepted. Remember what we went through and what the reviewers were asking. Are you really sure that this increment that you have seen is from the CAST? Wouldn't it have occurred anyway? Yeah? So when you create the model, you have to put all those factors into your model and control for them and say, what I have remained with, this 30% is from CAST, beyond doubt. It takes a lot of discussion with different stakeholders in the evaluation, the programmers, the evaluators, the stakeholders who received the intervention, such that you can be able to come up with what is the true impact of your intervention. Now let's come to this word, the counterfactual. Because I told you in the first slide, the important thing is to identify that your intervention has caused that outcome in the absence of other facts. So the counterfactual, like I told you, it relates to the control, to what is not factual, to what is sham, to anything. Yeah? It relates to expressing what has happened and is not the case. Yeah? So, when you bring in the counterfactual, you now start to go into the science of randomized controlled clinical trials. Because you want a control. But unfortunately, unlike in medicine and other experiments, where you can randomly say you will take this drug, you will not take this drug. In programs, you cannot randomize in most cases. Yeah? You cannot randomize. So what do? You still need to find the counterfactual. So counterfactuals is based on the theory which was advanced by Mills. That is sometime back, 1806. And he came up with these methods. So I have to tell you these things, such that when we get to the exercise, we apply them. Yeah? So this is what Mills said. How do you find the counterfactual? So he advanced this theory in 1806. So he has what we call the method of agreement. The method of difference. The method of both the difference and agreement. The method of residues and the method of concomitant variation. So here, for impact evaluation, because our interest is the difference, we are going to concentrate on the method of difference. What is the difference? Did it really happen? So the method of difference helps us to establish that a certain factor is sufficient, yes, in bringing about a certain effect. There is a slide I'm not going to take you through. Sufficient alone, sufficient with others, necessary, sufficient, but we will stop here. So it tells us to look at some factor that is present on the equation when E occurs and absent in other situations. So this is the theory of the method of what? Of difference. So whenever you want to find out if something caused another, you are going to use the method of what? Of difference. So, what are some of the designs that we use to find if there is a difference? Of course, the simplest, you know, that we always run to is the before and what? And after. Yes. The before and after. That's the easy one. But it has some problems. Yeah? You can have the with and without. You can have cohort studies. You can also do repeated cross-sectional evaluations. Yeah? But in most cases, the higher you go in the design, the cost increases. So there are issues with some of these. For example, the before and after. Many things change over time. So when we are looking at the impact of cost, you will see when the paper comes out. Yes, we have seen that cost controlling for all the things was associated, is it 1.69? I think 1.69. That's the final impact of cost. So cost, the moving everything else, caused a 69% increase in what? In case detection. Yeah? Now, the question is, wouldn't that increase have occurred? Okay? That's the question. Wouldn't it have occurred? So we went back and looked at 10 years and designed a model to look at the time series over the 10 years. Why didn't it occur? And it had not occurred. It only occurred with the cost. So we added some little evidence that probably the change was due to cost. So what is the problem of with without, the counterfactual issue? The problem is, why did the enrollees decide to enroll? Yeah? I gave you the example of the child case detection TB project, where the districts which were included are the ones which were poorly performing. So now you are going to compare them with the other ones. So you have started now to compare oranges with apples. And you will come up with the wrong conclusion. As I told you, you can randomize, if you can. You can do cohorts. You can do serial cross-sectional designs. These serial cross-sectional studies are actually very good. And I would recommend to most programmers. Introduce one cross-sectional as a baseline, in the middle, and at the end. So you have 3 data points. Yeah? So it is easier to incorporate. Okay. This one you will not see. Are you able to see from where you are? Okay. We can leave it. Here, the point I wanted to bring in is that if you say before and after, they are variants of before and after. Yeah? If you are going to use cohorts, there are variants of cohorts. If we are going to use control, there are variants of cohorts, of controls. And then you can go through them. Sorry, the color changed. Now, this is the overall framework of any impact evaluation. As I told you, it is very, very important that you understand the program attributes. Have meetings with the people who designed the program. Talk with them. Yeah? Look into the designs which I have shown you. So you have a range of things you can choose from. What are you going to use? They have told you evaluate if cost works. Are you going to use a cohort? Are you going to use before and after? Are you going to randomize? Are you going to do serial cross-section surveys? But central to any evaluation is sitting down with the programmers and deciding what are the evaluation questions. Yeah? Many times, I have done like 5 impact evaluations. They tell me the question to go and evaluate, and I don't sleep the whole night. Because the question is not what? Is not answerable. You get it? So I'm going to show you, I hope the table will be easy. Oh, this one is even worse. But you will get it. So these are the different questions which we ask about programs. The first one is, to what extent can a specific impact be attributed to an intervention? Has the intervention made a difference? Has the intervention made the difference in the environment that is independent of the intervention? Yeah? Yeah? So, these questions are at the back. But let me tell you what the programmers will ask you. For example, I don't want to ask the boss. The question they usually ask me about who has designed an intervention here. Program intervention. The question they will ask you, tell us, is this working? Yeah? But that question, is this working, is hiding many other questions inside. Because actually, what they are telling you is that they actually want to know if there was value for money. They actually want to know if there was change in the outcome by asking you, does it work? Okay. Now, as I said from the beginning, usually each program has an M&E plan. But what is implemented is only the M. The E is ignored. So this morning I want to tell you some attributes of M&E and some attributes of impact evaluation. The first one is, when you look at monitoring, is the program being implemented as efficiently as planned? Is the program targeting the right population? Are the outcomes moving in the right direction? Are we finding more TB? Are we curing more TB? Yeah? When you come to the impact, you ask yourself, what was the effect of the program on the outcome? Yeah? How do outcomes change under alternative designs? That's the counterfactual. Does the program impact people differently? For example, children, women, and men. Is the program cost effective? So these are the attributes. Now, how do you differentiate if a program is concentrating on the M and ignoring the E? So monitoring versus impact evaluation. The first one is frequency. Monitoring is ongoing, all the time, continuous. Impact evaluation is periodic. Yeah? At the beginning, in the middle, when you want to change the program, when you want to continue the program or discontinue it. Coverage. All aspects of the project are covered, but in impact evaluation, you concentrate on certain aspects. The data is universal. The data in impact evaluation is a sample. We don't need everything. What we need is to check to the extent that we can tell you beyond doubt that your program is working. The depth of information, impact evaluation is deep, as you've seen. The problem, which I told you at the beginning, impact evaluations are expensive. But this morning we will discuss together how can we make it cheaper such that it can be implemented. And impact evaluations is used to make major decisions about programs, either discontinuing them, scaling them up, even discontinuing them completely. Okay? Now, there are also two other things which are related, which confuse people. Health impact assessment. Yeah? Health impact assessment is different from impact evaluation. Yeah? And you know also sometimes we have also mixed up this word. For example, the project for evaluating case-finding interventions, we called it an assessment. Yeah? I think there is a few others we have called assessment. So health impact assessment is defined as the process of identifying the future consequences of a current or proposed action. So you can see it is so different from impact evaluation. It is like environmental impact evaluation. So you are saying if we implemented CAST now, what would happen? So you ask yourself that question before you implement. You get the difference. Evaluation comes after you have what? Implemented. Assessment comes before you have implemented. WHO actually has a huge document on health impact assessment. What would be the impact on people's health if that thing happened? But it has not yet what? Happened. So there are those terminologies. The next one is research. Is impact evaluation research? If you ask yourself. The quick answer impact evaluation is not research, but it is closely related to research. Because the language we have been using, find the cause without any other contribution. The methods, the RCTs, the design. So it looks like it is research. Yeah? Actually, when I proposed this talk, the initial title, I think, the people who are capturing, they had actually called it research. It is not research, but it is related to research. What makes it not research? These are a few reasons. One, impact evaluation is aimed at improving the program, the decision-making process. It is not aimed at generating knowledge to keep. Yeah? Impact evaluation is done by programmers, not researchers. Impact evaluation is what people these days have tried to call implementation science, operations research. Yeah? So, although the methods are from research, it is not actually research. And it is when we make people understand that we will now be able to incorporate impact evaluation in all the interventions that we plan. Okay. So that is impact evaluation. Over 30 minutes of talk, about 30 minutes of impact evaluation. So we are going to take a break and recap. The key message you should take away this morning, one, there is not a lot of money to implement everything. Decision makers have to make a choice. So we need to give them data to make a choice. Okay? Two, there are so many innovations. In the olden days, TB programming was the same. The dot strategy, finished. If you have the dot strategy, you are done. Everyone knew what we are doing. Today, everyone is coming up with a new way of doing something. So if we don't have the system to evaluate, then you can waste resources on interventions which do not work. Impact evaluation requires that you go through a process of associating the outcome to the intervention. That is key. So we use such methods to be able to discern what would have happened if our intervention was not there. Okay? Impact evaluation is related to monitoring and evaluation. That's another key point. But most people ignore evaluation and concentrate on the monitoring. Where is monitoring? Just counting your blessings. We found 4 cases. We found 5 cases. But we could actually have found 5. Or even if you didn't go, maybe the cases would have been what? Found. Yeah? Impact evaluation is not research. Okay? So like I told you, I have been, either by choice or not, I have been doing a couple of evaluations for TB. Actually, I also did one baseline assessment one time. Yeah? But that one, I didn't do it myself. I saw my senior, Dr. Katamba, is here. The union gave him some work to do a baseline assessment for Kampala. They were going to work in slums. Then he gave it to me. We did the baseline assessment and gave them the report. And that project actually succeeded. It succeeded because they had the baseline assessment. The other 3, which I've done that I'm going to use today, this morning, about 10 years ago, were invited to do an evaluation of the track TB project. But you can see we called it an assessment that time, terminology. But we did an evaluation. The second evaluation we have done a couple of others, is coffee project. This is an intervention in Bukoma and Simbi. For them, track TB was end of project evaluation. Coffee was mid-term. And then currently, we are doing an evaluation of the different case-finding interventions that the program has implemented. And that's what we are calling the CFIRE. So, my plan, if you agree, is that we form 3 groups, but the biggest problem, most people are online. Yeah, most people are online. So, but the ones who are here, let's see if we can do this. I have my co-facilitators. I think it is the next. So the first one is the track TB assessment. This is a summary. I'm not going to show you the results because I've not been allowed by the owners of this project to show you the findings. So track TB assessment, which we did in 2016. So the purpose of this assessment, if you can read, you remember the key thing in evaluation questions. What question are you asking? What is the hypothesis? I didn't want to mention that because it would again sound like research. But actually you are hypothesizing that track TB has caused something. So you want to find out. So the purpose was to find which approaches have been more effective in contributing to the achievements of the project. That was the first question. The second is, what new priorities and strategies are there for sustaining and addressing TB? Remember I told you the reason why you should evaluate? So these guys wanted to know which approaches worked. I don't know why they wanted it, but I think he wanted to put them in defeat TB, maybe. Because later there was defeat TB. I don't know whether an evaluation was done for defeat TB. But I think that was the reason. The next one, what new priorities? So they wanted to find what can be added. And then the third is, how has track TB worked collaboratively and in partnership with the government? So they wanted. And these are the questions. That was track TB, almost 10 years ago. So these are the approaches that we came up with. Yeah. One, you can see there, secondary data analysis, document review, key informant interviews, triangulation, qualitative and quantitative. Yeah? And then you can see this graph here. Do you see the graph? The intention is not for you to see it. The intention is we selected facilities which we are going to use to generate the counterfactual. Yeah? To compare with the track TB facilities or areas. And we went and analyzed the data, program data, and were able to find facilities which we can compare to the track TB facilities, such that we can be able to show that track TB has caused this. For some of you who are there, we presented this report, I think at Protea, but today I didn't want to interfere with the results because I didn't have time to get permission. And also did the interviews. We listened to the people. So this is coffee. Coffee, these are the objectives, the bit wordy. But as I told you, this was a mid-term evaluation as opposed to the other one, which was end of project evaluation. So the objective was to analyze the matching rate of testing results between NTRL and those ones of the institute, to analyze the change in the TB. Let's concentrate on this. Change in TB case detection rate in that district where they implemented. And they had secondary objectives. Now, selection. Again, I put that small graph there, not for you to read it, but to show you how we found the counterfactual for coffee. How did we get a control? To be sure that the results we are seeing in Bukoma and Simbi are actually due to coffee. Okay? So this is the CFIRE. CFIRE is still going on. This is the assessment of the impact of strategic initiatives for finding missing people with the TB in Uganda. Again, you see here, we are using the word assessment instead of evaluation. But these are some of the questions that the program gave us. To what extent have the elements of the various case-finding intervention been implemented? You will tell me in the group work if that is an evaluation question. What are the effects of implementing these interventions on TB case deflection? What are the best practices? What are the views for improving these interventions? And what are the costs? And what is the cost effectiveness? 6 questions which we have to find out in CFIRE. Number 2, I think, and number 1 are complete. We are now analyzing the qualitative data. Okay? I will leave this. I will also leave that, so we start the group work. I don't know who the chair is. I don't know how much time we have, but I had planned that we are going to put our hands onto this. We have group 1, which will look at track TB, facilitated by Mudashir. Group 2, which will be facilitated by Winters. I don't know whether Winters is here. Yeah, he's here. Looking at coffee. And group 3, which will look at fire, facilitated by Jasper. Because this is a capacity building thing, I don't want to stop on the lecture. So the questions we are going to ask ourselves in these groups, were these impact evaluations justified? You write down. 2, were the designs and the evaluation questions appropriate according to what I have told? I haven't taught you. To what have I done? To what I have discussed with you. Then number 3, were the methods appropriate? So maybe the moderator will be going to these slides, going through them up and down, if you want to remind yourself. So Jasper, Mudashiru, and Winters, please. The reason these ones are chosen is because they have participated with me in the evaluation. Yeah? So they have an idea of the jargons that goes behind before we give you that magic figure of whether it is working or not. So you stand up and people join you. Simon, how much time do we have? So in 10 minutes from now, if you want to look at fire, which is the hottest, it has cast, you go to Jasper. If you want to look at coffee, which was a one district project, you go to Winters. If you want to look at track TB, which was a huge project, you go to Mudashir, and the questions are there. Thank you. And while you discuss the rapporteurs, probably not these ones, another person in your group should write down. You will come and tell us your take on these evaluations.
Thank you very much, Professor Chirenga. Another round of applause for Prof. Okay, let's quickly transition into our groups. Jasper, how do you want? Maybe you can work with the group tables close to you. So again, the spirit of this was to, tweak our minds into some sort of research mindset as we go about our programming. So that's why we thought this session would be very important as part of this summit. Can I leave you to mobilize your team members? You can come and join the table here. 3. I know there's Jasper, there's Mudashiru, and Mutamba. Jasper, you can sit here. Sorry, can we kind of move a little fast? We already lost some minutes. Wanji? There is a group around Mudashiru, and then a group around Winters. So maybe the co-facilitators, I'll leave you to mobilize your group members. Alex, come and join here. Alex, so that when we are doing our programming, we think about the questions and designs properly. Yeah. Yes, I see Mudashir is already started. Just so you can get started here. Winters. Yeah, you can mobilize the team close to you there. Rose, can you move and join Winters? So this session is designed to last about 10 minutes. I'll try and manage your time. Winters, I think it is your group that is not yet formed. You can join the team at the back, maybe. Hmm? On the southeast. Is it northeast?
Tuberculosis is a threat that continues to affect an estimated 10.6 million people around the world. TB takes a huge toll not only on the health of individuals, but on families, economies, and societies. Joint action between affected communities and the health system are critical to bringing this ancient killer under control.
To end TB, meaningful community engagement is necessary to acknowledge the strength and the aspirations of the communities affected and infected with TB, and even TB survivors.
Harnessing the experience, skills, and insights of affected communities allows for better tailoring of programs and interventions, making them more community-centered and context-specific.
The most crucial step in an effective TB response is identifying
Samson, please come to the podium. Mudashiru, kindly break up your group and convene. We want to catch up on the rest of the items in the program.
Translated material that can give us guide the evidences that is actually lifted if not like TV3.
The number of clients you identify and you start them on treatment before you realize the next time you are going to check on them, then you work.
So we still have that challenge of this for leprosy.
We have a very good result. Could it be extensive?
We are strengthening community disease surveillance on all the borders.
Tuberculosis is a threat that continues to affect an estimated 10.6 million people around the world. TB takes a huge toll not only on the health of individuals, but on families, economies, and societies. Joint action between affected communities and the health system are critical to bringing this ancient killer under control.
To end TB, meaningful community engagement is necessary to acknowledge the strength and the aspirations of the communities affected and infected with TB, and even TB survivors.
Harnessing the experience, skills, and insights of affected communities allows for better tailoring of programs and interventions, making them more community-centered and context-specific.
The most crucial step in an effective TB response is identifying who the community is, because they have the highest risk and are most vulnerable to TB, and because their voices and contributions can help capture the pandemic.
So, members, I think we need to listen to the group that did the CFIA study. Is it okay, Professor? We go ahead. There was a group which was actually seated here, led by Dr. Jasper Nidoi, and we were privileged to have the commissioner, the assistant commissioner in our team, who were discussing about was the impact evaluation justified for the CFIA, that is the case finding initiatives. That is basically the focus was on the CAST intervention. The first question is, was it justified? The general statement and agreement by the team members was yes, because it was a new innovation which had been done for 2 cycles, that was March and September 2023, and therefore the evaluation was to inform the program on what to do next in terms of what to adopt and what to drop. So it was due for that. The next question was, were the design objectives or questions appropriate as how they were laid in the protocol? Still the answer was yes, because the objectives were looking at how many cases were we able to find, how were we able to build the system, and were we able to justify the expenses that related to the cost in terms of the input? Yes. The cases were found in the 2 cycles. We were able to find more than 100, actually over 14,000 TB cases, which relates to the element of case finding. In terms of system finding or strengthening, we're able to work with the VHTs, the health workers, the district, the regional, the national, and the implementing partners to see that we actually all move at the same pace. You would actually appreciate that within the 2 cycles, we're able to realize that the implementing partners were able to put in finances to support the implementation of the CAST Plus. which was a component of coordination, collaboration, and multi-sector accountability for the services that we are supposed to deliver to the communities. Then the last question was all about were the methods appropriate in terms of the design to do the study. Still the answer was yes, because there were a lot of desk reviews, there were a lot of literature review, looking at the reports that were produced by the program, and looking at the before and after effects, and during the implementation of the CAS Plus, they were able to triangulate and make a justification that if CAST wasn't there, the 14,000 cases that we were able to find could not be found at that time. And therefore, they would remain in the community, they continue to transmit the disease, and we get more problems as far as TB is concerned. So basically, that's what I would summarize. And I had members in the team. If any is willing to supplement, is welcome. The team members, any. If not, I think that is it for the group which looked at CAST and Sphere. Thank you. So the next group, who is ready? Group 2? Are you group 2? Yes.
Good morning, everybody. Samson Omongot are my names, and I was with the group 2. So ours was really case detection at the Mukoman Simbi. I find it pronouncing it a bit, I don't know whether technical or, yeah. So I think the first one was the impact evaluation justifiable. Yeah, for us when we looked at the evaluation, we said, I think it was justifiable. Yeah, because first of all, the evaluation was done mid-term, which of course is quite good, because then you don't need to wait, for the project to end and then you evaluate. Why? Because at times it will guide you even in finding out issues that could be sorted out before you can what? Before you can run the project. Because at the end of the day, you really want a good outcome. And so we say it was justified. Then the objectives. Yeah, so the objectives were quite right, because it was really analyzing whether the project is appropriate. And so when you look at the objectives, the objective was really to analyze, finding out whether it was appropriate, and then whether the objectives that were set actually were answering the question that was in place. And we saw the objectives were really right and quite appropriate. Now, the third one was, were the methods appropriate? Yes, we also say the methods were appropriate. Why? They did a mixed method. Actually, they did a mixed method where they had the qualitative and then the quantitative. So the quantitative was really basically to try to have seeing whether the cases were detected, issues to deal with the numbers, but also seeing whether things, was it feasible, was it appropriate, was it, so quantitative. Then, of course, the qualitative part was really trying also to get an in-depth understanding. Just like I said, it was done mid-term. In-depth understanding of what were the factors probably that could have been maybe causing challenges, and then probably how we could address these factors such that the project runs and we come with a better outcome, seeing that cases are detected and that the right numbers are recorded and everything is done well. Thank you.
Good morning to you all. I'll give our remarks on track TB. The first question was the impact evaluation justified? Refer to when to evaluate slide. So from our findings, we realized that yes, the impact evaluation was justified. And then for question 2, that was talking about whether the design objectives were appropriate. Here we had an issue. Track TB missed out on the key indicators that would then be referred to, in continuing with the objectives. So in this case, we are like, no. Then for question 3, that asks about the methods. The methods were okay, except we realized that they did not include the real beneficiaries, who are the people who actually were living with TB. And so in that case, we really realized a bias. But also, when it came to the cohorts, by then in 2016, we don't have data on how many of those sites, the dot sites were, but it could have given us perhaps an understanding of whether they were really representative of the whole number of sites available at that time. But then also the fact that the staff, excuse me? Yes, so also the choice of sampling itself alone creates bias. And so we do not know how they did counter for that. Thank you.
Thank you very much. The groups, please clap for yourselves. I hope that this has given you a little bit of a peep into what goes on in evaluation. Yeah? These reports are available. You can get them and read more about the methods. It's an area that as young people can give you what to do. Yeah? If you develop these skills. But the thing you should take in the mind, the horizon is, did a change occur? Yeah? Did the project lead to a change? Of course, I didn't show you the results. Is that change due to that project? Those are the two words. Whenever they call you to evaluate a project, one, you have to come up with the design and the methods to detect that there is a change, but also confirm to the programmers that that change is from that what? Intervention. It is a lot of work and discussions that go on. You've seen in most of them actually, we even went ahead and included interviews, focus group discussions. For Sifaya, we have just finished the interviews, focus group discussions. A few in the north, in the south, all that design is in those proposals, such that we can attribute that change to the intervention. Now, as I promised, over 10 years, I've been working on these impact evaluations, and I have some ideas and thoughts on how they can be made simple such that people do not fear that they are going to waste money on evaluation instead of getting outputs. The first one is that you must determine early in your project that you will need evaluation. When you call us Say, get a few professors, let them tell us. Sometimes the data we need is not there. Yeah? And then we used to call it Kosa coughing. Putting here, putting here, putting here. Yeah? Number 2, during any evaluation, make sure that you have engaged the stakeholders, the people who made the program and the beneficiaries. I think group 3 picked this. Although from the little data we gave you, you cannot see that we talk to patients. Actually, during interactive assessment, we actually talk to patients. But the information I gave you was not what? Enough. Can you bring back the slide? Be flexible with your methodology. I didn't want to bother you so much to go into the details with the methodology. They can actually be very complicated. So when you start your evaluation, be flexible. Don't say, for us, we came to do before and after. Then you land on a control and you ignore it. Yeah? You be flexible. Projects should include, at the minimum, a baseline assessment, such that you know where you have started from. Now, again, the problem is cost. And this is my recommendation in the next bullet. Program staff, all of them, should have some knowledge of evaluation, such that you don't get a separate group from outside. Of course, there I'm throwing myself out of job, so you won't call me. But I can come and help a bit when people already have an idea. Program staff should have knowledge of evaluation. They should not stop on the M. That M and E includes the evaluation. And I have told you what evaluation is today. Evaluation is saying there is a change, and the change is due to what I did. It's not a matter of filling Excel sheets with numbers. So let's also make sure that the E in the M and E is recognized. Yeah? Embrace technology. With the technology, it is now very easy to do evaluation. For example, you will see when the cast paper comes out, that 10-year data, the 10-year analysis we did, imagine if there was no DHIS and we are going to the district to pick this data. We would not have done it. Yeah? So with the technology and AI, it should be able and cheaper to do evaluations. My other recommendation, let's have phased implementation of complex programs. For example, CAST started small. You know, the first CAST, March 2022. That CAST allowed us to have a counterfactual. Actually, if you want to believe the data, don't believe the September 2022. Because there you went everywhere. The counterfactual is we are cooking it, not cooking. We are looking for it. But in March 2022, we had the counterfactual. Phased implementation. Now, if you have your program staff, everyone, we have started the project, yeah? And has started, everyone has been sensitized on evaluation, and you phase on a smaller scale before you scale up. Probably that could help to reduce the costs. So those are the thoughts I have, but I know most senior people here, you have ideas. We have to find out how to make evaluations cheaper and useful to programming, such that we justify the resources that are used for evaluations. I know you have already clapped for me, so please don't clap again, but I've finished my session.
I think it doesn't hurt to really thank Professor Chiraenga with another big hand clap. Yes, you've done us very well, Professor, and I hope you've sort of laid the seed for all of us in-house and online to integrate evaluations in our programming. I now have the privilege to invite Professor Jorova to also present to us. all of us here are his former students, here and online. So what you see, Professor, here is your product in one way or another. And you speak from here. As Prof goes to the podium, I think he's well known to us, but some of his credentials include being the chief scientist of the Supra National Reference Laboratory, which is hosted here in Uganda, and is responsible for over quality diagnostics for TB across 20 countries in Africa. As I said, many of us in-house and online are his students. Some of us benefited from his research activities. And he has also been the former dean of the biomedical school at Makerere. Is the slide coming? Okay. Prof, okay, great. You're welcome to speak to us this morning. Thank you.
Thank you very much for those kind introduction. I'm really very thank you, former Professor Bruce and all the organizers for this invitation. It's always worth a while when we sit here to see how we advance TB, and I hope I can move the slides. My task today is not very complicated. I'm talking about SMART for TB. Will you move my slides? This gadget. I may need some relation. Oh, okay. This. Thank you very much. So, SMART for TB, this is what it stands for. Supporting, mobilizing, and accelerating research for TB elimination. I think I usually take a vote to see whether there are people who believe in that we can eliminate TB. But today I will not do that. I think they know my side. Now they may want to appease me. So I think, but this is a big USAID support, and it is towards actually eliminating TB, and it is, as I said, supporting, mobilizing, and accelerating research, TB elimination. It's a corporate agreement and an extraordinary investment to accelerate progress towards achieving NTB. It is the biggest investment towards research in this direction. It's about $200 million actually, and it was competed. It's actually research. There are very many groups which competed for it, and we're among the group which won. I think we are very happy that we won this grant, and it's a consortium of leading researchers, educators, policy experts, and public health advocates from across the globe, as I will try to show you. And it's over 5 years to meet challenges for ending TB. I do believe everybody here knows some 3 figures. They introduced me badly. They said I'm a professor, and that is a problem actually for you, because I may ask questions for you to answer. There are 3 figures I always want TB people to remember, not me but the NTB: a 95, a 90, and a 0. And I think you are scratching your head what the 95 means, 90, and a 0. But today I'm not going to make your life very complicated. Those are the NTB targets for elimination. 95% reduction in mortality using a 2015 baseline. 95. Please remember that by the year 2035. Then 90% reduction in incidence, again for the baseline of 2015. And a 0 catastrophic cost. 0 catastrophic cost. I'm not going to define them again, but please remember, there are other milestones in the middle. I will forget you those ones. But at least remember 95, 90, and 0. For all of us, we work towards that, and this support is working towards that to eliminate TB. And so we already have, we are in the second year, and year 1 and year 2 had $25 million funding dollars, and as we also funds come for the missions. Okay. It is a tripartite mission looking at research, capacity strengthening, policy, and community engagement. These are the 3 broad areas which this research covers. Research, meaning looking for new knowledge, but also capacity strengthening for people to do research, but there is also end up into policies and community engagement. Those are the 3 main areas. So these are the part of the consortium. You have John Hopkins, who was the lead, and then UCSF, University of San Francisco, KNCV, there is EGPAF, TAG. I cannot, these are many. I have no time to explain each and everything, but I think these are common organizations. But there is also regional centers, collaborative centers, where you have Uganda, where we have Walin, and you have others in Europe, South Africa, India, and Vietnam as the leads here. So these are the overall consortium. And so far, each country, the mission, USAID mission, provides concurrence, and that means that they are willing to support activities of SMART for TB and help. I'm really very glad that the Uganda mission already has provided concurrence together with the other mission. So, colleagues, we are in business. So we'll be to let you know what will come along. So, and we have different technical areas, 7 of them, which you should really find yourself where you belong. We have already tried to map out teams in these areas. I don't know why. Okay. They are really simplified for you here. I can't see here, but I can't. Oh, it has come. So area number 1 is diagnostics. It's not me who influenced that because I belong to diagnostics, but I think it's because it's very important. And if you remember NTB strategy, pillar 1A is diagnostics. You need to be in for you to be treated. Technical area number 2 is therapeutics, that's treatment. Technical area number 3 is operational research, and 4, interrupting transmission, 5, vaccine preparedness, 6, capacity strengthening, which involves human resource, infrastructure and sites, and then technical area number 7 is policy translation. Whatever we get, we need to translate it into working policies. So these are the 7 areas we are working along in the SMART for TB. So I think if things will be coming along these areas, and will be prepared to get involved. I think in the interest of time, I will not do much, but already in diagnostics, already things are happening, and we are looking to leverage high quality TB diagnostic research sites, which are already existing, because there is no time we want to accelerate. If there are already sites which are already involved, we want to have things go to the pipeline of WHO for review of promising novel tests. So we will be, already there is 2 studies which are ongoing, ADAPT for adults and ADAPT for children. We're looking at non-sputum based diagnostics. For example, Tanga swabs and others. And these are already moving on. And so, okay. And I'm happy that we will be involved in one of these in Uganda. So that I think I will move on. So that one, the ADAPT for children is already ongoing in Mozambique, looking at 200 participants, and so we'll see the outcome. In terms of therapeutics, there are many activities, there are many studies which are going on. For example, PRISM. I will not go in details. I think maybe we'll share these slides, but it's just making you aware that there are a lot of things going on. PRISM is about drug-resistant TB. There's PRISM for adults and PRISM for children. That's about drug-resistant TB. Then SMILE TB is treatment shortening, and for drug-sensitive TB in children. And as you will see, with the 2-month regimen, and Uganda is actually involved in this, as we'll briefly tell you. And then there is a BREACH, a randomized control phase 3 clinical trial evaluating bedaquiline for prevention of TB disease. And so there are many of these which we are looking at already in the pipeline. So SMILE for TB, where Uganda is involved, if a 2-month regimen in children with presumed drug-sensitive TB is non-inferior to a 4 to 8 month. And I think, again, in the interest of time, you'll be aware, just in terms of awareness, that this is really going on. And this is an open-label randomized control treatment shortening non-inferiority trial, and those are the drugs involved. I'm sorry, there's no time to go into details, but I'm encouraging you to really follow up, and we will be having further discussion on that. So these are the countries involved, and as you can see, Uganda is part of that with MUJU here, Makerere University, John Hopkins research collaborations, partners, NTLP, and others as we get along. And the first site here was in Mozambique, in South Africa, and Zambia, in terms of visits. And in Uganda, we hopefully the USAID will be visiting us late this year. And so that's already going on. In terms of vaccine preparedness, you already know that actually in TB we are working towards also getting a vaccine, but vaccines have faced challenges. It doesn't mean that when you have a vaccine, it will be really absorbed. Experiences we have from COVID and HPV and other vaccines have shown us that we need to do some groundwork. So for the TB people, we are not going to wait. There is already a group working on how we can make our people prepare for these vaccines. This is what this group is doing. And capacity strengthening, early stage investigators, mentorship program. And if you are observant, a call has been ongoing, and I'm happy that actually many Ugandans have made applications. Personally, I've recommended some. And this is only for, it's only, I think people like you, if you graduated with a master's or a PhD in the last 10 years, it's been very flexible, giving up to 10 years. You are eligible for this, and you should be actually associated or affiliated with the National TB Program, and I think many of you are, and all working on one of these projects which I've shown, then you will be eligible. I'm glad many people applied. Unfortunately, the deadline was 14th of March, but there will be other calls. So I think be prepared when the other calls come in. It's an intense training program which has 4 phases going up to 2 years. So I think it will look at those phases, and by that you should get something and be able to have your own research. So policy translation, which is a key activities and deliverables. The SMART for TB is not like any other research where we will do things and leave them at the shelf. The importance is that we should have policy and community engagement plans and use resources towards that. So things should be translated. That's why we are working closely with the program, working closely with the communities to really absorb the findings. So there are many opportunities in which will come after year 2 and beyond, such things as operational research, and we engaged with the Uganda mission here, and we are looking forward really to see whether we get support. Actually, other missions have already given some support towards operational research and making sure that when we come to meetings like this, like what Professor Bruce was saying, that we have things which inform improvement of what we do. So, and of course, interrupting transmission is very key, is part of what we needed. Opportunities will be coming, and people who are looking at prevention be in business for this once an opportunity comes. It is a cooperative agreement. It's not really, I must tell you that this type of funding is not like the usual funding where you have calls, you apply. There are opportunities, you just keep alert. Whatever opportunities comes, you really be with it. So I really need to make sure that our Ugandan colleagues are well prepared for that. This is the collaborative agreement centers. In here you see Walim, which is led by me, and not Walim, but the Walim project, the Walim hub is led by me and Dr. Chilis Katamba in here, and we take East and West, some of West Africa, and we have a big footprint. There are others in Europe, as you can see, in Asia and South Africa. So this, our footprint actually goes to Nigeria, Ethiopia, DRC, Tanzania, Kenya, and Uganda. This is Walim, which is actually close to half the population of Africa. In case we need to, this is where we need to support. So what are we supposed to do as a regional collaborative center? Organize regional meetings with program managers, researchers, and community. Provide a platform for training opportunities such as workshops, symposia, and mentorship. This one was a very good one for us, and I think I'm glad that such will be part of our job. Coordinate capacity strengthening initiative, like that's why we are very involved in early stage investigators, and of course provide a forum for sharing best practices, and if we possible, we could actually sponsor local investigators depending on how we mobilize resources through this consortium. This is our role, and we hopefully to do that. And Uganda is very advanced. The NTLOP, as I must tell you that NTLOP has sat together with partners, and they have developed the research priorities. And already we have a concurrence with our USAID mission, and we are actually in discussion with the mission to see what areas we could support, and we are considering things like technical area number 3, operational research, things to do with Smile for TB is already going on. Early stage investigators have explained, and be opportunistic and proactive as things evolve. So I'm not going to go through this in details, but just to summarize that NTLP has priorities. One of these priorities is TB prevention, and where they are looking at, and also looking at upcoming vaccine preparations and TB diagnostics, and they are looking at making sure that they improve access to diagnosis. This document exists and has been developed by NTLP with partners. They are also looking at TB treatment, particularly drug-resistant TB, and they are looking at involving private sector, which I think the findings are that the private sector is heavily involved in treatment of TB, and as well as community engagement, and they are looking at post-TB lung disease, and I think Bruce here is very familiar with this problem in his MLI, and they're not forgetting, of course, leprosy as part of it. I'm not going to go through this, but this is really to tell you that the NTLP is ahead of the curve, has already thought through this, and they think they will leverage on Smart for TB to try and support some of these. So I would end here, and I think All I had to do is to make you aware of what Smart for TB is doing and is planning to do. Thank you very much. Simon, I think I don't have questions. Mine was an awareness.
No, you don't have questions. Thank you so much. Another round of applause as Prof takes his seat. I now quickly wish to invite Dr. Achilles Katamba to also speak to us. The program has benefited a lot from his research activity in terms of implementation research. Over to you, Dr. Achilles.
Good morning to you all. Yeah. As they put the presentation, I think there is a number of TB cases that we are always missing, and they are there in the community. So the people who come to our health facilities are less than those probably which exist. And there is always a gap there. At the same time, if you recall, a lot of resources have been put into strengthening healthcare systems through implementing partners, government, global fund. Many implementing partners have supported the strengthening. But when COVID came, despite all that, we realized that our TB notifications went down because of those restrictions, lockdowns and others. Meaning that probably if we continue to focus the way we do business, that people have to come to the healthcare facilities, probably if we are attacked again, we need to rethink the business, and that's the whole issue about reimagining TB care. And by reimagining, we need to put in the aspirations, the needs, the wants of those we serve. Should people always come back to pick TB medication for continuation, or they can get it nearer their services? So, and I think this is where the concept of reimagining TB care came in, and I think we are going to continue to look at that. So I will quickly present this reimagining TB care, which we are doing jointly with the National TB Program, and this is work that is supported by CDC and COICA through Stop TB Partnership and United Nations UNOPS. So, really, the vision and objective is to transform when, where, and how TB services are accessed along the cascade of TB care. Which components of within the cascade of TB care can we really decentralize and even integrate so that services are delivered at the convenience and aspirations of the people? And this is the work that we have been doing and we are continuing to do. So we did do some people-centered design, really human-centered design. As you all know, the first pillar of the NDTB strategy is integrated patient-centered TB care and prevention. And this is really putting the people at the center in terms of human rights and others, to make sure that whatever we do, and this people-centeredness is really a way. We had to consult people in the different communities and get their views. And based on those views, then we went forward to come up with what do they want, what are their needs. And that gave us sort of opportunities on what we need to focus on in terms of that. So this work was done in a small area, in a few districts, and the participants who participated in those consultations were NTL to understand their hopes, dreams, and needs, and the wants of TB-affected people and stakeholders. And there were a number of analyses we did during that time. And we came up with 15 different opportunity areas. And we had a number of meetings to make sure that we consult people more. After analyzing that data, we invited the same different groups of people, and we looked at what are these needs, what are the opportunity areas. And we came up with 4 opportunity areas. Awareness is a very big gap. There is a need to increase awareness into the community. There is a need to integrate care as our NDTB strategy. Why do you go there to screen for TB and don't screen for malaria and don't screen for other? Which a concept that the program has taken up already with the CAST, trying to integrate CAST Plus. Why do you go there to do immunization and others? This would reduce the stigma due to TB if we integrate this and look at it as healthcare screening. There is the issue of decentralization. People here want services to be brought nearer to them and also improve the diagnosis for TB. Those were the 4 opportunity areas which we faced. And we worked with a company to identify the different innovations which can address awareness. If you look at how many ways to address an awareness that are being used locally and in other countries with similar settings, there are very many. But we had still to sit down and say which are those that are appropriate for our setting in this country. And we sit down still in workshops, in meetings with different, to identify which of those may be appropriate given the resources and other things. And then we moved forward to discuss those and came up with some concepts. And the concepts really were 3, which we are putting into one. We need to make sure that TB-affected people really address their needs. We need to look at the community health workers themselves. And we need to look at the communication between those and others. And so all of these have been designed into one concept which we are working on right now. And we are still having a series of meetings to make sure that we come up with that one concept, which is more going to be making an electronic application that can be used by the VHT to do screening at the community level for the different diseases. And also for some of them, where diagnostics allow, do some initial diagnosis or screening, like for HIV, malaria, they are rapid tests. For TB, unfortunately, we don't have such a test. The nearest test is the CRP, which probably seems still to be a bit far to be used as a screening test in the community. And so we are still going to use our intensified case finding form and use the action points so that to guide what action will be taken. And this is work that we are working on to make sure that it's linked to our DHIS system. So we are working with HISP, we are working with Electronic Community Health Information System and the Health Information Division of the Ministry to make sure that we come up with a solution. And we have a meeting this SARS people to have input into that application that we shall test out and see what happens. So we need your support all as we come out and when we invite you to get. So the implications from the scalability and that. So We are still in that phase of where even are we going to implement this. We are working, as you see. This is a joint activity with the national program. So we need to identify which districts, which settings we are going to do so that we can design a study which can be able to answer a number of questions and also guide the way we do business. So I will stop there and thank you very much. We need to acknowledge, as I said earlier in the beginning, this work has been funded by CDC, COICA through the United Nations UNOPS and supported by Stop TB Partnership.
We will now take a break for about 15 to 20 minutes, a tea break, and then we will come back and start the second half of the first session. So break is being served right outside the room, and it's ready. We are ready for you, so please step out and have a cup of tea. Hello?
Out of this TB cast program.
I'm wondering whether they have translated material that can give us valuable evidences that is actually live TB, not live TB.
The number of clients we identify are reduced. They need to start them on treatment before you realize the next time you're going to check on them, it's a new way.
So we still have that challenge of this people take this.
If you have very good results, could it be expensive?
We are strengthening community disease surveillance on other borders. We are not only targeting TB.
Tuberculosis is a threat that continues to affect an estimated 10.6 million people around the world. TB takes a huge toll not only on the health of individuals, but on families, economies, and societies. Joint action between affected communities and the health system are critical to bringing this ancient killer under control.
To end TB, meaningful community engagement is necessary to acknowledge the strength and the aspirations of the communities affected and infected with TB, and even TB survivors.
Harnessing the experience, skills, and insights of affected communities allows for better tailoring of programs and interventions, making them more community-centered and context-specific.
The most crucial step in an effective TB response is identifying who the community is, because they have the highest risk and are most vulnerable to TB and because their voices and contributions can help combat the pandemic.
Meaningful engagement means that community members are valuable partners in the TB response. Decision making must include
is co-created with representatives of civil society, communities affected by TB, national TB programs, and other partners. It is a major tool that ministries of health, their national TB programs, NGOs, and other community groups can consult to harness the power of local communities to prevent, treat, and end tuberculosis wherever they are. Yes, we can end TB together.
I think we are not tapping enough out of this TB program.
I'm wondering whether we have translated material that can give us valuable evidences that is actually lead TB free, not life TB free.
the number of clients we identify and we start them with
nakora okay ne Noah mwali mu Rwanda ngata kwata simu Professor Noah okay, it's okay. So this is it. Hey, those things moving actual cash from what? Hey.
I think we are not tapping enough. Some member of the community who bring lived experience and reality to the table.
Meaningful engagement requires intentional, deliberate actions. It must be costed and be included from planning throughout the national TB program cycle, including monitoring and evaluation. Creating or maintaining strong platforms and networks and coordination will be key.
The guidance is co-created with representatives of civil society, communities affected by TB, national TB programs, and other partners. It is a major tool that ministries of health, their national TB programs, NGOs, and other community groups can consult to harness the power of local communities to prevent, treat, and end tuberculosis wherever they are. Yes, we can end TB together.
I think we are not tapping enough out of this TB program.
I'm wondering whether they have translated material that can give us guide the audiences that is actually live TB free, not live TB free.
The number of clients we identify are reduced. There is no you start them on treatment before you realize the next time you are going to check on them, and nowhere to see.
So we still have that challenge.
Chimanyere eronti. Whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health. Chimanyere eronti. Whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health.
I think we are not tapping enough out of this TB program.
I'm wondering whether they have translated material that can give us guide the audiences that is actually live TB free, not live TB free.
The number of clients we identify are reduced. There is no you start them on treatment before you realize the next time you are going to check on them, and nowhere to see.
So we still have that challenge of these people take this.
Okay, having very good results. Could it be extensive?
We are strengthening community disease surveillance on all the borders. We are not only targeting TB and leprosy, but we are all identifying diseases.
Tuberculosis is a threat that continues to affect an estimated 10.6 million people around the world. TB takes a huge toll not only on the health of individuals, but on families, economies, and societies. Joint action between affected communities and the health system are critical to bringing this ancient killer under control.
To end TB, meaningful community engagement is necessary to acknowledge the strength and the aspirations of the communities affected and infected with TB, and even TB survivors.
Harnessing the experience, skills, and insights of affected communities allows for better tailoring of programs and interventions, making them more community-centered and context-specific.
The most crucial step in an effective TB response is identifying your urban communities, because they have the highest risk and are most vulnerable to TB, and because their voices and contributions can help combat the pandemic.
Meaningful engagement means that community members are valuable partners in the TB response. Decision making must include an informed member of the community who bring lived experience and reality to the table.
Meaningful engagement requires intentional, deliberate actions. It must be costed and be included from planning throughout the national TB program cycle, including monitoring and evaluation. Creating or maintaining strong platforms and networks and coordination will be key.
The guidance is co-created with representatives of civil society, communities affected by TB, national TB programs, and other partners. It is a major tool that ministries of health, their national TB programs, NGOs, and other community groups can consult to harness the power of local communities to prevent, treat, and end tuberculosis wherever they are. Yes, we can end TB together.
Shimanere-ronti. Whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have.
Yes,
For
Stella,
example,
can you help
cough,
me to
flu,
mobilize
and tuberculosis. This message
delegates
is brought
that
to
are
you by
still
the
outside
Ministry
of the
Health.
room? Yes. We are going to transition to the officiation session. Yeah, I'll hand over to you.
Tuingire. Someone is coming, by the way, to give you my specs, and to take my.
microphones for the members who are coming. Hello, everyone. We are reconvening after the tea break. If you're still outside, please let's conclude so we can come back in. Good morning. We are reconvening after the tea break. Please come back in so we can continue with the day's proceedings.
Yes, also want to continue thanking participants online. Thank you for participating in the event. We are transitioning to the officiation session, which is going to be facilitated by the Assistant Commissioner for the program. I don't know where our SC is. Sorry.
Hello. There's a phone that was left at the tea station. If it belongs to you, please come for it.
Okay, so let's wait for our dignitaries to settle in. So the dignitary profile includes the academia, USAID, WHO, and Ministry of Health. I'm happy to inform you they are all present in-house. Professor Chitara, I think I saw you somewhere. Oh, yeah, there you are. Yes, you are part of the team that will be invited to the podium. We are still trying to mobilize the rest of the officials to come into the house. So IT, you could do some videos to as we wait for the, yes, I can see some are walking in.
Whenever you cough in a public place, you have to cover your mouth with a handkerchief
opening session,
and open the window if you
we shall then dive into
you.
the core business of the summit, which is the science. And for today we have 4 science sessions. I think the list is actually mouth-watering. I'm eagerly waiting to hear the papers that will be presented. Okay. So the co-chairs for the sessions, I hope you are in touch with your delegates? Okay. Right, I think we are set for the next segment. I now wish to hand over the mic to the Commissioner, who will in turn invite the dignitaries to the podium. Thank you.
Thank you, moderator. Good morning to you all. Yes, Dr. Turia Westavia are my names, and I'll be taking you through the next session, which is about the official opening of our summit today. Amidst us, we have our chief guest for the day and key dignitaries that will be joining him to officiate at this summit. To the podium or to the high table, I'd like to invite the chair of organizing committee to sit at the high table, chair organizing committee for the summit. I want to invite the representative of the academia, Yes, Professor Dr. Paul Chitara, you're welcome to the high table. And then would be followed by the CCM chair, but I'll quickly invite, in place of the CCM chair, someone representing the civil society for TB to join the high table. Then I request the USAID Director for HIV and Health, Harry, please take a step forward to the high table. And you'll be followed by the WHO country representative, and then finally our chief guest, Dr. Ora Charles, in capacity of the Director General and representing the Minister of Health to the high table. So without much ado, maybe for the benefit of our officials, we have participation in this conference of key innovators across the country. We have representatives from the academia who are doing a lot of research in TB, and high-level organizations that deal in research. And we have the Ministry of Health team. National TB Leprosy Program in particular is here. You can stand for recognition. National TB Leprosy Program. Yes, the people who want to use evidence to make sure that the response to TB and leprosy is evidence-based, you're welcome. We have the civil society with us. members from the civil society, you are most welcome to this summit. I'm told the media is also here. I have not interfaced with them. If you are in the media, they are there trying to make sure that this event is on air. Thank you for coming. Our partners from the national level partner for TB, Dr. Mary Mudiope, we recognize your presence. And our other implementing partners who have come or who are online. Online we have over how many? How many people do you have online so far? Okay, 80 participants and above. Thank you, online participants, for keeping with us. I think mainly, broadly, those are the key participants in this summit. I will now invite the chair organizing committee for the summit to take us through the summit objectives and any other words he might have as a chair organizing this event. Dr. Simon Warisimbi, you are most welcome to the podium.
Thank you, SC. The other words that I have really are words of gratitude. Maybe I say good morning once again. Yes, I want to thank our commissioner, my commissioner, for having entrusted us with the task of organizing this summit. It is our very first summit dedicated to science in this area of TB. So thank you so much for that vote of confidence. I also wish to take this opportunity to thank the members of the steering committee and advisory committee for their guidance in setting up this summit, particularly for mobilizing the required resources. We mobilized these resources in a very short space, but as you can see, it has taken shape. So I want to thank the steering committee members, headed by the assistant commissioner herself. We had Dr. Isiko, I think I saw him. We had Professor Chirenga, yes, you're welcome. Stella, yes, Professor, you're here. We had Dr. Luze. If I've forgotten any other member of the steering committee, my sincere apologies. But we are very grateful for the guidance that you provided, and these are the fruits of your guidance. This summit was put in shape in terms of the scientific rigor. We set up a science committee, which was headed by my sister, Zawed, I call her Zawed, Dr. Stella and Dr. Jasper. So the abstracts, the papers that you're going to receive, were vetted by that scientific committee with a very strong technical support team of about 15 members, which I will not run through, and scientific reviewers who volunteered their time and expertise to make sure that the papers are of quality and real world-class sort of level. We took on a world-class outlook as we prepared for this summit, because we expected national and international members, stakeholders, to participate in the summit. With those remarks, I fall guilty for not projecting my objectives, but this summit was set up with a general objective of promoting the use of evidence, scientific evidence in TB and leprosy programming. And it is against that background that we had the session in the morning. How do we go about programming our TB interventions with a scientific base informing the activities that we do. So all the efforts that we are really involved in this activity are to enable us have an evidence-based TB and leprosy program, and that is the broad objective. We are convening here to make sure that we share this science for the program to uptake and utilize. Specifically, during this two-day event, we are going to share findings from all the ongoing research activity in the country. As you might be aware, Uganda is very, very visible in TB research at a global level. Oftentimes, as a country, we sometimes do not benefit from this very good work, and the commissioner, together with others, thought it is high time we benefited from this research. And so one of the specific objectives is to share these findings, and then through this platform, expedite the use of these findings in national policy and practice. So we expect that a number of issues or conclusions that arise from the papers that will be submitted this morning and later in the day will translate into guidelines and SOPs for TB and leprosy interventions. The second objective is to share best practices. A lot of good things happen on the ground, and we need to pick these up at a national level so that they can be implemented at scale by others. So as we selected the papers for presentation in the summit, we looked out for QI interventions, implementation innovations that can be used for a subsequent implementation at scale. All regions of the country should be able to innovate, to learn from the innovations at the sub-national or sub-regional levels. So during this summit, we expect to pick up some of these practices and then roll this out for implementation at national level. Finally, we thought that this summit can be used as a capacity building platform for research. For all those who are involved in the national TB and leprosy response. And again, it is against this thinking that we incorporated the capacity building workshops on the 2 days, starting each morning of the 2 days. This time around, we thought we talk about implementation research and economic evaluations. So it's because of that thinking that we set up these workshops. Our targeted audience, as you might be aware, is everybody at national and subnational level that is involved in the TB response. So our colleagues from wherever they are, online especially, should be able to participate in this event. I want to wish and pray that you find the proceedings of the event enjoyable and enlightening. Thank you very much.
Thank you so much, Chair, Organizing Committee, TB Leprosy Symposium 2024. I'll now take the honor to invite the representative of the academia, Dr. Paul Chitala. Dr. Paul Chitala is a renowned scientist and academician. He will say a lot about what he's doing at Guru University, one of the universities that the country has and is advancing steadily. You're welcome, Doctor.
Thank you very much, Commissioner, Director in the Health Services, Dr. Charles Solaro, our distinguished guests, ladies and gentlemen. Good morning. I would like to specifically thank you for inviting me to join you for this very important task. Professor Kitara is my name. I was formerly the chair for the program oversight of the CCM for many years until I left in 2019. I was at the Harvard University for this period. I came back last year. I feel passionate when I see Dr. Isiko Paul, when I see Dr. Raymond, when I see Professor Bruce. This country has done so well in making the world know about TB. I would like to congratulate you plus all the other members. The government of Uganda, the Ministry of Health, USAID, Stop TB program. Let me tell you, you're visible internationally. And thank you for your great work. Often, when I was away, everything about Uganda was so good. Everybody rates Uganda so high. But somehow, when I came back, I felt as if people were over-complaining about what they feel is not done. But I think the lens we are using for looking at Uganda, we need to shift it a bit because there is a lot of work which is being done in this country. And we'd like to congratulate the government, and we'd like to congratulate the Ministry of Health. Let me say this. Recently, I was looking at life expectancy in the whole of Africa for the last 30 years. But recently, I came back to look at East Africa, life expectancy in the last 61 years, from 1960 up to today. We are looking at Uganda, Kenya, and Tanzania. I can tell you that one of the greatest successes in improving life expectancy in Uganda has been the control of infectious diseases. And one of them was TB. So for many of you who want to see the impact of your work, go and look at the life expectancy of Uganda as one of the results coming from the control of TB. And Uganda, from around 2002, our life expectancy have been going up exponentially. The gradient is much bigger than any of the East African countries. And I think this is partly because of the work that has been done by the ministry and its partners. So having said that, I would like to emphasize our colleagues who are in academia. Let's look more on research on medicine to control TB. Let's look at the people, their behavior, and we look at what can change, be the change in this area. Secondly, we need to look at innovations, the modern technology. How can we use the telephone for mapping out people who have TB and how to follow them so that they can be able to do that? We can use that. That technology can be used. I've seen it in many other aspects. But something which is lacking at the moment is the question of curriculum support and development in many of the health training institutions. Some programs do not have TB ingrained in their curriculum training, and this should be something that we should be able to look at. Finally, I would like to say that I would like to thank you for inviting us. Thank you for the organizing committee. It has been wonderfully done, and I took the trouble to come from Gulu to come and join you. We'd like to ask you to have a very good celebration and our deliberation. Thank you very much.
Thank you, Professor David, for those high-level remarks and for applauding the government for the great work. And I know you are saying the Ministry of Health, which you have also been part of, and calling upon the academia to do more in terms of generating the evidence we need to end TB. Someone said here we need to reduce the TB mortality by 95% by 2035, achieve zero catastrophic expenditure, and the other 90 I have forgotten. It will come. Yes, incidence, reduce the burden of disease to more than 90% by 2035 compared to 2015 figures. Without evidence, some of these things are not achievable. So the academia, you are called upon to continue to support that effort, but also the programmers to use innovative approaches. Be as innovative as possible to make sure that what you are giving, the service you are giving, has impact. Our next speaker this morning is Dr. I hope so. Harry, Jessica, the USAID Director for HIV and Health. Doctor, you're most welcome to give us your remarks.
Thank you so much. Dr. Alaro, Clinical Services and representing the Ministry of Health. Dr. Stavia and your impressive team, the organizing committee, Gulu University, colleagues from WHO, Makerere University Lung Institute, colleagues from LPHS, TB, and other partners in the room. I also wanted to acknowledge Professor Joloba. It really gave me chills when you were being introduced and they made the point you're overseeing the supranational lab that provides diagnostic services to 20 countries in Africa. Wow. So thank you. We're here with a really impressive group today, and I just really want to appreciate this opportunity, and my remarks really build on those of Dr. Chitala in celebrating the great work that has happened here. And this is a wonderful opportunity to share best practices and peer-to-peer learning and to really look towards the future. It's a very impressive group of abstracts and presentations and a very full few days. And when I think about harnessing local research and innovation for impact, for me personally, I really think about TB control here in Uganda. I haven't been here long, but I've been so impressed at the work happening. And we're really proud of our role as USAID in this area. USAID's collaborated with Stop TB the Stop TB Partnership, to scale up innovative tools such as the portable digital X-ray labs with artificial intelligence for the diagnostic connectivity solutions such as Lab Expert, rapid molecular diagnostics, and others. We've been very proud to partner with you to implement the successful community TB case finding strategy, CAS-TB, that led to more than 100% treatment coverage in 2022 and 94% in 2023, putting Uganda ahead of many other countries in the recovery after COVID-19. So this is a global best practice now, and I really want to congratulate you all for that in the Ministry of Health. And so this work and also the impressive treatment success rates that you've seen over the past couple of years have really delivered results for Ugandans. And Uganda was one of only 5 countries that achieved more than a 50% TB mortality reduction from the 2015 baseline. So all of this research, innovation, the work is really delivering results. So congratulations again. So I think in addition to celebrating these successes and sharing best practices, these few days are a really good opportunity to look at those areas where we're not making the progress as quickly. So these are in the area of TB prevention coverage, drug-resistant TB case finding, and overall reducing the incidence of TB, which we'd like to speed up over the coming years. So these remaining challenges call for more evidence-based programming, efficiency, and sustainability gains for really lasting solutions for Uganda. I'd also really encourage you all to think these few days about how we take the best practices from CAS-TB and roll them into more routine programming so they can be the most cost efficient and the most sustainable in the long run. So one thing for USAID, for the United States Agency for International Development, we're really committed to making sure that the technical assistance and the support that we bring to Uganda is delivering on your needs and on the greatest needs of the country. So SMART for TB was already presented this morning, so I won't go into that in great detail, but I just wanted to emphasize that this is research that will happen not only in Uganda, but around the world. And I'd really encourage you to follow the progression and what's happening. I'd also really encourage many of you to apply for the early stage investigator program, where young researchers or newer researchers can apply for mentoring and longer term research grants. So the last area that I wanted to touch on that's a priority for us moving forward, and I know the Ministry of Health as well, is working on more person-centered, patient-centered care in TB and beyond. So looking at not just outcome-driven healthcare, but really people-driven healthcare. And TB is a great area for this work, because if we're not paying attention to poverty, to nutrition barriers, to discrimination related to whether it's age, sexual orientation, anything else, then we're going to miss people and we're not going to reach our national and our global goals. So on behalf of USAID, I wanted to thank you again for this opportunity, congratulate you on all the tremendous work that's happened, and wish you a very fruitful few days of deliberation and sharing. Thank you.
Thank you so much. Another round of applause for Henry, please. Yes, thank you so much, Harry, for those wonderful remarks. Again, reiterating the support of USAID to the country and applauding the country for the innovations that we have worked on together. They have also called upon us to take opportunities that are available in the SMART for TB that was presented here. So don't miss out on these opportunities. There's some money that is there that we can tap into. The next speaker is representative of WHO. Well, the civil society came. I didn't keep looking. When I called before, you did not come very fast. Now I see the civil society is on table. We want to thank you for coming to join us at the summit. Our request a representative to come and greet the participants from the civil society before we hear from WHO. Thank you.
Thank you, our AC, Dr. Stavia Triahawe. The USAID country representative, the representative of the Ministry of the Director General of Health Services, the senior researcher, the WHO NPO for TB, and dignitary from the Guru University and our AC, National TB and Leprosy Division. I'm honored to be here to be part of the Science Summit. The journey of TB has been a long one from the perspective of civil society. I would like the audience here to give a round of applause to Dr. Stavia Triahawe. I'll tell you why. Dr. Stavia has shifted the paradigm of TB and got on board civil society fully. And we do appreciate Dr. Stavia. Without much ado, I would like also to congratulate all of you who are here and to say that we have World TB Day on 27th March in Isinjo district. Please be there. Also like to recognize the presence of Professor Jolova with a good presentation. Also recognize the presence of Dr. Seyum of USAID. Dr. Biarhanga Raymond has also been supportive of the community engagement, as well as Mr. Buzamiru Bamloba. It's a wonderful team, Dr. Luze, the NTLP team. I'd like to congratulate all of you and also to remember our godfather of civil society, Dr. Paul Isiko, Executive Director of Uganda Stop TB Partnership. Thank you all to be here. Let's say, yes, we can end TB as civil society. Remember, there is nothing for us without us. Thank you, Dr. Savia.
Nothing for us without us. And yes, we can end TB with the civil society. Thank you, Roger Kamugasha, for representing your colleagues in the civil society space. And thank you, all of you from the civil society who have come to this summit. The innovations, if they are not taken up by the communities, they are nothing. So you need to be part and parcel of the whatever is happening. When the researchers are trying to test a regimen that is not going to be acceptable, you need to tell them at the design of the studies. So you need to look out in these universities and you make sure you have your teams working with the academia to, on the research and innovations that are happening out there. Now I turn again back to you, WHO representative, in your capacity representing the country representative of WHO. You're welcome, Dr. Evelyn Tibananuka, the National Professional Officer at WHO.
Thank you, Ms.
Good morning. My name is Dr. Evelyn Tiwananuka, as Essie has introduced me. I'm the technical officer or the professional officer for TB and leprosy under WHO Country Office Uganda. I bring you greetings and apologies from Dr. Jonas, the country representative for WHO in Uganda. Dr. Jonas has sent me to deliver his speech on his behalf, and I'm going to read it as is. The chief guest, officials from the Ministry of Health, dear partners, NGOs, civil society organizations, all stakeholders, ladies and gentlemen. I am delighted to join you in the scientific symposium on harnessing local research and innovations on TB and leprosy to shape national policy and practice to end these diseases in the country. I want to remind you that TB remains one of the world's deadliest infectious killers, with more than 10 million people falling ill with the disease every year. Uganda is among the top 30 world's nations challenged with TB and TB HIV. Annually, 91 people are estimated to fall sick with TB in Uganda, meaning that the country records 249 cases every day. In addition, over 30 people daily in Uganda lose their lives due to TB. Yet TB is preventable and curable. Ladies and gentlemen, on top of that, leprosy remains a challenge to the advancement of health care system, with globally 200,000 cases suffering every year. There are millions of people living and enduring the damages caused by delayed leprosy treatment. We recognize that 3 decades ago, Uganda achieved the elimination of leprosy as a public health problem, and through targeted efforts, this has been sustained over years. However, evidence of the past 5 years shows a reverse in our progress. Between 2017 and 2022, the country registered an increase in the number of leprosy cases, moving from 121 to 518, with 13% of these cases being children. The growing trend could be due to reinvigoration of leprosy control services and the ongoing community transmission. Members present here today, there is an urgent need for evidence-based innovations to save lives. This symposium serves as a critical platform for sharing insights, innovations, and strategies to drive a meaningful progress towards our shared goal of ending TB as a global health threat and sustaining leprosy elimination status in Uganda. Today we can leverage our collaborative expertise to confront the challenges posed by TB and leprosy heads-on. I wish to commend the government of Uganda, especially the Ministry of Health, for their tireless efforts in combating TB. In 2022, Uganda achieved its annual TB estimate, case notifications. We recognize that due to innovative approaches like CAST and a well-coordinated multi-sectoral accountability framework for TB, this dream was achieved. Additionally, I commend the efforts of the National TB and Leprosy Program for its innovative strategy and organizing the platforms for enhanced collaboration and knowledge exchange in TB control. Dear Chief Guest, we want to recognize the combined efforts of our partners and stakeholders, which have greatly helped us in addressing the issues related to TB and leprosy. These collaborations have significantly boosted our ability to deal with challenges posed by these diseases, leading to a better health results for our communities. As I conclude, I call on everyone to hasten the power of local research and innovations to inform national policies and practices, ultimately paving a way towards a TB-free and a zero leprosy Uganda. On behalf of WHO, I reaffirm our continuous collaborations with both state and non-state actors. We shall also continue supporting the country with leprosy treatment and preventive therapy as we work with member states towards TB vaccine. I thank you.
Thank you so much, Evelyn, for those wonderful remarks from WR and technical guidance, like you always do. Yes, it is now the moment for the official opening, but I picked a few things from the WR's remarks, and they have to do with numbers that over 240 people today will get TB, and about 30 people today will die from TB. Those are very serious numbers. So we need to cross quickly to reach the end so that we can save lives. But also she hinted on the numbers for leprosy that are on an increase to the tune of, I think, over 500 in 2022. Although they also reduced with TB in 2023 because we didn't search as we did in 2022. Yeah, those were the numbers that I picked that should continue to be at the back of our mind as we deliberate in this summit and synthesize the evidence. That said, guest of honor, I would like to take the honor to invite you to speak to this house and the people online. You're welcome, Dr. R, to speak to us. And after he has done so, we'll be inviting you to a group photo moment, and we continue. Thank you.
Thank you, Stavia. The Director of Health and HIV of USAID, the representative of the World Health Organization, the Minister of Health staff, members of the academia, all implementing partners, civil society organizations, all our front health workers, ladies and gentlemen. Good afternoon. Good morning. Okay, it seems like I have moved very fast. So good morning. I'm only hearing from the people in front. Good morning. It's with great pleasure for me to officiate in this first Science and Innovation on tuberculosis and leprosy. And I'm very proud to be associated with the first. I think this idea, I think Kirenga and Stavia remember it very well when we were in France attending the Lung Congress, is when we mooted this idea. That was when? November. And you see now we had to take it about 2-3 months to be able to do what? Implement it. I don't want to complain that we should have actually had it earlier, but everything always has some time to begin. So I want to congratulate the team which has been able to put all this together. Let's clap for them. So strengthening evidence-based TB response by harnessing research and innovation is in line with the global anti-TB strategy and the 2023 United Nations high-level meeting on political declaration on the fight against tuberculosis. To achieve all the commitments of the high-level meeting, which was adopted and signed on the 6th of December last year, we need to implement evidence-based interventions. This will allow us to remind ourselves on the commitments. I think this has been mentioned several, but I still let me able to re-echo them. To reach over 90% of the people who need TB treatment. Last week I was in Mbale. I was opening one of the theaters of a health center in Namatala, and I visited their ward, and I think they had run that day 8 samples, and 3 of them had become positive of what? Of TB. And definitely, you know, the informal settlement which is around Namatala. So it still means that we have many pockets of what? So we really need to be able to be deliberate of mapping up those points. Yes, we would want to reach all the places, but probably it would be good first that we reach those places which can give us the high what? Yield, and so that we can be able to pick up that. So I hope the Mbale team has been able to follow it up. 100% coverage for rapid diagnostics, testing for TB, and 100% coverage for health and social benefit package for people with TB, and mobilizing adequate resources for TB diagnosis, prevention, and treatment and research. So this is our commitment, and we are looking at that. Definitely the summit will help us to understand how well, or probably those areas where we are not doing very well, to be able to achieve those commitments. It is sad, as has been mentioned, it remains a significant health challenge to our country, in Uganda being listed among the 30 high burden TB and HIV burden countries globally. And estimated, we have heard already, over 250 people who fall ill, and 30 people die each day due to tuberculosis, which is curable and preventable. So these are the numbers which we have to contend with, and we have to see how do we change the narrative. I think all of you who have been in this country for some time, like me, you remember how it was very difficult to move the maternal mortality ratio down and all those other things. And for quite some time we are not what? But we've made some inroads. So now we need to be able to do this also for what? For TB. And I'm sure that all of you in the room are committed to be able to do that. But for us to be able to achieve that, it means that definitely services have to be accessible, we have to be equitable, but also at the same time we have to be responsive that people complete their treatment. so that our efforts don't end halfway. Because if when people don't complete treatment, it means like it's not a job, we have not completed that job. So the country has made significant progress and TB as a public health problem through implementing several innovative strategies to optimize TB case finding and eliminate the missing people within the TB in our communities, such as the active case finding toolkit, the Detect Child TB, and more recently the community awareness screening, testing, treatment, and prevention of TB casts and campaign. I think this has been a model. I think again when we had in the Congress, we shared this. It has been a model, and I'm happy now that we have integrated it. When Professor Katamba, he will say probably he's not yet, but when Professor Katamba was talking here, he talked, I think, of 3 issues: issues of awareness, issues of integration, and issues of decentralization. So I think we need to be able to look at those aspects. So with the CAST campaigns, there has been a 30% increase in TB notification that was realized in 2022. And we think that we need to continue to harness these benefits in expanding access to TB prevention. Following this exciting research, the Ministry of Health and partners have agreed to use the community intervention in an integrated manner. I think this makes sense. I think we need to be able to see how does malaria help to support TB, and how does TB help to support what? Malaria, so that we don't run things in silos. And I think this is happening now. And I want to congratulate the TB because you supported the malaria program quite a lot. So we are looking at that in 23, we are working with partners to develop and pilot an integrated CAST package in 14 districts, I think, and which will look at TB, HIV, leprosy, malaria, WASH, immunization, antenatal, and nutrition. There's evidence that the Ministry of Health is focused in improving health through an innovative approach. And I think that's the way to go. I'm very happy with the organizers of the Science and Innovation Summit, with the theme of harnessing local research and innovation on TB and leprosy to shape national health and practice to end TB and beat leprosy in Uganda. If we talk in, definitely if you have to do research, you need numbers. And I'm sure the numbers are here. If you need to be able to do that. So I am looking at how can we first as a country be the beneficiary to be able to improve from this research. So I am happy that when I was looking at the booklet, I was looking at really very high level scientific papers. And most of them have been done here in the country. So I want to thank all there were not many people of my age in the room, but all of them are young. So I want to really thank the young people in the room. Thank you very much for doing this work. So the World TB Leprosy Day have already been had. It's going to be in Isingiro, and with the theme of yes, we can end TB and beat leprosy. So we need to be able to look at that. This summit is part of a commemoration of what? Of that, and we really would want to raise their awareness of TB in the community. But also depends on how you define the community. Sometimes you think the communities but there are also communities in the urban areas which actually we need to do what? We need to be able to reach. The summit, as you've seen, is about in 6 sub-themes. And I think TB preventive treatment, TB and comorbidities, policies and pragmatic implementation, TB, vaccine and immunology, and post-TB lung disease, and laboratory diagnostics, imaging, laboratory and zoonotic disease. All this, I think you will be able to cover. Initially, I had a very big concern that leprosy had not featured very well, but at least I was shown that there's a section of papers which are specifically addressing aspect of leprosy. So we need to be able to see what we can be able to do partially at those hotspots. Because West Nile still is giving us over 50% of the cases. So we need to be able to look at what should we be doing differently so that we don't just report West Nile as what. We should be able to look at what are we doing differently. When I was chairing the National Coordination Committee the other time, I raised concern that yes, we've been able to track this data, but there have been districts which have been persistently on red. This year, next year, the other year, and I was wondering when will they ever get out of the what? Of the red. Not the political party color, but the red that they are poorly what? They are poorly performing. And now I had put a challenge that if we have partners working with us that area, it means all of us are what? Are failing because we are putting resources, but we are not doing what? So I think the next part of implementation, which I really would want to see, I would really want to see how can we be able to transform those areas which are parceland on the red to green, so that by the time we have the next summit, we should be able to see that most of this picture has been transformed. So I call upon us to concentrate during this summit, identify key evidence to inform our policies. Definitely, Stavia, if you brought all this one and you brought the booklet, it won't be of good use to the Minister of Health. So I'm sure you will have to look at them and look at what exactly can be those things which we can be able to do. Either to do at zero budget, probably we first look at those ones which don't need which need any additional budget. Then those which probably we can do with the same budget, and those probably which need minimum what? Before we look at those ones incrementally, which probably will need additional resources. So in order to promote harnessing and research and innovation, the program will continue to organize these monthly research forums, the NCC, and the annual science. So I think this has already been ingrained in our calendar. So we need that when we leave here, we're already planning to see when the next one will take place. I also request us that we work closely with the program to mobilize the required resources to fund the research project. And I'm happy that Jessica, and you said, has been supporting us in this area. So we want to appreciate that support. And probably since Jennifer is here, let's clap harder so that we can get more money. So we are finalizing a protocol for the second TB prevalence survey, which we hope to implement along with alongside CAS TB Plus, and we need resources to conduct this activity by September this year. So when we do that, the survey, it will show that whether all this time we have wasted our effort or we have made some inroads. So we really look at that, okay, let's remain optimistic. It will show that we have what? We've done positively in that direction. Allow me to thank the chair of the organizing committee, Dr. Simon Walisimbi, and your entire committee. Thank you very much. As I did say that this assignment has been done in a marathon of less than 3 months. So we are looking forward that most of the evidence here will inform policy and programming. And I want to thank our development partners and for supporting and funding the summit, first of all, and other activities like the CAS TB Plus, and eventually the World TB commemoration, and especially not all of them. Global Fund, USAID, CDC, Stop TB, WHO, Walimu, MLI, Makerere School of Public Health, and others. Let's again also recognize them and support and appreciate them. And I would want to add that when we come again, be available to do what? And willing to support us. Lastly, allow me to inform and invite you to participate in the World TB Day commemoration activities for 2024. And that whereas in Isingiro, would want that every district has some level of activity to commemorate this. And I think that's when it will make good sense than for us just look at in Isingiro. So this summit is one of them, and the date is 27th March, so I would want that you mark this date in your calendars. So as I conclude, first I wanted to apologize that the speech is long. It is not mine. It was just for I was just representing the Director General who was supposed to read it. So you will get me excused. But now, lastly, it's my pleasure and honor to declare the 2024 National Tuberculosis and Leprosy Summit open. Yes, we can end TB and beat leprosy. Thank you very much for listening.
So the people who are technical in the photo moment, how do we take the photo? We bring chairs here for the team that is that side, and then people stand behind them and also behind, I think. Chairs here. Who is bringing the chairs? Hey, you want to take us the stairs? Okay. They want you to take a walk. You've been seated. I hope you'll get all of them. When you say come, some people may remain on their on their laptops. Please let's join the chief guest for our summit at the photo moment.
Tuberculosis is a threat that continues to
Seeing you stand up, he's going to be there before all of you. You can see he's taking quicker steps than you. Please stand, go to the stairs. Let's go to the stairs. We'll only allow people who are on IT to remain behind here to make sure that our things are safe. The rest of us, let's go to the stairs. Meanwhile, the next session chair will need to be preparing so that we don't waste time transitioning.
And open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health. Chimanyere eronti. Whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health.
I think we are not tapping enough out of this TBcast program.
I'm wondering whether they have translated material that can be able to guide the audiences that is actually live TB free, not live TB free.
The number of clients we identify are reduced. They should start them on treatment before you realize the next time you are going to check on them, anywhere is.
So we still have that challenge of these people take this.
If you're having very good results, could it be expensive?
We are strengthening community disease surveillance on all the borders. We are not only targeting TB and leprosy, but we are all identifying diseases.
Tuberculosis is a threat that continues to affect an estimated 10.6 million people around the world. TB takes a huge toll not only on the health of individuals, but on families, economies, and societies. Joint action between affected communities and the health system are critical to bringing this ancient killer under control.
To end TB, meaningful community engagement is necessary to acknowledge the strength and the aspirations of the communities affected and infected with TB, and even TB survivors.
Harnessing the experience, skills, and insights of affected communities allows for better tailoring of programs and interventions, making them more community-centered and context-specific.
The most crucial step in an effective TB response is identifying who your community is, because they have the highest risk and are most vulnerable to TB, and because their voices and contributions can help curb the TB pandemic.
Meaningful engagement means that community members are valuable partners in the TB response. Decision-making must include an informed member of the community who bring lived experience and reality to the table.
Meaningful engagement requires intentional, deliberate actions. It must be costed and be included from planning throughout the national TB program cycle, including monitoring and evaluation. Creating or maintaining strong platforms and networks and coordination will be key.
The guidance is co-created with representatives of civil society, communities affected by TB, national TB programs, and other partners. It is a major tool that ministries of health, their national TB programs, NGOs, and other community groups can consult to harness the power of local communities to prevent, treat, and end tuberculosis wherever they are. Yes, we can end TB together.
Chimanyere Eronti. Whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health. Chimanyere Eronti. Whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health.
I think we are not tapping enough out of this TB program.
I'm wondering whether they have translated material that can give us guide the audiences that is actually live TB free, not live TB free.
The number of clients we identify are reduced. You start them on treatment before you realize the next time you are going to check on them, anywhere is.
So we still have that challenge of convincing these people to take this.
If you're having very good results, could it be extensive?
We are strengthening community disease surveillance on all the borders. We are not only targeting TB and leprosy, but we are all identifying diseases.
Tuberculosis is a threat that continues to affect an estimated 10.6 million people around the world. TB takes a huge toll not only on the health of individuals, but on families, economies, and societies. Joint action between affected communities and the health system are critical to bringing this ancient killer under control.
To end TB, meaningful community engagement is necessary to acknowledge the strength and the aspirations of the communities affected and infected with TB, and even TB survivors.
harnessing the experience, skills, and insights of Africa.
Stella, you ready? You ready? Okay, so we want to start the science. Wanji? So we want to start the scientific sessions, but right before the sessions, I will invite the chair of the scientific committee, Dr. Stella, to come and give to us an accountability of how the papers were selected. Are you ready? I want to go off the podium. Yes, over to you, and then you invite the... Oh, thank you.
Thank you very much, our chair. So thank you very much to our speakers for opening our summit. And I think we will start now. We thank everyone who responded to the call from the NTLP to submit scientific abstracts for this conference. We had a very short turnaround time, but we had an overwhelming response, and we want to thank everyone. We want to thank all our partners online. We want to thank the people in this room. We want to thank you so much for taking off the time to analyze your data and submit your abstracts. The abstracts were this process of submitting, getting and submitting abstracts was led by the scientific committee. Simon is our overall chair. I was the chair of the scientific committee. Dr. Jasper, please stand up and wave. Yes, I was my co-chair, and we worked very well together, so thank you, Jasper. We were supported by the technical committee. The technical committee, can you please stand up and wave? Okay, yes, thank you. And we were also supported by 25 abstract reviewers from across the hills. So people from Makerere University, people from the IDI, people from MLI, people from USID, LPHS, all of them gave us their time to review these abstracts and give us their professional opinion. So I will give you a short summary, a very short summary of the abstract. Can we please start? Okay, so in total we had, as the presentation comes, we had 173 abstracts which were submitted. Please clap for yourselves. And these 100, so there we have it. These are our abstracts, and these were the thematic areas and the places they came from. So our biggest thematic area was program implementation and policy. And we want to thank everyone who has promoted operations research and implementations research, because we had over half of the abstracts coming in dealing with the program implementation and people at health facilities analyzing their own data and, you know, coming up with findings to improve programming. So that's very commendable. Then we also, the second one was epidemiology, which was really people just analyzing trends, like, you know, trends of treatment outcomes, trends of mortality, and, you know, and using data from larger areas. So this was like regions or districts, or some people analyzing data from DHIS2 and writing abstracts. Then we had abstracts on diagnostics. We had abstracts on social protection. And this is a new area for TB, but we are glad that we had about 10 abstracts submitted on social protection. We also had 13 abstracts submitted for leprosy. You know, leprosy and the zoonosis. So thank you. Yes, Rose is clapping. Please clap for leprosy, because usually we have like 1 or 2 or sometimes none, you know, but we had 13. Not all of them made it past the review, but at least they were submitted. So thank you. Then we have that map that you see. The green areas are where most of the abstracts came from. You know, we had a few abstracts that didn't have their addresses, but these green areas, so we had very good response from Kampala, Mukono, Wachiso. We had very good response from the Ankole region, Lango region, Karamoja region, West Nile region. We also, the East had a few abstracts, Jinja, Mayuge, Iganga. We didn't have a very good response from the West. So if you see your area is white, we didn't have a very good response from you. So the West, South Central, and the East, Soroti, we didn't have a very good response. We hope that next year we'll have better response from across the country, but we thank the people who really put in the time. How did we choose these abstracts? So like I said, we had an abstract review process, and it was a multidisciplinary team. So it was a team from the NTLP, from the MLI, from Makerere University, from IDI, from USID, LPHS, and we all came together. We mixed and matched our reviewers to make sure that we are matching their areas of expertise, but also we don't have people reviewing their own abstracts. And we had a clear criteria. So the abstract review was marked, the abstract, depending on whether they had a clear background and justified objective, whether the methods were clear in case it was clinical research, or if it was public health practice, whether the intervention was appropriate for the objective, and whether that intervention was clearly described. Then for the results, we wanted to know whether the results were clearly presented and whether they drew from the objectives. You know, so if you implemented an intervention in public health practice, do the results you give us come from that implementation? You know, otherwise you can implement, if you want to increase TSR, then the implementation process wouldn't be to increase gene expert utilization. Those two, you know, one does not lead to the other. You know, so we wanted to make sure that your interventions implemented lead to the results which you are presenting. And then your conclusions, were your conclusions supported by your results? And were they feasible for public health practice? Were your conclusions feasible? And then we had a mark for study originality and contribution to the field. So there were a few abstracts that were not really saying, had no novelty, and so we had a mark for that. We also had a mark for people from the district actually writing and presenting these abstracts. So that's not put there, but it was a bonus mark. So if you had someone from the district, not from the implementing partner, you know, but from the district actually writing and submitting that abstract, you got a bonus mark. Yes, and that, so how many abstracts did we accept? So our acceptance rate was not bad, it was 50%. So out of 173, so we had 42.8 rejected. So we had about 50-something, 57 point something that were accepted. And some were accepted for oral. The biggest number was accepted for oral. And then there were some which were accepted for poster presentations. So the acceptance rate wasn't bad at all. So we want to thank you again, all of you. We want to thank our advisory committee from the Ministry of Health, the scientific committee, the abstract reviewers, very important, and all the authors and co-authors. Thank you all very much. So we will now go to the first session of abstracts. The session is TB epidemiology and surveys, and the chair is Professor Noah Chiwanuka from the School of Public Health, and his co-chair is Dr. Luze Henry from the NTLP. Over to you.
Thank you very much. Once again, I'd like to welcome members to this first scientific session of epidemiology. Epidemiology surveys and burden for TB. We have 6 presentations. I will lead 3 of them, and my co-chair, Dr. Henry Rose, will take the last 3, and we also lead the question and answer session. So I'd like to take this opportunity to welcome our presenters to come to the podium, to come in front to this table. Frida Roya Cheng, are you here? Professor Harriet Mayanja. Oh, this is Harriet Mayinja. And the presentation is going to be made by Wendy Masse. So please come to Geoffrey Amanya. I think I've seen Geoffrey here. Yeah, so please come to the table. Joseph Baluku, Timothy Kintu, and Richard Kwezera, please. Thank you. So we're going to have each presenter present for 10 minutes. I'm very notorious on time, please, because I like to respect everybody's time. So presenters, please take a keen note of the time, 10 minutes. There is no confidence interval attached to those 10 minutes. It is just a point estimate, 10 minutes, no confidence interval. Okay, so, and the rest of us in the audience, please keep all the questions to the end of this session. We shall have the questions asked once. We are not going to be interrupting the presenters as they go along. So I would like to take this opportunity to welcome Frida. Frida is going to be presenting to us spatial distribution and temporal trends of tuberculosis case notifications, a 10-year retrospective analysis between 2013 and 2022. We're supposed to have another mic, but don't worry, you can use this one.
Good afternoon, everyone. All protocol observed. My name is Frida Loya Cheng, and I currently work with the Ministry of Health as a senior epidemiologist. My presentation is on the spatial distribution and temporal trends of tuberculosis case notifications in Uganda, and this is a 10-year retrospective analysis from 2013 to 2022. Next slide, please. Uganda has a high incidence and prevalence of tuberculosis, and analysis of spatial and temporal distribution of TB is an important tool for supporting spatial decision-making, planning, and policy formulations. Identifying districts with high TB prevalence can enable improved focus on preventive and control interventions. We determined the spatial distribution and temporal trends of tuberculosis notifications in Uganda from 2013 to 2022. So we conducted a retrospective analysis of routinely generated program data that is reported through the National TB and Leprosy Program Surveillance System. We calculated the case notification rates per 100,000 per year by district and region, And we calculated the case notification rates using the cases per district as the numerator and individual district populations as the denominators. Then we used logistic regression to determine the percentage annual change in case notification rate over the study period. And to describe the spatial distribution of the TB case notification rates, we used QGIS software and we drew choropleth maps for Uganda showing the TB case notification rates per 100,000. Over the entire study period, we had 5,068,957 cases of TB were reported, and there were 44,886 cases in 2013 and 94,286 cases in 2022. And there was a 6% annual increase in TB case notification rates reported from 134 per 100,000 in 2013 to 213 per 100,000 in 2022. Moroto region in the northeast had consistently high case notification rates throughout the 10 years, while Mbale and Soroti regions in the eastern Uganda had the lowest case notification rates throughout the 10 years. Moroto, Napak, and Kampala districts, I'm still on the results. Moroto, Napak, and Kampala districts had consistently high case notification rates throughout the 10 years. Bududa, Bujiri, Chibuku, Namutumba, and Palisa districts had low case notification rates throughout the 10 years. So we have the implication for the national TB and leprosy response is that the NTLP should institute intensified measures aided by more funding to identify cases of TB and mitigate and reverse the negative impacts of the COVID-19 pandemic on TB. So that's a graph. The figure shows the TB case notification rates per 100,000 in Uganda from 2013 to 2022. We identified an increase in overall reported cases of TB in Uganda during that period, and the overall increase is likely due to a combination of factors, including a long-standing national TB control program, the presence of at least one focal person in every district, technical and financial support from implementing partners distributed throughout the country, as well as improved reporting and capacity to diagnose TB. And over the 5 years, you can see from 2013 to 2017, there was a decline in TB case notification rates. And this could be due to probably real declines in the population of TB cases, maybe changes in diagnostic rates, change in the notification rates, underreporting, as well as limited capacity to diagnose TB. And in Uganda, we have the active case finding began in 2018, and it is not surprising that the case notification rates have been consistently higher than the pre-active case finding period. The decline in TB case notification rates in 2020 can be attributed to the COVID-19 pandemic, which disrupted healthcare worldwide. And the increase in notification rates in 2021 and 2022 could suggest that the number of people with undiagnosed and untreated TB grew during the intense waves of the COVID-19 pandemic, resulting in more community transmission of the infection and subsequently an increase in the number of people developing TB. In 2022, the National TB and Leprosy Program, with support from the partners, began the Cast TB leprosy campaign, and this has resulted into an increase in the TB case notification rates, especially as Professor Chirenga actually clearly explained. Okay, I would like to acknowledge the following: the NTLP program, the US CDC, and the Uganda Public Health Fellowship Program. Thank you.
Thank you, Madam Frida. You actually saved us quite some good time. So I'd like to ask the organizers if it is possible for the presenters to move their own slides. Do we have that remote control for slide movement? It will be good for them to be in control. I would like now to take this opportunity to welcome Harriet Mainja from Ministry of Health. She's going to present to us pulmonary tuberculosis screening among travelers and migrants in Uganda at ports of entry. Analysis of surveillance data 2022-2023. And I think the presentation is being done by Mercy. Okay, over to you, Mercy.
Okay. Good afternoon, ladies and gentlemen. Mercy presenting to you pulmonary tuberculosis screening among travelers and migrants in Uganda at points of entry between 2022 and 2023. East Africa has a high burden of TB with an incidence ranging from 59 to 317 per 100,000 population. Transmission of tuberculosis in East Africa is fueled by cross-border movements. Mobile, refugee and migrant populations are at an increased risk of TB. TB is prioritized for disease surveillance within the 2019 East African Framework for Surveillance. And in 2022, Uganda introduced TB screening at points of entry using a symptom-based algorithm using 5 symptoms. So all persons with cough of more than 2 weeks or any other 2 symptoms are presumed to be TB cases, while those who don't have those symptoms are not. The presumed cases are registered and taken for testing, and samples are picked for testing using GeneXpert. Confirmed cases are linked to care, while those who are not confirmed do not have TB. So our objective was to assess the performance of screening among travelers and migrants in Uganda at points of entry between 2022 to 2023. We performed a descriptive analysis of routinely collected surveillance data in the DHS2. We looked at the following performance indicators: the number of presumptive cases identified, the proportion of identified presumptive cases that were tested, and the proportion of confirmed TB cases that were linked to care. This was done at 45 out of the 65 points of entry in Uganda, and we did a descriptive analysis. So here are our findings. Of the 10 million travelers and migrants, 39,000 were presumed to have TB. Less than half of the identified presumptive cases were tested, and this could be attributed to gaps in testing at the points of entry. The Western and Central region had the lowest proportion of presumptive cases that were tested, and this highlights gaps in these regions. On average, 29 confirmed TB cases were identified per quarter. In quarter 4 of 2022 and quarter 1 of 2021, there was an increase in cases, and this could be attributed to an observed increase in cases observed along the Kenya-Uganda border. On average, 59% of the confirmed cases were linked to care. The gaps in linkage to care could be attributed to the unique population. These are mobile populations who in some cases have already moved on by the time their results come back. We found missed opportunities in the TB cascade at points of entry with suboptimal proportions of suspected cases tested and missed opportunities in linking confirmed cases to care. We acknowledge the following. Thank you.
So thank you, Mercy. seems people are very time conscious. Maybe we should reduce the minutes given to presentation. So far, the highest, so far both of them have used 60 minutes each. I would like now to welcome Geoffrey Amanya. Geoffrey works with the Ministry of Health, NTLP, so they are the ones hosting us here. Anyway, and Geoffrey is going to be presenting to us characterizing and understanding TB transmission dynamics in a high burden pastoralistic region of Karamoja. Over to you, Geoffrey.
Yeah, thank you, Prof. Geoffrey Amanya is my name. I'm supported by the LPHS TB activity as an epidemiologist to the Ministry of Health TB program. So we'll basically be looking at characterizing and understanding transmission dynamics in a high burden setting, socially constrained setting, Karamoja. So we undertook a review of records to understand the transmission dynamics in Karamoja. This was a team effort, and this surveillance activity was supported by WHO financially, and it received technical support from USAID and also Global Fund. Yeah, so we know that last year, in 2022, we notified over 94,000 patients. That was far above the national estimate. So, but also we know that the country continues to experience an even distribution of TB. That is not unique to Karamoja. It also has areas where you find TB is almost threefold the national when you look at district level. So some districts, they have TB up to 786 per 100,000 when you're looking at burden. So in 2023, 5,000 TB patients were identified in Karamoja, and 24% were pediatrics. So in line with the pediatric TB, there was a plan to go and assess surveillance to understand if there is transmission dynamics from the adults. So with the support, we conducted this surveillance in July 2022 with the objective of establishing the chain of transmission, the specific objective to describe and characterize TB, and also to recommend control measures. So like I said, this was a retrospective review of records. We did some triangulation of data with our ECBSS, the case level data. And we also adapted a tool from the household vulnerability assessment tool from the gender side. And also we administered a questionnaire to understand access to TPT and transmission dynamics. Yeah, so like I said, there is the cases per 100,000 have been growing in Karamoja scene, and the annual change in incidence has grown from 28% in 2018, 39% in 2019, and 2021, the annual change in incidence was at 11%. I think because I don't have the other subsequent years for now, but that highlights the annual change in incidence for TB. So as part of this work, we are supposed to characterize, to understand what type of TB is this. So we had the PBCs comprised of 40%, PCDs, clinically diagnosed TB, was at 38%, and the EPTB at 21%. So for the EPTB, adenitis was the highest at 61%, and spine at 22%. So the picture is our inception meeting with the regional referral hospital. So just fast forward, we have 24% of the patients we reviewed were 0 to 4 years, 17% 5 to 14, The highest was 25 to 44. These households, according to the HVAT, the vulnerability scaling, they were ranked as critically vulnerable households. 70% of these households reported having a meal a day. 54.5 suffered poor ventilation. So the 40% overall showed that they were critically vulnerable. Just proceed, the TB nutrition picture. 52% of the TB patients had a BMI of less than 18.5. 89% of these had poor outcomes. Those who had a BMI of less than 18.5, they had poor outcomes. 58 died, the others got lost follow-up, and failure were 7. So like I said, we also assessed TPT. Oh, sorry. Yeah, we also assessed TPT. Only 44% had been started on TPT with a completion of 98%. That was good news. The other good news is none of these patients who were on, those who were started on TPT developed TB. None of them in all the 1,500 records we reviewed. So the last objective was to understand the transmission dynamics. So usually in epidemiology, you want to know how is the transmission going in the households and outside the social networks. So these were Manyatas. The first picture shows us what was in Matany. In Matany, the key question was, who is a super spreader? What is unique before I cross over? The transmission, these Manyatas, that's a Manyata, and a Manyata. So we found a super spreader, a patient LJ. He had transmitted to, they had transmitted to LA, they had transmitted to LC, and the picture kept growing as you see there. On the right, we buffered around the villages to understand how transmission dynamics were. So key is to identify that there was an index patient who transmitted or a primary case transmitted to a secondary case, and also we have tertiary cases in Manyatas. So 31.2% of these contacts had suffered TB. So lastly, the implications for this are we need to scale up the SOS because we have seen the proportion. Thank you. We had seen the proportion of 0 to 4, and the other was extremely high. So there is need to have ensure diagnostics, like Prof was saying, Prof Joloba. There is need for advocacy and social protection. So I will quickly highlight that we were supporting a TIFA project supported by USAID across in Kenya. 87%, that is Turkana, of the people, the other side had TB, rather had malnutrition. That was North Pokot and Turkana. So, but we also learned something in the spirit of MAF. In the same setting, they had listed all programs which are providing social protection to ensure they reach out for TB. So I felt this was critical. I bring it in because that was the darkest point in Kenya concerning TB. Second last was TPT for households. We need to ensure we have future studies that look at whether there is transmission among those ones who have TPT. But then also we need to strengthen cross-border interventions. During this review, we found around 6 patients were from across the country, and they had been, accessing service in a way or the other. So those I appreciate and I acknowledge the following. Thank you so much.
Thank you so much, Manya, for the presentation. You took actually all your time.
Before you go on, we'd like to tell everyone who's listening online that if you have a question, please you can use the chat function and type in your question. After the session, we'll read out all those questions. For us who are in the room, please jot down your question You'll put up your hand at the end of the session and then we'll pass the mic around. But for those online, the chat function is available and is functional. Thank you.
Thank you, Stella. Thank you, my chair, for giving me the opportunity not to be just idle here. So I want to call upon the next speaker. Something very interesting, really. Death after cure. Mortality among tuberculosis survivors in rural Uganda by Joseph Baluku from Kirudu National Referral Hospital and also Makerere Mulago Lung Institute. So over to you, Dr. Baluku.
Good afternoon, colleagues, and I'm very excited to share our results that are barely 2 months old. And we looked at mortality among people who had survived TB. Now, ladies and gentlemen, the average person with TB is malnourished. He's probably poor, smokes cigarettes, takes alcohol, has HIV, and probably a myriad of other comorbidities, has suffered stigma and discrimination. By the time this person develops symptoms, they are going to take about 3 months before they can show up at the health facility. When they show up, it is going to take another month navigating the healthcare system to get the TB diagnosis. When you make that TB diagnosis, it is going to take another 1 week before you can start treatment. Now, all this while the disease is progressing, they are suffering catastrophic costs. Other body organs are being involved. Even when you start treatment, this individual is going to suffer a myriad of drug toxicities. But you're going to promise this person cure. Is it cure? Indeed. Now, by the year 2020, we had cured over 150 million people globally. And so we are doing a good job. But the risk of mortality, even after TB cure, is 3 times the general average person who has never suffered TB. And we know that globally about 12 million years of life are lost in Africa alone during the post-TB period. In rural settings, because people in the villages suffer a lot of these inequalities that I've discussed, almost 4 times, these individuals are 4 times more likely to die than their counterparts who have never suffered TB in the same setting. So this is important. Now, if you only focused on deaths contributed by TB during the active TB, you will miss out almost, I think that's 49% of additional deaths that occur after TB cure. So this is a very important aspect. So we wanted to ask ourselves, what is the mortality rate among TB survivors? What are the predictors? How long do people survive? At least those who die, how long do they survive from the time they are cured? And what are the potential years that they lose? Now, we're not starting from zero. There are studies from Uganda that earlier on showed that 33% of people who were previously hospitalized, they die even after you cure them. 62% in one study among people who were being retreated had already died within 2 years of follow-up. So this is a very big problem that I think we need to focus on. So what we did is to conduct a very simple study at Masaka Regional Referral Hospital. And we went to the TB registers and identified everyone who had bacteriologically confirmed TB and was cured in the decade between 2013 and 2023. And then we contacted these individuals by telephone. If these individuals were not available, we went to their homes to search for them to ascertain whether they were alive or they were dead. And that is all that we were interested in. And all these other analyses are really the standard things that you would normally do. What did we find? Of 334 people whom we were able to trace, this is about a 71% success rate of tracing. These people are very difficult to find. If you look at other studies, you'll be lucky if you got even 40%. Of 334 people whom we were able to find, 11% had died. This gives you a cumulative incidence of mortality of 113.7. Now, in comparison, mortality data in Uganda is not very, very reliable, but some online resources suggest that in the general population, the mortality rate is 5.8 per 1,000 population. What that tells you is that a TB survivor in rural Uganda is 15 times more likely to die than someone who has never suffered TB. And we found that these people lose, on average, 24 years. Now, if you were supposed to die at 63, as it has been now, it has increased to 68, the life expectancy of Ugandans. If you are supposed to die at 63, once you suffer TB, you are likely going to die at only 40. So you lose almost 23 years, even if we have cured you of TB. Now, among those who died, these individuals survived for only 9 months after TB cure. Then we ask, what are the predictors? Who is more likely to die? And what we see is that if you were hospitalized at the time of TB diagnosis, you were likely to die, even when you were cured. We found that if you were unemployed, you had no job at the time they diagnosed you with TB, you were likely to die. And this tells you that the critically ill and people who are financially impoverished, even during TB treatment, do not make it even if you cure them. So what are we saying? We need social protection measures, not just for TB, people with TB, but also for survivors of TB, because TB has a catastrophic, enduring effect on somebody's livelihood, even when you cure them. We are saying that we need long-term follow-up, maybe 9 months for those who are critically ill at the very least. And maybe we can even reduce hospitalizations to start with by diagnosing TB early. But I think the most important takeaway message is that we need long-term studies, we need databases of TB survivors, long-term cohort studies. We need strong societies of TB survivors to advocate for interventions for them, strong community-based organizations that can mobilize them if we need to study them, if we need to carry out any interventions. I thank you very much, and I'll be glad to take your questions.
Thank you, Dr. Baluku. Again, you kept time. And now I want to call upon the next presenter, Dr. Timothy Kintu. Kintu is going to present on the prevalence of electrocardiographic abnormalities at TB cure. These are preliminary results from a prospective cohort in southwestern Uganda. Dr. Kintu is actually not from Barara, as is indicated. He is from Mulago National Referral Hospital. So, Dr. Kintu, over to you. Thank you.
Thank you very much, Co-Chair. Good afternoon to all of you. As we wait for the slides to pop up, I am Timothy Chintumwanje, currently working as a medical intern doctor at Mulago National Referral Hospital, and also a research associate under the African Center of Excellence in Bioinformatics and Data Intensive Sciences at the Infectious Diseases Institute. So I am going to present work on behalf of the IMPACT-U team from Barara Regional Referral Hospital, which is improving pulmonary function after tuberculosis in Uganda. I'm here on behalf of the study PI, Dr. Edwin Nwajera. So, thank you very much. So a number of concerted efforts have been made in TB prevention, screening, and management. However, Dr. Baluku's talk served as a wonderful preamble. What happens after TB cure? It is commonly underlooked. These patients are rarely followed up. And evidence from a systematic review done in 2019 indicated the #1 cause of mortality in these patients was cardiovascular abnormalities. So what we set out to do as a sub-analysis of the IMPACT-U work was to describe ECG abnormalities among pulmonary TB survivors at cure. We used the ECG to serve as a surrogate marker for cardiovascular abnormalities. So as I mentioned, this was a prospective cohort of patients enrolled between 2021 and 2023 with index pulmonary TB. They had to have laboratory confirmed diagnosis of drug susceptible TB They had no prior lung disease at enrollment, and they were willing to be followed up for 18 months, which was a study period. All these patients were managed as per the standard of care under the national TB guidelines. We got the pre-treatment clinical and social demographic characteristics and pulmonary function using spirometry at TB cure, as well as ECG were done. The ECG was also done at baseline to allow us to compare the changes in ECG over the treatment period. The data was analyzed in RStudio, and the findings were summarized using chi-square and student t-test as required. So we enrolled 189 total participants between that period. ECG and lung function at cure were done on 105 patients, and 38% of these patients at TB cure had some form of an ECG abnormality. This was a very significant change from 6% of these patients at baseline. And these ECG irregularities were found to be associated with some lung function tests, like the pre-bronchodilator FEV1, the pre-bronchodilator FVC, and the FEV1 to FVC ratio, showing us that there is an association between lung function and development of cardiovascular abnormalities. There may be an association. We also looked at the change in ECG. So having an ECG abnormality at TB cure versus developing an ECG abnormality when you are normal, when we enrolled you. And we found that the duration, the patient told us they had cough before they came in, and the patient age was significantly associated with a change in ECG abnormality, with the development of an ECG abnormality. So the cough duration tells us that there may be something to do with the duration of disease before the patient presents to the hospital that is associated with developing an ECG abnormality. So the implications for us today is, one, like Dr. Bayoku mentioned, we need to follow up these patients even after they've left hospital. Here we use the ECG as a surrogate marker, but perhaps innovations can be made around developing better biomarkers of development of cardiovascular disease in these patients. We need to enroll larger cohorts of patients to identify which ECG abnormalities are the most common in these patients, and what are the significant factors, so that we can design interventions to capture these patients early enough and reduce cardiovascular associated mortality in post-TB patients. The acknowledgements, like I mentioned earlier, the entire IMPACT-U team. IMPACT-U was supported by the American Thoracic Society under the study PI, who is Dr. Edwin Wajra from Bara. Thank you very much.
Thank you so much, Dr. Kintu, for that good presentation. Lastly, on our program, we have Richard Kwizera from Infectious Diseases Institute, who is going to present on chronic pulmonary aspergillosis in Uganda, focusing on the burden, diagnostic challenges, and implications on TB care. Over to you, Dr. Kwizera.
Good afternoon, everyone. My name is Dr. Kwizera Richard. I work as a research scientist at the Infectious Diseases Institute. So my talk is about chronic pulmonary aspergillosis in Uganda. I'll highlight some information about the burden, the diagnostic challenges we face in Uganda, and then the implications on TB care. So chronic pulmonary aspergillosis is a slow, progressive, and destructive parenchymal disease. It's mostly caused by Aspergillus fumigatus. We see it in both immune-competent and immune-compromised patients, though what they have in common is that they usually have some form of previous or underlying lung damage. CPA is estimated to affect about 3 million people globally. It can coexist with pulmonary TB. Radiologically and clinically, you can't distinguish the two. And in most cases, these people with CPA are usually misdiagnosed and they're managed as mere negative TB. Pulmonary TB is on the top of the list of risk factors for CPA. Though we have about 2% of these patients who have CPA but without any known risk factors. So who gets CPA? We have patients who get CPA without TB. Probably they have other risk factors. These are patients who get CPA, and then at some point if they get TB, you can pick up the CPA at the diagnosis of TB. These are patients that will have persistent respiratory symptoms even after the 2 months of the intensive care of TB. Though there are those that actually get the CPA along the way during the treatment of TB, but it was not there at the beginning, mainly due to the pathophysiology of TB. However, we have this most interesting population, which are people who are treated for TB. They are declared cured, and then later they come back with persistent respiratory symptoms. They get CPA after curing the TB. So the idea here is that the TB leaves behind scars or, let's say, cavities. These get colonized by the fungus. It forms a biofilm there. The biofilm becomes the source of the constant or persistent respiratory symptoms. So if you did all the TB tests, they will be negative for this patient. Sometimes it presents as post-TB lung disease. Sometimes it's seen as a reinfection of TB if you didn't do the fungal investigations. So we initially tried to estimate the burden of fungal diseases in Uganda using modeling and systematic review. We estimated CPA at 22% of TB patients with cavities and 4% without cavities. And we estimated up to 3,000 new cases, that's per year, for post-TB CPA. And we estimated CPA at about 7%, those who have symptoms. And then there is an additional 1.5% who have a fungal ball or an aspergilloma. We estimated mortality at up to 500 deaths per year. We then followed up a cohort of TB patients and measured their aspergillus IgG specific antibodies. We found out that 4% of them had elevated titers at the beginning of treatment, and 9% of them had elevated titers at the end of treatment. Those with CD4s less than 100 and those who were not on ART at baseline had significantly elevated titers of the fungal antibodies. From this work, we just concluded that the aspergillus infection may complicate active pulmonary TB. We went to Gulu and also did a longitudinal cohort. And from this cohort, we concluded that CPA actually complicates treated TB with residual chest, radiography, cavitation. We noted that the chest radiographs alone could exclude CPA. However, if you added serology, you could diagnose CPA with a reasonable accuracy. From this work, we noted that HIV co-infection had no significant impact on the frequency of CPA. So we concluded that actually without these fungal antibody tests, most of these patients with CPA are misdiagnosed as recurrent smear-negative TB and sometimes are given second-line TB therapy. Then a group of scientists from Uganda and from all over the world came together and then suggested a case definition for CPA in resource-constrained settings. Ideally, someone should have an illness of 3 months or more, and then they should have all these 3 criteria. The first one is the clinical, where we mainly look out for the weight loss, persistent cough, and hemoptysis. About 67% of these patients will have hemoptysis. In the radiography, we try to look out for cavities, infiltrates, fungal balls, fibrosis, pore thickening, and nodules. Then the third criteria is the microbiology or serology. So we try to look out for the aspergillus IgG titers or test. Though sometimes we also do the fungal culture using sputum. So this was an HIV positive lady with CD4 of 176, 3 months history of productive cough. She had all the signs of TB, and she had been given anti-TB drugs for 1 week prior to this admission. We did the radiographs. They showed cavities with fungal balls. The TB tests were all negative, but when we did the aspergillus test, it was positive. We discontinued the anti-TB drugs and put this patient on itraconazole. This was an HIV negative lady, 3 months history of coughing up blood, chest pain, who had been referred from one of the health facilities. They had suspected her to have TB. They had given her TB drugs for 2 weeks. She had no history of chronic chest symptoms. So we did the radiographs that showed the mass, fibrotic changes, and a fungal ball. So then the aspergillus test was positive. Then we had this young lady, HIV negative, hysteroproductive cough, chest pain, had most of the signs of TB apart from the night sweats. She had been treated for TB in 2017 and 2018. So she comes back with these symptoms in 2019. And when we did these investigations, we saw cavities, bronchiectasis, and then a nodule. And the aspergillus test was positive. We then tried to follow a cohort of TB patients, looking out for those who had persistent respiratory symptoms after the 2 months of the intensive treatment. We enrolled 162 patients. Majority of them were male. 30% were HIV positive, and 9% had prior TB. And 23% of these patients had Aspergillus niger grown from their sputum, and about 8% of them had Aspergillus fumigatus grown from their sputum. 4% had cavities with fungal balls, and 32% just had cavities without fungal balls. So we diagnosed CPA in 20% of these patients who had persistent respiratory symptoms after the 2 months of intensive care. So we concluded that CPA actually may be causing persistent respiratory symptoms in up to a fifth of patients who are after the TB treatment. We recently tried to estimate the burden of fungal infections in Uganda, and we estimated CPA incidence at 57 per 100,000. The prevalence was estimated at 137 per 100,000. We also estimated that CPA actually probably accounts for about 14% of TB-related deaths in newly presenting cases. Our recent work also showed that patients who had CPA with pulmonary TB co-infection had poorer health-related quality of life compared to those who just had pulmonary TB. So ideally, globally, the burden of CPA attributed to healed TB lesions is estimated of over 1.2 million cases annually. Ideally, active TB is the #1 differential diagnosis for CPA. And CPA is the #1 differential diagnosis for those patients who were previously treated for TB and they have recurrent smear negative TB. So we also estimated the annual new CPA development following complication of TB to be about 6.5%. And in Uganda, with a high burden of pulmonary TB, most of it secondary to HIV, we believe the incidence of CPA is actually higher than what we suspect, but the index of clinical suspicion is still low. The major challenges we find in diagnosing CPA in Uganda is that we still have a low index of clinical suspicion. We are still diagnosing these patients as smear negative TB or post-TB lung disease. And I think we're still giving them TB therapy, which they don't need. We still have a shortage of trained clinical and laboratory personnel to make a definite diagnosis. There is still a high cost of fungal diagnostics. And even with the availability of fungal diagnostics, we still don't have itraconazole, which is the first line for treatment of CPA. Major recommendations from this work is we need to advocate for among physicians to increase the index of clinical suspicion. And then since CPA complicates TB treatment outcomes, we need to advocate for CPA diagnosis to be added to the national TB program and probably also the advanced HIV disease program so that we can screen routinely for early detection and anti-TB stewardship. We also need to advocate for the national TB program to add the Aspergillus point of care test for the diagnosis of CPA, especially among those who have smear negative TB and post-TB lung disease. But it can also be added at the point when we do the initial gene expert for TB. We also need to advocate for itraconazole to be added to our essential drugs list so that we can manage those we diagnose. So we've been able to safely discontinue anti-TB medications in patients with negative TB workup who met the diagnostic criteria for CPA. And then we commenced these ones on antifungal therapy with an overall good outcome. So if you're a clinician in a TB clinic and you have this patient who was previously treated for TB and is now symptomatic with negative smear or negative gene expert, think about chronic pulmonary aspergillosis. Thank you.
Thank you so much, Dr. Kwizera, for the presentation. I now hand over back to the chair of the session. Thank you.
Thank you, Dr. Luze. It's not a very common practice for people to hand chairs back in this nation, but thank you for doing that. And we now reach the point of question and answer, and I would like to give the first opportunity to the members online. The members online, so please, I hope you specified the question and who the person, who of the presenters it is addressed to.
So the presenters online, we have one to Dr. Baluku. Thank you, Dr. Baluku, for your presentation. My question is, what modifiable factors did you find different from other studies that have been done? And what can we do to modify or improve patient survival? The second question is also to you, Dr. Baluku. Excellent study on TB mortality. As you have truly suggested, I would love to see if we see the same results when we do a similar study in other regions, especially the eastern and northern region, to elicit common factors associated to mortality and time to mortality. I think this was just a comment. So far, that's what we have online. We'll keep looking out for other questions online.
I think the comment is very interesting. I think we need to replicate these findings. We need to study it among people with HIV, among people with drug-resistant TB and other comorbidities, to really have a holistic picture as a nation. Where are our people whom we have cured? Particularly, I'm interested in people who probably had clinically diagnosed TB or extrapulmonary TB. We know that these individuals are more likely to have worse outcomes, actually, than people who were cured. So it will be interesting to investigate that further. As I presented, we identified unemployment as a risk factor for mortality, and therefore we need social protection measures, whether this is health insurance, employment insurance, whether they are cash transfer programs. We need these to help people when they survive TB to get back to their feet. Hospitalization is a risk for mortality. In other words, when you diagnose someone and they are critically ill and you hospitalize them, please do not assume that all is well when you achieve cure. It's important that we follow up these individuals. Hopefully we can identify other complications that develop along the way.
Okay, now we are going to go to the question session for the participants in the room. But before we start, ladies and gentlemen, allow me to recognize the presence of, to acknowledge one of our presenters in our session. That is Dr. Chintu Mwanje, for having made such a presentation when he's still an active intern. I think he deserves a lot of applaud. I do think myself, I think that we are looking at a very potential great researcher for this country. Not many of us doctors here we agree with him that by the time we are interns, we would make such a presentation with such a confidence. Dr. Mwanje, we wish you the best. Keep rising.
Can I ask my questions? Yeah, thank you very much, Chair, and the presenters for the excellent presentations. Just quick questions. One goes to Frida. Thank you for the presentation. I would like to know what your interpretation of the consistently low notification districts is. What is your interpretation of that over the period of time? And to Mercy, what lessons do you learn from what you've seen, and what do they mean to public health practitioners? Dr. Baluku, my question is clinical. When we discharge these patients, who are many, as you know, in Chirudu and elsewhere, what should we do differently as we follow them up during the 9 months and more? Thank you very much.
Any other? We need to take three questions at a time. Okay, Dr. Katamba.
Mine is not a question. Maybe you will take another 2 more. Mine is just to emphasize the point. The issue of Dr. Baluku's question or study, it is clear that it's very important, and probably we all only know data from Masaka where he did the study. The suggestion that he does a national-wide study is important, and I think these are some of the questions which could be taken on by operational research in the Smart for TB intervention, so that at least we have issues which are appropriate for the country but covered. This can be done with small resources, because it is really data already exists in different areas and we just need to follow up. So probably we should not leave it here, but I think this is something that I would think is very relevant to Smart for TB question that could help the country to think for.
Thank you, Dr. Chiris. I think, Dr. Baluku, you got the idea. I know very well that Dr. Chiris Katamba and Moses Joloba are co-investigators on Smart for TB. So you can actually do a direct link after this presentation.
Yes, thank you very much. My question goes to Jeff. You indicated that 30% of the cases had a household contact, and I think that has been published and probably informing the paradigm shift of contact tracing. So in this study, did you identify other scenarios, for lack of a better word, beyond the household where transmission is occurring in Karamoja? And then also clarify on your recommendation for SOS in the context of your study. Thank you.
So I think we can continue with the responses. So over to you, Geoffrey.
Yes, so thank you, Dr. Maureen. In context for SOS, from the national database, we have 16% of the pediatrics who are in maybe stool providing age. So in context to this study, there's an age bracket of meaning from this setting, 17%, the 6 to 14 years, we think they should be eligible to provide a stool. So that's where I was making that recommendation. Thank you.
Any more questions?
Yes, I had a question. Thank you very much for the wonderful presentations, as has been mentioned by other colleagues. I just had one question for Joseph and I think Chintu, just a clarification on how they defined cure, bearing in mind that this is a retrospective study for for Joseph. I just wanted to clarify how they defined cure.
Thank you very much. So what we considered cure was lack of microbiological evidence of existing pulmonary TB disease in these patients at 6 months because this has only drug-susceptible TB. Thank you.
Thank you so much for your question. Well, using retrospective data involves a lot of speculation, and that is one of the challenges that we had when we looked at the trends in the different regions in the country. But I could say that when we analyze the data that we receive weekly from the different districts in the country, we usually find that most of the districts, not most, but some of the districts in the eastern region normally have low reporting rates. So we cannot know for sure if it is a low, maybe we are having few TB cases in that region, or it's simply lack of reporting. I cannot say for sure, but it would be good to find out. Thank you.
Okay, thank you. My question was, what lessons have we learned and what are the implications of this for public health practice? I think the lessons we learned that this innovative approach of TB screening at points of entry has provided an opportunity to find cases that wouldn't have been found in the conventional health facility setting, which provides an opportunity for getting more cases. However, we note that there are gaps in testing and linking to care, and this creates a need for strengthening access to and laboratory services at the points of entry, and also developing innovative approaches for linking such mobile populations to care, because their needs are very different from other needs. Thank you.
Yes, Professor Semitala asked what should we do differently when we discharge people out of care. We know from studies elsewhere the leading causes of death of TB survivors are cardiovascular disease, closely followed by cancer and respiratory diseases thereafter. And so we can surveil for these diseases. There are ways to surveil for cardiovascular disease, there are ways to surveil for at least certain cancers. So we need to follow them up, and then you surveil for those potential causes of death. And then secondly, and linked to that, is we need to optimize the management of comorbidities. Now, from our analysis, from our study, we saw that people who had diabetes, who had high blood pressure, were more likely to die, although this was not statistically significant at multivariate analysis. But this tells you that having a comorbidity increases your risk of death, and therefore if you are out there not integrated in care, no one is optimizing your comorbidity. So we need to integrate, like I know Professor Semitala is doing some work in integrating comorbidities in HIV care. We need to do the same probably with our people who are surviving TB. I appreciate Professor Katamba's comment for a need of a national survey among TB survivors, and I'm committing to become your friend here after, such that we can advance this work.
We have a hand there. Somebody was helping us with the microphone in the audience. Right here, the front table. Thank you.
Thank you so much, Chair, for giving me the opportunity. And I want to appreciate all the presenters. Mine is just a comment, not a question. I just want to supplement on a question which was asked to Jeff, because I was among, he mentioned that WHO gave financial support, but I want to correct that it was not only financial support, it was both technical and financial. So Maureen was concerned about SOS and what is so different with the contact. The survey, maybe Jeff didn't specify, was done in 2 districts of Napaka and Moroto, which had the highest pediatric TB cases by then. And if you look at the slide, a general bacteriological confirmation was less than 50%. But given the fact that the highest number were children, it was very critical to quickly think of how best we could improve bacteriological confirmation among pediatric TB cases. And now the SOS came in, using stool to diagnose TB in children. And immediately after that survey, it was followed by a training of health workers. I think in the next summit, we will be able to review the outcome of that. Now, when it comes to contacts, there are 2 lessons we need to learn from here. One, the vulnerability aspect. These households which had those high rates of TB transmission among contacts, they were also severely vulnerable. And the second lesson we could learn from this is the uptake of TPT. You noted that during that period, TPT uptake was very low, but the beauty is whoever had a history of taking TB preventive therapy did not have TB. So this means that actual TB preventive therapy works. And if we could put more efforts on TB preventive therapy, plus also addressing the other vulnerabilities, we could be able to reduce or even end TB in Karamoja and in the country as a whole. Thank you.
So on behalf of the presenter, one more question, Professor Bruce. I almost closed the session.
No. I just wanted, I had left it, but this is to Mercy. You had a problem of testing the samples. You are testing only 60%, but also I think your presumption rate is very high. 30% presumption rate. Yeah? I like numbers, they're in my head. You tested about 100,000 people and ended up with 33 presumption. So from best practice, it is very good, but probably you need to think how the presumption can be improved. So you have, you get the people who should be receiving the test. Thank you.
Colleagues, thank you very much. Round of applause to the presenters. Thank you very much. I also like to thank my co-chair for this session. So our session is closed. Looking forward to the next session. Dr. Ali, over to you.
Thank you very much, Prof. and Dr. Luze, for chairing that session. Wonderful presenters for sharing your findings and implications to the NTP. I think we can all agree it's been very informative. The questions were very engaging, both online and here. Without further ado, I'd like to invite Dr. Prosina Mwenge and Dr. Evelyn Tibananuka. And as they come, Moses, we just need to get our blood flowing so that we can go through the next session. So Moses, please come up. He's going to give us a 1-minute energizer. You know you're going to stand, so we can stand. Just a slight change in the program. We're going to have we have poster pictures, and the posters from session 1 will be presented with the posters from session 2, so that we can go on to session 2. Yeah, so Moses.
I know we are hungry, but we are going to expel one aspergilloma from the lower lobe. So everybody, you stand up and I show you how we are going to expel it. Okay, so you're going to breathe in until the aspergilloma exits from the lower lobe, okay? So take a deep breath. Hold it. Now exhale through your mouth. Okay? You should feel something in the lower lobes. Okay? One more time. In. Hold. Out slowly through the mouth. You feel good, right? Over to you.
Dr. Evelyn and Dr. Percy, you can take us through the next session. Thank you. And thank you, Moses.
Good afternoon, everyone. I am Proscovia Namuwenge, privileged to be chairing this session with my co-chair, Dr. Evelyn Tibananuka. So for this session, we have about 7 presenters. We will have Dr. Fred Semitala and Dr. Andrew Kazibwe, Crispus Mbaha, Leus Twena Twine, Dr. Irene Mbabazi, and Dr. Achilles Katamba. I'll request the presenters to come forward and take your seats. We are going to have a slight change in this session. The first presentation, which was supposed to be presented by Professor Noah Chiwanuka, will be shifted to the end because another presenter, Chris Warren from Atlanta, is the one going to be presenting it. So it will be done last. So this session is mainly focusing on TB preventive treatment. And as we all know, this is a very important intervention in the control of TB in our country, which is a high burden country. So the first session we are going to, or the first presentation we are going to listen to is that by Dr. Fred Semitala, the TB preventive therapy cascade of care among people with HIV undergoing systematic TB screening in Uganda. Dr. Fred Semitala is a senior lecturer and deputy director of postgraduate studies and internal medicine. He is the executive director for Makerere University Joint AIDS Program, and his research interests are implementation science, HIV, TB, and other HIV-related comorbidities. Welcome, Dr. Semitala.
Thank you, Dr. Namuwenge. Yeah, thank you, the organizers, for this excellent conference. And I'm happy to talk after they have emphasized the need for TB preventive therapy. The presentation I'm making on behalf of our team is part of an ongoing study, which is an implementation trial evaluating the best ways to identify people who need TB preventive therapy. As a background, my sight is not so good, so I can't easily see what is there, so I will use this. That TB preventive therapy uptake and completion among people with HIV has been poor. And to evidence that, by the end of 2021, only about 41% of all eligible people were getting their treatment and completing it. Therefore, systematic screening is intended to improve uptake of TB preventive therapy, and available short courses of TB preventive therapy makes it easier. As part of an ongoing trial for this part of the presentation,
we wanted to evaluate the 3HP cascade of care among adults with HIV in Uganda who screened negative for active TB disease. And we wanted to determine the cumulative proportion of people with HIV initiating and completing 3HP. We also wanted to identify the gaps that exist within the cascade and the major causes for attrition from the TB preventive cascade. In terms of the methods, at baseline we screened these patients for TB, and those who were negative were initiated on antiretroviral therapy. And at the time of being initiated, I must say that we did this at the time when they came into the clinic. So at the time of initiating ART, we also assessed them for eligibility for 3HP. We also conducted or tested them for pregnancy and also evaluated them for liver injury using AST and ALT. And patients were reviewed after 2 weeks. The idea was to reduce the time to initiate 3HP from the regular 3 months recommended to as soon as practical, but in a safe manner. And so when patients returned, these patients returned for care in 2 weeks. They were assessed on how they were doing with their antiretroviral therapy, and also, again, underwent screen for TB. At that time, if they didn't have any evidence of TB or if they needed further evaluation, they were sent to the providers, and subsequently they were started on 3HP. That's if the liver enzymes were not elevated, they were not pregnant, and did not have any ART-related complications. So what did we see? During that period, a total number of 846 individuals were screened negative for TB. And of these, 643 were assessed for 3HP eligibility. And out of those, I think the numbers are visible there. You can see that there is a progressive drop from assessment to eligibility, and we can see that the largest gap drop was between assessment for 3HP eligibility and those who were actually eligible to initiate. And the smallest was from initiated to completed treatment. So what we see is that the cumulative proportion that initiated 3HP was 64%, and the cumulative proportion that completed TB were 60%. So the other objective was to assess the reasons for ineligibility. And from that flow chart, you can see that the majority of the patients were ineligible because at the time they were being assessed, they were pregnant. And others are also pregnancy-related issues. However, it's important also to note that some of our patients have a heavy alcohol use. And I think Dr. Valuku mentioned that a typical person with TB often is taking quite a bit of alcohol. The other important issue that we need to think about, which we don't routinely do in many of our facilities, is looking for liver injury, which is not very common, but at least 2% of the patients were not started on 3HP because they had evidence of liver injury. So in conclusion, cumulative 3HP completion rate was high at 60% among the screen-negative adults. And among those who initiated 3HP, actually 94% completed, as emphasized by the representative from the WHO. However, 1 in 4 screen-negative people were ineligible for 3HP, and the common reasons were pregnancy and elevated liver enzymes, as I mentioned. So in addition to systematic screening, rigorous 3HP eligibility assessment and pregnancy safe TPT regimens will be critical for scale-up. I know that now we no longer stop women from taking TPT because they are pregnant, but those were the guidelines in place at the time we conducted this study. Thank you very much. I would like to appreciate that whole group and entities that have made this study possible. Thank you very much for listening.
Thank you very much, Dr. Semitala. Next, we are going to listen in to Dr. Andrew Kazibwe, who is going to present on the incidence of TB among people living with HIV on ART, who initiated IPT, a multi-center retrospective cohort study. Dr. Kazibwe is a principal technical advisor at the AIDS Support Organization. He is an internal medicine physician and public health practitioner with research interests which overlap on communicable and non-communicable diseases. He's previously worked with USAID Defeat TB and currently supports TASO community team of the USAID LPHS TB activity. Dr. Kazibwe, you have 6 minutes.
Sure, thank you very much, Chair, and a very good afternoon to you all. I'll be sharing findings from a study we conducted among clients attending TASO centers, and we looked at the incidence of tuberculosis among PLHIV on antiretroviral therapy who initiated IPT. By then we were calling it IPT. It was only isoniazid preventive therapy, and we didn't have many options at the time. So previous presenters have shown us the danger of not preventing tuberculosis and sometimes even the futility of treating it too late. And at the time we conducted this study, we understood that people living with HIV had higher risks of contracting TB disease, but also had poorer outcomes. But we also noted that despite evidence from other countries that some individuals might actually need repeat doses of TB preventive therapy, and some might actually need longer durations of TB preventive therapy. As a country, we still recommended a one-size-fits-all. Once you've had your dose of TPT, that is it, we assume that you're protected. But we conducted this study to establish whether some individuals still go ahead to develop TB disease even after they've had exposure to isoniazid preventive therapy. And unlike what our colleagues from Karamoja found, in our study we found that actually indeed some individuals develop TB disease when they've already had exposure to preventive therapy. So we conducted a retrospective cohort study, and this was involving 2,634 participants. So we used retrospective chart review with all its limitations and an electronic questionnaire to abstract the data from the patient charts. And we used Stata version 16 to analyze the data, and the study was ethically approved. So in the results, next slide please. So our study participant characteristics, majority were female. Nearly 2/3 of them were female, and we had about 1/3 who were less than 15 years of age. All of them were HIV positive, and about a quarter of them had a CD4 less than 200 at baseline. And at the time of enrollment in isoniazid preventive therapy, about 4 out of 10 had detectable viral loads at a threshold of 200, and about 2/3 had been on ART for at least 36 months, that's 3 years. So in our cohort, the completion rate of TB preventive therapy was high at about 93%. And out of the 2,634, only 22 were diagnosed with tuberculosis, a cumulative incidence rate of about 0.83%. And this showed that individuals who initiate IPT might actually, yes, be protected from tuberculosis because this is lower than what we would have expected without IPT. But we found that these 22 who caught TB even after exposure to IPT did so within a median of about 19 months. That's about 1.5 years. And the factors that were associated were a baseline WHO clinical stage 3. And in our clinics, the commonest defining illness for clinical stage 3 was oral thrush. But also those who stopped TPT had higher risk of developing tuberculosis disease. We also noted that the incidence rate was higher among males than females, and we are doing additional analysis on our data set, and we found that the mean viral load was lower after TPT completion. So if we compared viral loads for those who had their viral loads done before TPT compared to after TPT, the viral load was lower, and we will be discussing in our future presentations the implications of these. So to the next slide. So the implications for the national TB response is that TPT is most effective when completed. And so we need interventions, we need to strengthen interventions that improve TPT adherence. So the national rollout of 3HP to shorten the duration of TPT is a very welcome intervention, but also adherence support for individuals who initiate TPT is equally important. And we also need to identify individuals who may still be at risk of contracting TB despite completing or initiating TPT. And from what we see, those are individuals who have a baseline WHO clinical stage of 3. And we know that with further study, we might identify additional characteristics of individuals who might benefit from repeat TPT dosing or even longer duration of TPT. And the next slide, I acknowledge. Oh, yes, the next slide is the action photo. So here we display the survival graphs for the individuals, and we did control for some of the characteristics like clustering, because we had our participants coming from across the country, 11 centers, but still, even with those controls, we still had the WHO clinical stage and TPT outcome, very important predictors of TB disease after TPT initiation. So thank you very much to the co-authors, to the Ministry of Health, and to all the partners that support the TASO centers across the country. Thank you very much.
Thank you very much, Dr. Andrew Kazibwe. Next, we are going to listen in to Crispus Mbaha from Uganda Hospital. Crispus is a clinician from working with Uganda Hospital. He is a district TB mentor, and he is the district clinician lead. Over to you, Crispus. You have 6 minutes.
Thank you. Ladies and gentlemen, good afternoon. Welcome to this time when you're going to listen in from me, as earlier introduced. I'm focusing on leveraging the TPT campaign to optimize TB case detection rates in Iganga district. And in this presentation, we are going to look at how we utilized the resources which were geared towards TB prevention to also improve case identification within the district. Uganda is a high burden TB country and with an estimated incidence rate of 200 per 1,000 population and a mortality rate of 35 per 100,000 population. Ministry of Health under the National Strategic Plan 2021 to 2025 recommends community case finding approaches as a very effective intervention at increasing TB case detection as well as prevention. Walimu in 2023 rolled out the Expand TPT study in Uganda district as an approach to preventing the transmission to active TB disease for people with latent TB infection among all the PBCs as an approach to ending TB in the district by 2025. And by March 2023, Uganda district posted a suboptimal performance in case identification as opposed to the annual target, and which was at about 44%. Sorry about that. We had 3 facilities in the district that were selected to participate in this study, and these were Bugono Health Center 4, Iganga Municipal Council Health Center 3, and Namungalwe Health Center 3. A total of 6 staffs, evenly distributed as health workers, community health workers or volunteers, and then community riders, were trained for 5 days at each of these facilities with focus on TB case, with focus on TB contact tracing and TPT eligibility. Data clerks were reoriented on TB indicators and allocated MyFiles to capture weekly surveillance data and monthly data and also the quarterly reports. Contacts of all PBCs were line listed at identification of the index case, and visits were conducted at the community level to reach out to them. All the presumptive contacts of these index cases had their samples picked off at community level and brought to the different gene expert sites for testing, while the non-presumptives were issued with TPT. Our key findings, we have a table which is showing our annual target, the district annual target, and the district performance over the months. We also have data for these pilot sites and their contribution towards the district target. We see that as of March 2023, our percentage was 52%. And we see by that time, these 3 pilot sites were contributing averagely at 28%. But when this study came in, beginning from around late May and early June, we see the districts contributing significantly at an increased rate of about 32%, and this is maintained over the month until when we see the district surpassing its annual target by September 2023, and that was 126% achievement. Implications for the NTLP program, we are saying that community TPT campaigns or contact tracing provides an opportunity to reach out to the inaccessible populations with TB screening interventions and diagnostic interventions, hence contributing to the global plan of ending TB by 2030 through early diagnosis and case notification. I therefore want to acknowledge all the following people for the support towards coming up with this. Thank you. Over to you, Chair.
Thank you very much, Crispus, for that. I will now hand over to my co-chair to invite the next presenters and also handle the Q&A session.
Thank you so much, Chair, for giving me the opportunity to co-chair with you. and also for not taking over throughout. For the interest of time, I will not reintroduce myself because I was introduced already by the chair. Allow me call Leos Tumwine. Leos Tuenatwine is going to present improving TPT uptake among children contacts above 5 years through intensified healthcare-led community initiative of TPT. He's a medical doctor working with, and apologies for not addressing you as a doctor. I was told doctors, they are not called Isa or Madam, so you address them. So doctor is a medical doctor working with USAID LPHS TB activity as an urban TB service coordinator, collaboratively working with other stakeholders and partners to oversee TB management in the focus districts of Kampala, Wakiso, and Mukono. Over to you, Doctor.
Thank you very much, and apology accepted. So I'll be sharing improving tuberculosis preventive treatment uptake, focusing on TB contacts 5 years and older through an intensified health worker-led community initiation of TPT. And like earlier introduced, I'll focus on the Kampala metropolitan area. That's Kampala, Wakiso, and Mukono, abbreviated as KMW. Yeah, so globally, TPT is recognized as strategy for preventing TB disease. However, the implementation of TPT remains suboptimal at about 52% globally among all eligible, that's PLHIVs and contacts, and TB contacts. Despite its effectiveness and affordability and accessibility, TPT coverage in Uganda among PLHIVs is about 90%. However, for TB cross contacts, it remains very low at 39%. In October-December 2022, close to half of the TB contacts 5 years and older in Kampala Mukono had missed TB preventive treatment. So we share lessons learned from improved TPT coverage in the focus districts of Kampala and Mukono. So in collaboration with district health teams and other partners, the USAID LPHS TB activity was able to support the process of line listing all PBCs who had missed opportunities for contact tracing or TPT initiation in the period Jan 2022 and March 2023. Community health workers were then identified based on these line lists where most of the PBCs were coming from, and they were oriented. So an extended contact screening approach, reaching out to neighbors, workplace, social and home contacts was utilized, and then health workers were engaged to assess these identified contacts, presume to have TB, initiation of TPT and TB treatment at the community level. So these are the key findings or the results. We can see around October, December, about 50% of those eligible only accessed TB preventive treatment. But with the intervention of engaging health workers to initiate TPT at community level, one, we saw the people eligible increasing. That's because the extended contact tracing approach was utilized looking at contacts beyond the household, to include neighbors, workplace and social contacts, but also the coverage and uptake of TBT among contacts are also improving to about 77% in the 3 months. So the implications for the national TB and leprosy response is that one, intensified TB contact screening and community initiation of TPT can help address missed opportunities for initiating TPT among TB close contacts. And then partnership and collaboration during this activity is crucial as it addresses and it brings in a structured approach to addressing missed opportunities. That's an action photo of the health workers doing the TPT initiation and presumption at community level. I would like to appreciate and recognize all the partners. Thank you.
Thank you so much. The next presenter is Dr. Irene Mbabazi. Dr. Irene Mbabazi is going to present about the adverse reactions to 3HP during the programmatic rollout of TPT in Uganda. She's a medical doctor at the Infectious Diseases Institute. She's also a study coordinator for Pandora 3HP study and a master's student of public health at the University of Manchester. You have 6 minutes. Over to you.
Thank you very much. Good afternoon, everyone. So I'm going to present preliminary findings of an ongoing study at IDI, adverse drug reactions related to 3HP during the programmatic rollout of TPT in Uganda. So this study started at a time when 3HP was being rolled out nationally, so I think it was very timely. So 3HP is a rifampicin isoniazid. It's a combination taken once weekly for 12 weeks or 3 months. So compared to the previous regimens that were existing, like the 6 monthly isoniazid taken daily, this is a shorter regimen. And previous studies have showed that it has increased uptake of TPT by almost half. So this is very good towards completing TPT and achieving the NTB goals, the WHO goals by 2035. So studies that have been done have shown that 3HP is equally effective compared to the other regimens, and it has significantly fewer serious hepatotoxicity effects. So this study that we are doing aimed to describe the adverse events associated with 3HP and the completion rates of 3HP. We also aim to describe the pharmacokinetic and the pharmacogenomic determinants of adverse drug reactions related to 3HP and the efficacy of 3HP during the rollout. So for this presentation, I'll be focusing on our first objective. So this is an observational study. It's a prospective cohort study on people initiating 3HP. So we work within the facilities, the TB facilities at IDI and at different KCCA facilities. When the clinicians are starting the patients on TPT, they refer them to us after they have been initiated, and thereafter we initiate them on our study. So while on the study, we do follow up these participants at 2 weeks and then monthly for the 3 months while they are on the study. So for now, we have completed everyone on the study has completed the active phase of the treatment, which is the 3-month 3HP. So during the follow-ups, we do assess for adverse drug reactions that these participants report at every physical visit. And we also avail them with our phone contacts. So they do call us in case they experience any AEs, and we manage, but we also record these AEs, so to ensure that we've not missed out on any adverse events. So we assess the adverse events clinically, we do physical examinations and laboratory tests, in particular the ALT and total bilirubin. So we also assess for adverse events, for relatedness of these AEs, using the Naranja scoring assessment scale, and we grade them using the DAID score. So risk factors for adverse events for this particular presentation have been established using the modified Poisson regression models. So our key findings, median age is missing here, but it was 32 with an interquartile range of 26 to 42 years of age. So this study included, as the national guidelines state, children from 2 years of age and above. So I think this was a very important aspect, since most studies were actually didn't have data on the pediatric and adolescent population, which we did include in this study. 45.2% of the participants were male, so majority of our participants were female. 33% reported alcohol use and 6.9% reported substance use. 7.7% of our participants reported history of TB, and 67.9% were HIV positive. So the HIV negative participants were contacts of people that were confirmed to have pulmonary bacterial TB. So we did do contact tracing in collaboration with the NTLP to find out who are the people in the community who had latent TB. So we did the IGRA testing, and as you can see, 96.4% of the participants who we tested IGRA for were positive. So this 96 is not the entire study population, but only those who had an IGRA test done. And our outcomes, just like Dr. Semitala has presented in the first presentation, 94% of the participants there completed 3HP. So for us, 90.1% completed 3HP, 8.3% discontinued, 1.1 we had those were lost to follow-ups, and 1 participant died while on treatment. So this is only for the first 3 months of treatment, because the study is still ongoing. We are following up the participants for 2 years after completion of this treatment to assess for efficacy of the drug. So we fill in the TB intensified case finding form to see if they have any, if there are any that developed TB after completing TPT. Okay, so the adverse events that were reported. So here I'm going to present to you the top 10 AEs that we had. Flu-like syndrome, which was a combination of, we defined it as a combination of chills, malaise, headaches, joint pains. So that was the highest adverse event that we had reported, followed by drowsiness or dizziness. We had peripheral neuropathy, headaches, and then joint pains or musculoskeletal pains, nausea, abdominal pain, dermatitis, hypertension. We also had cases of hypertension and palpitations, and gastroenteritis. So from our table, from our analysis, the factors that were associated with which population of people were more likely to experience adverse events while taking 3HP. So the female gender, females were more likely to experience adverse events. And then we had older participants, that's people 55 years and above. And then people who reported neuropathy at baseline were also more likely to experience adverse events. So the other factors, BMI and HIV status, were not statistically significant. So overall, this regimen is well tolerated. About 82.3% of the adverse events were grade 1 and they did not stop people from continuing with a treatment and completing it. Females, as we've seen, are the older patients, and those with baseline neuropathy had an increased likelihood of experiencing AEs, and therefore these may require closer monitoring while on the drug. So currently we are still awaiting pharmacokinetics and pharmacogenomics data, which is still undergoing analysis. Yes, I want to acknowledge our investigators, Dr. Christine Sekaja, Dr. Stella, who is in the room, Dr. Stavia, and Dr. Maureen, who are in the room with us. We also acknowledge our study participants, the staff at the different health centers where we're working, and the NTLP program. And this study is being funded by the National Institutes of Health. Thank you.
Thank you so much. Allow me to call the next presenter, Dr. Achilles Katamba, who is a senior lecturer at Makerere University College of Health Science, focusing on the uptake of evidence-based interventions into policy and practice using implementing science research methodology. He's going to present to us the CHESS TB study, a cluster randomized trial of clinic-based versus hotspot-focused SCF and linkage to TPT.
Yeah,
6 minutes, over to you.
Thank you very much. Actually, I was going to ask it. It used to be 10, then 6, but I will try to work in 6. Yeah, so I want to just quickly maybe try to let people know how did we decide on clinic versus hotspot. In a study we did some time back in Kisugu and Wabigaro, we decided to go in 2 zones, in 2 parishes, Kisugu and Wabigaro, plus Yoka zone and Namuongo. And we went house to house, screening everybody for TB using Gene Expert. We could pick samples and send them to Mulago to National, and we screened using Gene Expert. During that time, when we went to households, we actually found that there are people you will never find at home. If you focus going on to households, there are people like us, healthcare workers, and many, they are never at home. The border riders and others. Then we also decided that we need to do a venue-based screening. We could talk with the community and identify either a church or a marketplace and put some music, either on a Saturday or a Sunday. Then we could screen people, 150 samples and that, and we send them for Gene Expert testing. So later on, we looked at the data within the clinic, and we looked at where do the notification come most from. Among these 2 parishes, which zones provide the highest number of notification based on routine data. We actually found out that 5 zones out of the zones in 2 parishes, 5 zones which could make up a population of 20% of the total population of the 2 parishes, which had the highest notification. When we went to screen in the community, door to door, they actually gave us almost 50% of the TB we screened. Meaning that if we use the notification data that we see, it can be very important to tell us where to go as hotspots. And we also asked people where do they want to be screened. During that time, we asked people, if you were screened for TB, where would you want to be screened? A number of people said they prefer to be screened at the healthcare facility. So based on that, we said we need to do another study. This had been a 4-year study funded by NIH. Then we went to another 5-year study, which led to using X-ray, clinic versus hotspot-based active case TB finding. So this time, there are already 3 interventions which are good. Expert, there's the chest X-ray using artificial intelligence, and there is the treatment for both active TB and TPT. So he said if we combine this in one intervention, what do we get? This is how we ended up with this study. Somehow, either the system is forcing the slides to go before me, I don't know. So now, in this study, these are really the objectives to compare the effectiveness of hotspot versus facility-based active case finding. Hotspots, we identify these hotspots with the district people. And we compare implementation and cost effectiveness of hotspot versus clinic-based to estimate the impact of active case finding and TB preventive therapy on time to diagnosis and population level data. So this is a study. The figures may not be very clear. I don't know if there's a point. Yeah, so in this study, if you look at the districts there, the study design, we had 12 districts. We invited these 12 districts to come into a randomization ceremony. We were going to work on in 8 districts to screen using our mobile X-ray. And they participated in deciding who should be in the intervention versus the control. So those are the 12 districts. And the people who chose agreed that they will be control. And the 8 agreed. So this study now started and has been going on with end 2027 and still going on in those districts. Mayuge, Uganda, Mukono, there are 12 districts where it's going on. And so in those districts, the individual level issues, every person will go and agree with the community where are we going to screen from. And the people are sent there. We screen using X-ray. Whoever is eligible is given an X-ray. If the X-ray is suggestive of presumptive TB, you are sent to, you take off sputum and sent to the facility which is nearby in the community, the government or private clinic that provides testing using GeneXpert. And then based on that, if you are negative, then you are screened using tuberculin skin test to see whether you have infection, and you are also referred for TB preventive therapy. And in addition to that, we are screening for other things because we found that this X-ray can screen for cardiomegaly, lung nodules, and other conditions. So we programmed it with the company which made it, and now we are screening for cardiomegaly, people who may not be already on, then screening for blood pressure and referring them to the facilities. If he has a lung nodule, he's advised to go for further investigation at the different centers like Lung Institute or somewhere to see whether this may not be lung cancer. So in those, the outcome really, we are trying to look at the number of residents initiating TB treatment for pulmonary TB, confirmed and relapse, and compare those hotspot and the clinic-based. So hotspot, we usually spend 4 months at every site. Like if you go right now, I think at Uganda Hospital, you will find outside the hospital a tent with people who have an X-ray, mobile X-ray. And so we take X-ray for all those who are eligible, who come to the clinic, irrespective of whether they have come for TB screening, because someone can have, he has come for family planning but has TB. So whoever is eligible is screened. And now I'm going to present the preliminary data for this work. So we have so far screened 51,000 people for TB and found 384 diagnosed with expert positive in the study in the first 24 months. So this is how we implement our community. We usually put our X-ray and put a tent, people consent and others, and then we move forward. So when we are doing this work, we realized that the cutoff which was prescribed by the company of 0.5 cutoff for people to have presumptive TB looked to be not very appropriate. So we lowered it to 0.1, and actually we have found that the number of TB patients who, if you look at 0.5, you may miss a number of people. So we have put it to 0.1, and we are actually seeing that the cutoff for females and males may be different. And so we are trying also to understand that in terms of using this X-ray algorithm. We have had some challenges and key unknowns. Tuberculosis testing uptake and completion have been low. There is a need for affordable same-day tests. Really, we tell people to come back after this time. Some are not coming back. We are finding people. Need ways for identify and target high-risk individuals. What to do when abnormal X-rays aren't TB? Should sputum negative subclinical TB also be treated? Non-TB findings, EG heart disease, lung nodules. These are opportunities for further health impact to the community. Once detection is enabled, need to follow up and the follow mechanism. If you detect a lung nodule or you detect another condition, you need to follow up these people. Prevalence TB is heterogeneous, and some will resolve spontaneously. Would shorter or less intensive treatment regimen be sufficient for many? Could simple and cheaper tests find those who would benefit most from treatment? So we acknowledge a number of people, NTLP, Ministry of Health, and National Institutes of Health, who is funding this study. Thank you.
Thank you so much. Allow me return the microphone to the chair. Over to you.
Thank you very much, Dr. Evelyn, my co-chair. The next presenter is Chris Wallen. He's online. He's going to be presenting from Atlanta. Over to you, Chris. Chris, are you able to hear us? As we wait for him, maybe we can pick some questions. I'm not sure whether is somebody in communication with him. He's ready? Okay. So as we get in touch with Christopher Warren, let's probably pick questions from online. Are there questions online?
Maybe as we go through the questions online, allow me to make one or two comments. My main comment is going to go to the presenter who presented on the mortality among TPT people. Thank you so much, because in different forums, that is the question which has been coming up. What is the mortality rate? But
well, good afternoon, everybody. Thank you for inviting me to the meeting.
We are going to get you started.
Okay. Good afternoon, everybody. Thank you for inviting me to the meeting. Today I'm going to talk about tuberculosis transmission in Kampala and other African cities. The driving question behind our research is the following. Why does tuberculosis persist in regions around the world? Indeed, we do not understand well the mechanisms of M. tuberculosis transmission that result in new infection and the replacement of tuberculosis cases, especially in urban settings in Africa. Next slide. This has been a question that I have been studying along with my colleagues at Makerere University really since the 1990s. And I list here several of the slides. I will be talking about the household contact study of TB that was done from 1995 to 2012, and how the findings from that study led to the social network contact study of tuberculosis 2012 to 2018. If the IT can just press again. We're currently doing studies relating to the mapping of tuberculosis transmission around Kampala and how the mobility of TB cases affects transmission. Next slide. So this is the main results from our household contact study looking at household transmission. And we use the epidemiological measure secondary attack rate of TB disease that is, and we found overall that it was around 3%. It's important to note that in this instance, we were using genotyping to confirm that the index case and the co-prevalent case had identical strains. We did find that about approximately 30% of the time, the co-prevalent case did not match the index case, but this is corrected for them. We developed new methods to study the secondary attack rate for infection within the household and found it to be 47%. That means that the risk of acquiring new infection from living in the household of a tuberculosis case is about 50%. We then calculated the risk of primary progressive disease from the time of infection until disease occurs, and we found that to be 6.3% within a household. So very high risk of tuberculosis when newly infected in a household. And out of interest, we calculated the daily risk of disease or daily risk of infection given exposure within the household, and found that they were quite low. It's 0.03%. But for incident infection, it was just about 1% per day. So that gives us an idea of what the likelihood of transmission is per day from living in the home of a tuberculosis case, a little less than 1%. Next slide. So the take-home from household contact studies were that the household is an environment for intense transmission of M. tuberculosis and occurrence of progressive primary disease. Although I didn't show the data, children and HIV seropositive contacts are at highest risk for disease, though not infection. Daily risk of infection in household exposure is between 0.7 and 2%. Next slide. We then conducted an analysis to ask to ask the question, how much transmission occurs outside the households of tuberculosis cases? And for this, we used the population attributable fraction, and we performed a study, a social network study, in which we measured the contacts, not only the household contacts, but the contacts that occur outside the household. And here, when we look at all contacts, the population attributable fraction was 11.1%. So what that means is that only 11% of infection in the community can be attributable to known contact within the social network of a TB case. Let me say that again. The probability of if you can go back, please. Can you go back one slide, please? Thank you. So just to interpret the population attributable fraction, only 11% of infection in a community can be attributed to exposure and infection to the known social network of a tuberculosis case. When we break that down, we see that it's within the household, 7% of infection is attributable to household transmission, and 3% is attributable to transmission within the social network outside the household. Next slide. We then developed the tuberculosis networks, in which we constructed networks in the following way. From left to right, at the center, we identified the TB case and asked the TB case to tell us who their contacts were. And those are the light green circles surrounding the center circle. We then asked the case and the individual's name to identify whom they know and whom they associate with, and we draw those links. And then to all the contacts of TB cases, we did exactly the same procedure. For each contact of a TB case, we asked who their contacts were and identified links between them. This is very similar to snowball sampling that some people may know about. It's also a similar process that was used for us to eliminate or eradicate smallpox using ring vaccination methods. This is a kind of ring sampling method. So this is how we constructed our social networks. And then as we constructed them, we found many, 123 cases, and we identified 124 controls. And we used artificial intelligence methods and machine learning methods to link together all of these individual networks. And next slide. We're missing the picture of the network. Well, none of my figures are showing up, or at least I don't see them on my presentation.
Christoph, I think the animation didn't work well, so you could just talk through what you're seeing on your side.
Okay. All right. And on my side, I do not see the network figure. Let's see. Would it be possible for me to share the screen from my computer?
Yes, please go ahead. I think you should be able to share now.
Okay. Are you able to see the figure?
Yes, we can.
Okay, good. So we use this method of identifying the index case and the contacts, connecting the contacts, and then connecting the contacts of the contacts, and some artificial intelligence methods to generate the social network in Lubaga Division in Kampala. And this network includes 11,000 individuals or nodes. There are 40,000 links between the nodes, and that gives an average degree or average number of links of 7 for each individual in the network. The network, although it looks very compact, there are actually very few links. The density of links is quite small. The path length, that is, if I take 2 people from the network, the path length is only 11, and the longest path is 33. So this is a moderately sized network in terms of how compact it is. It's highly clustered, and it's not all connected. Some of the different colors represent different portions of the network. We then study the various aspects of the network to understand how heterogeneous the network is. This is important because transmission of respiratory diseases will be greater in heterogeneous networks. And this is referred to as the degree distribution, which shows most people have just 3, 4, 5 contacts, but some people have as many as 90 or 100 contacts. When we log transform, we're able to see that the network actually is quite heterogeneous, both in terms of the length, the average path between any 2 individuals shown here, and the degree of clustering. The degree of clustering changes as the number of the level of clustering changes as the degree gets larger. And that's important for understanding how tuberculosis is transmitted in the community. We then used molecular epidemiology and found 14 clusters of tuberculosis cases where the whole genome sequence indicated that the clusters had fewer than 12 single nucleotide polymorphisms between them. And the clusters ranged from 2, size 2, that was the most frequent, to 3, 4, and 5. And from within these clusters, we were able to identify 30 pairs of individuals who had related strains. We then used the social network that we had measured to ask the question, how close were those 2 TB cases within the social network? We know that they transmitted to each other, so they had to be in the same place at the same time. But in the social network, how close were they? And what you can see is that the 30 pairs of TB cases, only 7 of them were close, and that's about 21%. The remainder of the pairs of TB cases were 7, 8, 9, 10 steps away, and in 12 of the pairs, we were unable to link the 2 individuals at all. So the takeaway message is that transmission of TB does occur in social networks of tuberculosis cases, and that's represented by these with a short path length. But the majority of transmission occurs between individuals with weaker ties or distant social connections, that's shown here. We then went on to do a Bayesian analysis to estimate the transmission networks in the social network. And using methods, we were able to identify 6 transmission clusters within the study participants. And then when we map where these individuals are located within the network, we see that they're pretty well distributed, and we did not find any clustering within the social network at all. There's a very small degree in transmission network and the degree in the social network, but it was not statistically significant. So from our takeaway message from the network transmission of TB in the community is that transmission of M. tuberculosis occurs within an unobserved contact network in the community, and that this network is made up of two subnetworks, a social network around index cases which are characterized by strong ties between the members, and an undefined network that is connected by weak ties between members, that is, in casual or incidental connections. Most of the transmission of tuberculosis occurs through these weak ties, and only about 20% of the transmission may be linked to the strong ties. And these findings have important implications for the use of contact investigation in Kampala and other African cities with endemic disease. And this is just a representation of the transmission overall, and what we envision the transmission in the social network as a relatively small portion of the transmission which happens in the larger contact network. So I have many, many people to thank, in particular Dr. Noah Kiwanuka, Moses Jaloba, and Sarah Zawango, and my colleagues here at the University of Georgia. Thank you very much. My apologies for the technical difficulties.
Thank you very much, Christopher, for that informative presentation, and we don't take for granted the effort you've put in to make sure you have this presentation through to us, considering the time difference. I will now invite questions. We'll take the first 3 questions, and depending on how much time we are left with, we may have to have other questions written down so that we can respond to them later. But now I'll give opportunity to 3 questions. Who is helping us move the mic? If you have a question, please raise your hand so that we can. Yes, please help us move the mic to Dr. Stavia. Any other one with a question? Yes, there is another hand there. So part 2. And Dr. Rose.
Thank you, Chair, and thank you, our presenters, for the nice pieces of work you have shared with us. This one is to Dr. Katamba Achiris, who presented about chest TB. My first question is on how you defined a TB hotspot in the communities. It would be good for us to know what criteria you used to identify a TB hotspot. And then number 2, from the data that you presented, we did not see the comorbidities that you were talking about, that the X-ray artificial intelligence is able to identify. It would be good for us to know how much of the other conditions you picked other than TB because of using it's called Cure, I think, the one we are using. For us in the program, we use CAD. We are trying to see how to move to the other side if the CAD does not improve to capture other conditions. So it would be good for us to understand what other conditions you picked. Then, Chris, thank you for the work you have done here in Kampala. My question is, would this, do you think this would be reproducible if we went for contacts beyond a city setting, or this is only applicable for those in cities? Thank you.
Yes, thank you very much for the presentation. I have two questions for Irene. Thank you, Irene. My first question is on the ADRs that you have listed. I just wanted to know whether there were any new adverse events that were previously not documented on 3HP that you were able to identify during the study. Related to that, I would have loved to see the grading for the adverse events. You mentioned about 80% were grade 1, meaning they were not so serious. But for the other events, maybe close to 20%, I think I would be very interested to know what they were and how you graded them. But also, lastly, is on the death. I think the co-chair asked about the death. Since this was an adverse event study, would like to know the cause of that mortality, that one death. What caused that death? To Dr. Fred, one question on the viral load being lower on the people who were on TPT. Very interesting. We want to know whether TPT contributes to some bit of suppression. Thank you so much.
Thank you, Pamela. I think your last question was to Dr. Andrew. He's the one who had presented that. Our final question from...
Thank you very much. Mine goes to Dr. Katamba. Thank you for the presentation. I'm also relating to the selection of hotspots, which you talked about, based on the numbers of TB patients in the registers. I just wonder whether you explored, some patients may not be able to reach the facilities for different reasons, and therefore they will not appear that much in the registers. Some of the issues could be like barriers, hard to reach areas, or underserved communities. And when we base our selection just on the numbers in the register, maybe we may be missing such communities, and they don't participate in this very important intervention. Thank you.
Thank you for the questions. I appreciate there are more questions, but because of time constraints, let's allow the presenters to respond.
It's good. I also had a question, but this was also to my teacher, Professor Chris Warren. This is more of looking at what are the implications for active case finding when you look at these social networks. How do we really use the social network to improve active case finding? I don't know whether Prof. Chris has heard me, but if he has not heard, Noah is here, whom they have been doing the study. Yeah. So then let me start responding also to my questions. There are three. It is about hotspots. How did we identify hotspots? Yes, the hotspots, first we collected data from all health facilities which probably are in that catchment area. And we captured data not only from this facility only, but in those. So data could tell us that in this zone called Butakabukirwa, or this zone, many cases are coming from there. That's data we had But however, this data from the registers, now we invited people from the districts. And these people from the districts, we did not present them what we thought were hotspots. We started brainstorming of what they think are hotspots. And they give you different views that, you know, some of this area, when we went in cast, we found many cases, though it does not appear in the hotspots. So people had various reasons. And then even part of the reasons they had was also a number of cases are coming from this community. So we aligned all those reasons, and we also presented the data. And in that case, also, we decided saying in which parish, in what. So they listed a number of hotspots in each parish, zones, and others. And then finally, in that very meeting, we started ranking them together with them. If you were to look at, because we are thinking that every 4 months, we are able to screen like 10,000 or 15,000 people. Then we say, if we are to focus, all these are hotspots, let's rank them. Then the people rank them. And we agree, in terms of population, maybe these are the 5 or 6 where we are going to focus these 4 months, and we shall start elsewhere. So there was input beyond the data from the communities. And that was important because, as you said, barriers to reaching, CAST found many cases in certain areas where people didn't know because they are not coming. So that exercise, and when we go back to the district, that exercise is repeated. Now we were in one district, when we go back 4 months, because we shall be in every site a total of 12 months, like at Higanga Hospital, for example, we shall be there 4 months, then go away, come back another 4 months, a total. So whenever we go back either to the district, we have to reevaluate what were the hotspots. Hotspots last time may be different from hotspots. So we still invite the district leaders and other people to say where should we focus. And some of them have changed. So that's how the hotspot. On the issue of other conditions, thanks Assistant Commissioner, we have data. This is something that we did not start right in the beginning, but later on we realized that and we had to reprogram. We have data on what we have found, those nodules and other things, and we shall be presenting it. At least we have some data for those. I think those were the 2 questions.
Irene?
Thank you for the questions. I think I'll start with a question from the co-chair about the one death that was reported. So this was a young lady about 30 years old, and she was newly diagnosed with HIV and had been given ART for 3 months. She was then initiated on 3HP and referred to us. We enrolled her into the study and we gave her drugs. Saw her at a 2-week visit. She had no complaints. And then she came back for the month 1 visit, still no complaints. But then after that, we lost contact with her. So both the numbers, her number was off, the next of kin, the number was off, so we did do a locator tracing, and we found out where she was staying. She was working for someone, and the person told us she had left, and she didn't know where she had gone. So we kept trying, and about 2 months later, we were able to get in touch with a relative who told us she had passed on from Mbarara Regional Referral Hospital. So we were able to get in touch with a doctor at Mbarara who had managed her, and he informed us that she had come in with TB symptoms. They did take off samples and then started her on TB treatment, but then she passed on a week after starting anti-TBs. So we thought maybe it was TB iris. Yes. Then the other question about the adverse drug reactions. So most of the AEs that we recorded had actually been documented. But yes, we had some AEs like eating disorders. Some people reported increased appetite, while others were reporting reduction in appetite. And then we had a number of people reporting insomnia. They were not able to sleep well, while others were reporting oversleeping. So it was, yeah. And then the AEs, yeah, like I said, about 80% were grade 1, about 11% were grade 2, and then 8% were grade 3, and about 1.1% were grade 4. We assessed the grading using the DAID score, and we recorded 6 serious adverse events that were related to the drug.
Thank you, Irene. Andrew, I think you have one question. Kindly keep it short.
Thank you, Chair. And the question regarding the viral load pre-TPT and then post-TPT. Well, our hypothesis when we were looking at our data again was that probably administering TPT would worsen adherence to ART and probably result in worse viral load suppression for people living with HIV. But when we explored the data, we found the reverse, and we know that there are scientific mechanisms to explain this particular finding, and like I shared, we will be providing the details in our future presentations. Thank you, Chair.
Thank you very much, presenters, and everyone has asked questions. If you have more questions, kindly note them down and give them to the Secretariat so that the presenters can be able to respond at a later time. We've eaten into our lunch time, and I'm told they're about to take it away. So I have to end this session at this point. Thank you very much.
Thank you very much. We have lunch for 40 minutes, and we come back at 3:45. We will be running posters during the lunch break, so the posters will be playing on the screen. If you have some time, please sit in and listen. We have about 8 poster presentations to play during the lunch break.
Lunch is being served on ground level. When you reach there, there's a team of hotel staff ready to guide you to the restaurant. Please keep it short. Please keep it short. Thank you.
morning or good afternoon, wherever you are. Thank you for having me at the NTLP Summit to present our work on the incidence of acute kidney injury and associated mortality among individuals with drug-susceptible tuberculosis in Uganda. So, tuberculosis is associated with significant mortality and morbidity. However, its impact on kidney function is not well understood and has often been attributed to drugs used in the treatment of TB. Previous studies in this area have shown that the incidence of AKI among patients with TB ranges between 7 to 10%. In this study, we aim to assess the incidence of AKI in the immediate post-TB diagnosis period in Uganda, a TB HIV endemic country in sub-Saharan Africa. This is important because in our setting, due to limited resources, majority of our patients in hospitals with TB do not have kidney function monitored routinely. So, in methods, this is a prospective observational cohort study of adults with drug-susceptible TB enrolled at Masaka, Barara, and Kabale regional referral hospitals over a period of 1 year with no prior history of kidney disease and enrolled within 7 days of TB diagnosis. These 3 hospitals serve 12.5% of the Ugandan population. So our primary outcome was the incidence of AKI within 2 weeks of TB diagnosis. And we defined AKI as an increase in serum creatinine of 50% from baseline within 7 days. Our secondary outcomes were included predictors of AKI and its association with 30-day survival. In terms of results, we screened 345 adults with active TB at the 3 hospitals, and we present findings from data for 156 participants who were followed up to 30 days. So the median age of our participants was 39 years, and majority, 68.6%, were male, 49.4% were HIV positive, and 43 of these were on heart, but with 68.4% having CD4 less than 200 cells per cubic meter. The rest of the baseline characteristics were similar between the HIV and non-HIV groups. So for our primary outcome, we found an incidence of AKI in this cohort at 33.3%. 71% of these had stage 1 AKI. And for our secondary outcomes, having any degree of proteinuria or hematuria at enrollment was associated with higher odds of AKI. And AKI at day 7 was associated with 5.8 Good morning or good afternoon, wherever you are. Thank you for having me at the NTLP Summit to present our work on the incidence of acute kidney injury and associated mortality among individuals with drug-susceptible tuberculosis in Uganda. So, tuberculosis is associated with significant mortality and morbidity. However, its impact on kidney function is not well understood and has often been attributed to drugs used in the treatment of TB. Previous studies in this area have shown that the incidence of AKI among patients with TB ranges between 7 to 10%. In this study, we aim to assess the incidence of AKI in the immediate post-TB diagnosis period in Uganda, a TB HIV endemic country in sub-Saharan Africa. This is important because in our setting, due to limited resources, majority of our patients in hospitals with TB do not have kidney function monitored routinely. So in methods, this is a prospective observational cohort study of adults with drug-susceptible TB enrolled at Masaka, Barara and Kabale regional referral hospitals over a period of 1 year with no prior history of kidney disease and enrolled within 7 days of TB diagnosis. These 3 hospitals serve 12.5% of the Ugandan population. So our primary outcome was the incidence of AKI within 2 weeks of TB diagnosis. And we defined AKI as an increase in serum creatinine of 50% from baseline within 7 days. Our secondary outcomes were included predictors of AKI and its association with 30-day survival. In terms of results, we screened 345 adults with active TB at the 3 hospitals and represent findings from data for 156 participants who were followed up to 30 days. So the median age of our participants was 39 years and majority, 68.6%, were male, 49.4% were HIV positive, and 43 of these were on heart, but with 68.4% having CD4 less than 200 cells per cubic meter. The rest of the baseline characteristics were similar between the HIV and non-HIV groups. So for our primary outcome, we found an incidence of AKI in this cohort at 33.3%. 71% of these had stage 1 AKI. And for our secondary outcomes, having any degree of proteinuria or hematuria at enrollment was associated with higher odds of AKI. And AKI at day 7 was associated with 5.8 Good morning or good afternoon, wherever you are. Thank you for having me at the NTLP Summit to present our work on the incidence of acute kidney injury and associated mortality among individuals with drug-susceptible tuberculosis in Uganda. So, tuberculosis is associated with significant mortality and morbidity. However, its impact on kidney function is not well understood and has often been attributed to drugs used in the treatment of TB. Previous studies in this area have shown that the incidence of AKI among patients with TB ranges between 7 to 10%. In this study, we aim to assess the incidence of AKI in the immediate post-TB diagnosis period in Uganda, a TB HIV endemic country in sub-Saharan Africa. This is important because in our setting, due to limited resources, majority of our patients in hospitals with TB do not have kidney function monitored routinely. So in methods, this is a prospective observational cohort study of adults with drug-susceptible TB enrolled at Masaka, Barara and Kabale regional referral hospitals over a period of 1 year with no prior history of kidney disease and enrolled within 7 days of TB diagnosis. These 3 hospitals serve 12.5% of the Ugandan population. So our primary outcome was the incidence of AKI within 2 weeks of TB diagnosis. And we defined AKI as an increase in serum creatinine of 50% from baseline within 7 days. Our secondary outcomes were included predictors of AKI and its association with 30-day survival. In terms of results, we screened 345 adults with active TB at the 3 hospitals, and we present findings from data for 156 participants who were followed up to 30 days. So the median age of our participants was 39 years, and majority, 68.6%, were male. 49.4% were HIV positive, and 43 of these were on heart, but with 68.4% having CD4 less than 200 cells per cubic meter. The rest of the baseline characteristics were similar between the HIV and non-HIV groups. So for our primary outcome, we found an incidence of AKI in this cohort at 33.3%. 71% of these had stage 1 AKI. And for our secondary outcomes, having any degree of proteinuria or hematuria at enrollment was associated with higher odds of AKI. And AKI at day 7 was associated with 5.8 Good morning or good afternoon, wherever you are. Thank you for having me at the NTLP Summit to present our work on the incidence of acute kidney injury and associated mortality among individuals with drug-susceptible tuberculosis in Uganda. So, tuberculosis is associated with significant mortality and morbidity. However, its impact on kidney function is not well understood and has often been attributed to drugs used in the treatment of TB. Previous studies in this area have shown that the incidence of AKI among patients with TB ranges between 7 to 10%. In this study, we aim to assess the incidence of AKI in the immediate post-TB diagnosis period in Uganda, a TB HIV endemic country in sub-Saharan Africa. This is important because in our setting, due to limited resources, majority of our patients in hospitals with TB do not have kidney function monitored routinely. So in methods, this is a prospective observational cohort study of adults with drug-susceptible TB enrolled at Masaka, Mbarara and Kabale regional referral hospitals over a period of 1 year with no prior history of kidney disease and enrolled within 7 days of TB diagnosis. These 3 hospitals serve 12.5% of the Ugandan population. So our primary outcome was the incidence of AKI within 2 weeks of TB diagnosis. And we defined AKI as an increase in serum creatinine of 50% from baseline within 7 days. Our secondary outcomes were included predictors of AKI and its association with 30-day survival. In terms of results, we screened 345 adults with active TB at the 3 hospitals, and we present findings from data for 156 participants who were followed up to 30 days. So the median age of our participants was 39 years, and majority, 68.6%, were male, 49.4% were HIV positive, and 43 of these were on heart, but with 68.4% having CD4 less than 200 cells per cubic meter. The rest of the baseline characteristics were similar between the HIV and non-HIV groups. So for our primary outcome, we found an incidence of AKI in this cohort at 33.3%. 71% of these had stage 1 AKI. And for our secondary outcomes, having any degree of proteinuria or hematuria at enrollment was associated with higher odds of AKI. And AKI at day 7 was associated with 5.8 Good morning or good afternoon, wherever you are. Thank you for having me at the NTLP Summit to present our work on the incidence of acute kidney injury and associated mortality among individuals with drug-susceptible tuberculosis in Uganda. So, tuberculosis is associated with significant mortality and morbidity. However, its impact on kidney function is not well understood and has often been attributed to drugs used in the treatment of TB. Previous studies in this area have shown that the incidence of AKI among patients with TB ranges between 7 to 10%. In this study, we aim to assess the incidence of AKI in the immediate post-TB diagnosis period in Uganda, a TB HIV endemic country in sub-Saharan Africa. This is important because in our setting, due to limited resources, majority of our patients in hospitals with TB do not have kidney function monitored routinely. So in methods, this is a prospective observational cohort study of adults with drug-susceptible TB enrolled at Masaka, Barara and Kabale regional referral hospitals over a period of 1 year with no prior history of kidney disease and enrolled within 7 days of TB diagnosis. These 3 hospitals serve 12.5% of the Ugandan population. So our primary outcome was the incidence of AKI within 2 weeks of TB diagnosis. And we defined AKI as an increase in serum creatinine of 50% from baseline within 7 days. Our secondary outcomes were included predictors of AKI and its association with 30-day survival. In terms of results, we screened 345 adults with active TB at the 3 hospitals, and we present findings from data for 156 participants who were followed up to 30 days. So the median age of our participants was 39 years, and majority, 68.6%, were male, 49.4% were HIV positive, and 43 of these were on heart, but with 68.4% having CD4 less than 200 cells per cubic meter. The rest of the baseline characteristics were similar between the HIV and non-HIV groups. So for our primary outcome, we found an incidence of AKI in this cohort at 33.3%. 71% of these had stage 1 AKI. And for our secondary outcomes, having any degree of proteinuria or hematuria at enrollment was associated with higher odds of AKI. And AKI at day 7 was associated with 5.8 . Good morning or good afternoon, wherever you are. Thank you for having me at the NTLP Summit to present our work on the incidence of acute kidney injury and associated mortality among individuals with drug-susceptible tuberculosis in Uganda. So, tuberculosis is associated with significant mortality and morbidity. However, its impact on kidney function is not well understood and has often been attributed to drugs used in the treatment of TB. Previous studies in this area have shown that the incidence of AKI among patients with TB ranges between 7 to 10%. In this study, we aim to assess the incidence of AKI in the immediate post-TB diagnosis period in Uganda, a TB HIV endemic country in sub-Saharan Africa.
Hello everyone, my name is Ibrahim Sendagiri. I work with the Division of Intramural Research, National Institute of Allergy and Infectious Diseases, NIH. I am a medical research specialist. We would like to share with you some of our work. Incidence and risk factors of tuberculosis at a rural HIV clinic in Uganda. Tuberculosis is the leading cause of death among people living with HIV, and antiretroviral therapy has been documented to lower the risk of HIV-associated TB. Earlier studies have shown that the risk of HIV is very high in the first year of initiating ART. An earlier study in Uganda reported TB rates of 11.25, 6.27, and 2.47 per 100,000 years in 0 to 3 months, 3 to 6 months, and 6 to 12 months respectively. These studies were conducted in urban areas. A few studies have looked at TB incidence among this population in rural areas. We therefore conducted a retrospective cohort analysis to assess the TB incidence among the rural cohort population. Incidence TB disease was defined as occurrence of first-time TB as documented in the TB treatment register. TB incidence was calculated by dividing the number of cases per total follow-up time and expressed as 100 and estimated per 100,000 years. Exploratory variables were assessed in both variable and multivariable analysis by post-hoc regression at 5% significance to establish the factors that were associated with TB incidence. Now the results. Between 2012 and 2019, 2,580 patients were initiated on ART. 57% were female. Female were more likely to be less than 35 years, while males were more likely to be between 25 and 44 years. Of the 2,589 patients included in analysis, 87 females compared to 70 males were in the WHO clinical stage 1. There were 61 TB events in the 6,363 person-years of observation. Overall incidence of TB occurrence was 0.83 cases per 100 person-years. The incidence of TB disease before and after 6 months of ART was 3.3 and 0.58 per 100 person-years. We found that TB incidence continued to decrease over time. Our conclusion is incidence of TB among patients on ART is low in these rural cohorts. Increasing ART coverage among people living with HIV is a key strategy in lowering the burden of TB. Thank you very much.
I think we are not tapping enough out of this TB CAST program.
I'm wondering whether they have
translated materials that can be able to guide the audiences that is actually live TB free, not live TB free.
The number of clients we identify and reduce. You start them on treatment before you realize the next time you are going to check on them, they know where to see.
So we still have that challenge of these people to take this.
If you're having very good results, could it be expensive?
We are strengthening community disease surveillance on all the borders. We are not only targeting TB and leprosy, but we are all identifiable diseases.
Tuberculosis is a threat that continues to affect an estimated 10.6 million people around the world. TB takes a huge toll not only on the health of individuals, but on families. Joint action between affected communities and the health system are critical to bringing this ancient killer under control.
To end TB, meaningful community engagement is necessary to acknowledge the strength and the aspirations of the communities affected and infected with TB, and even TB survivors.
Harnessing the experience, skills, and insights of affected communities allows for better tailoring of programs and interventions, making them more community-centered and context-specific.
The most crucial step in an effective TB response is identifying who your community is, because they have the highest risk and are most vulnerable to TB, and because their voices and contributions can help cut the TB pandemic.
Meaningful engagement means that community members are valuable partners in the TB response. Decision making must include an informed member of the community who bring lived experience and reality to the table.
Meaningful engagement requires intentional, deliberate actions. It must be fostered and be included from planning throughout the national TB program cycle, including monitoring and evaluation. Creating or maintaining strong platforms and networks and coordination will be key.
The guidance is co-created with representatives of civil society, communities affected by TB, national TB programs, and other partners. It is a major tool that ministries of health, their national TB programs, NGOs, and other community groups can consult to harness the power of local communities to prevent, treat, and end tuberculosis wherever they are. Yes, we can end TB together.
Chimanyere nti, whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health. Chimanyere nti, whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health.
Good morning or good afternoon, wherever you are. Thank you for having me at the NTLP Summit to present our work on the incidence of acute kidney injury and associated mortality among individuals with drug-susceptible tuberculosis in Uganda. So, tuberculosis is associated with significant mortality and morbidity. However, its impact on kidney function is not well understood and has often been attributed to drugs used in the treatment of TB. Previous studies in this area have shown that the incidence of AKI among patients with TB ranges between 7 to 10%. In this study, we aim to assess the incidence of AKI in the immediate post-TB diagnosis period in Uganda, a TB/HIV endemic country in sub-Saharan Africa. This is important because in our setting, due to limited resources, majority of our patients in hospitals with TB do not have kidney function monitored routinely. So in methods, this is a prospective observational cohort study of adults with drug susceptible TB enrolled at Masaka, Barara and Kabale regional referral hospitals over a period of 1 year with no prior history of kidney disease and enrolled within 7 days of TB diagnosis. These 3 hospitals serve 12.5% of the Ugandan population. So our primary outcome was the incidence of AKI within 2 weeks of TB diagnosis. And we defined AKI as an increase in serum creatinine of 50% from baseline within 7 days. Our secondary outcomes were included predictors of AKI and its association with 30-day survival. In terms of results, we screened 345 adults with active TB at the 3 hospitals, and we present findings from data for 156 participants who were followed up to 30 days. So the median age of our participants was 39 years, and majority, 68.6%, were male. 49.4% were HIV positive, and 43 of these were on heart, but with 68.4% having CD4 less than 200 cells per cubic meter. The rest of the baseline characteristics were similar between the HIV and non-HIV groups. So for our primary outcome, we found an incidence of AKI in this cohort at 33.3%. 71% of these had stage 1 AKI. And for our secondary outcomes, having any degree of proteinuria or hematuria at enrollment was associated with higher odds of AKI. And AKI at day 7 was associated with 5.8.
Hello everyone, my name is Ibrahim. I work with the Division of Internal Research, National Institute of Allergy and Infectious Diseases, NIH. I am medical research specialist. If we would like to share with you some of our work, incidence and risk factors of tuberculosis at a low HIV clinic in Uganda. Tuberculosis is the leading cause of death among people living with HIV, and antiretroviral therapy has been documented to lower the risk of HIV-associated TB. Earlier studies have shown that the risk of HIV is very high in the first year of initiated ART. An earlier study in Uganda reported TB rates of 11.25, 6.27, and 2.47 per 100 person year in 0 to 3 months, 3 to 6 months, and 6 to 12 months respectively. These studies were conducted in urban areas. A few studies have looked at TB incidence among this population in rural areas. We therefore conducted a prospective cohort analysis to assess the TB incidence among the rural population. Incidence TB disease was defined as occurrence of first-time TB as documented in the TB treatment register. TB incidence was calculated by dividing the number of cases per total follow-up time and expressed as 100 and estimated per 100 person years. Exploratory variables were assessed in both variable and multivariable analysis by post-hoc regression at 5% significance to establish the factors that were associated with TB 57% were female. Female were more likely to be less than 35 years, while males were more likely to be between 25 and 44 years. Of the 2,589 patients included online, 37 females compared to 70 males were in the WHO clinical stage 1. There were 61 TB events in the 6,363 person-years of observation. Overall incidence of TB occurrence was 0.83 cases per 100 person-years. The incidence of TB disease before and after 6 months of LRG was 3.3 and 0.58 per 100 person-years. We found that TB incidence continued to decrease over time. Our conclusion is the incidence of TB among patients on LRT is low in these rural cohorts. Increasing LRT coverage among people living with HIV is a key strategy in lowering the burden of TB. Thank you very much.
I think we are not tapping enough out of this TB-CAST program.
I'm wondering whether they have translated materials that can be able to guide the audiences that is actually live TB-free, not live TB-free.
The number of clients we identify are reduced. There is no need to start them on treatment before you realize the next time you are going to check on them, tell me where it is.
So we still have that challenge of these people take this.
If you're having very good results, could it be extensive?
We are strengthening community disease surveillance on all the borders. We are not only targeting TB and leprosy, but we are all identifiable diseases.
Tuberculosis is a threat that continues to affect an estimated 10.6 million people around the world. TB takes a huge toll not only on the health of individuals, but on families, economies, and societies. Joint action between affected communities and the health system are critical to bringing this ancient killer under control.
To end TB, meaningful community engagement is necessary to acknowledge the strength and the aspirations of the communities affected and infected with TB, and even TB survivors.
Harnessing the experience, skills, and insights of affected communities allows for better tailoring of programs and interventions, making them more community-centered and context-specific.
The most crucial step in an effective TB response is identifying who your community is, because they have the highest risk and are most vulnerable to TB, and because their voices and contributions can help curb the TB pandemic.
Meaningful engagement means that community members are valuable partners in the TB response. Decision making must include an informed member of the community who bring lived experience and reality to the table.
Meaningful engagement requires intentional, deliberate actions. It must be costed and be included from planning throughout the national TB program cycle, including monitoring and evaluation. Creating or maintaining strong platforms and networks and coordination will be key.
The guidance is co-created with representatives of civil society, communities affected by TB, national TB programs, and other partners. It is a major tool that ministries of health, their national TB programs, NGOs, and other community groups can consult to harness the power of local communities to prevent, treat, and end tuberculosis wherever they are. Yes, we can end TB together.
Kimanye leero nti Whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health. Chimanye rero nti, whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health.
Good morning or good afternoon, wherever you are. Thank you for having me at the NTLP Summit to present our work on the incidence of acute kidney injury and associated mortality among individuals with drug-susceptible tuberculosis in Uganda. So, tuberculosis is associated with significant mortality and morbidity. However, its impact on kidney function is not well understood and has often been attributed to drugs used in the treatment of TB. Previous studies in this area have shown that the incidence of AKI among patients with TB ranges between 7 to 10%. In this study, we aim to assess the incidence of AKI in the immediate post-TB diagnosis period in Uganda, a TB HIV endemic country in sub-Saharan Africa. This is important because in our setting, due to limited resources, majority of our patients in hospitals with TB do not have kidney function monitored routinely. So, in methods, this is a prospective observational cohort study of adults with drug-susceptible TB enrolled at Masaka, Barara, and Kabale regional referral hospitals over a period of 1 year with no prior history of kidney disease and enrolled within 7 days of TB diagnosis. These 3 hospitals serve 12.5% of the Ugandan population. So our primary outcome was the incidence of AKI within 2 weeks of TB diagnosis. And we defined AKI as an increase in serum creatinine of 50% from baseline within 7 days. Our secondary outcomes were included predictors of AKI and its association with 30-day survival. In terms of results, we screened 345 adults with active TB at the 3 hospitals, and we present findings from data for 156 participants who were followed up to 30 days. So the median age of our participants was 39 years, and majority, 68.6%, were male, 49.4% were HIV positive, and 43 of these were on heart, but with 68.4% having CD4 less than 200 cells per cubic meter. The rest of the baseline characteristics were similar between the HIV and non-HIV groups. So for our primary outcome, we found an incidence of AKI in this cohort at 33.3%. 71% of these had stage 1 AKI. And for our secondary outcomes, having any degree of proteinuria or hematuria at enrollment was associated with higher odds of AKI. And AKI at day 7 was associated with 5.8.
Hello everyone, my name is Ibrahim. I work with the Division of Intramural Research, National Institute of Allergy and Infectious Diseases, NIH. I am medical research specialist. If we would like to share with you some of our work. Incidence and risk factors of tuberculosis at the Royal HIV Clinic in Uganda. Tuberculosis is the leading cause of death among people living with HIV, and antiretroviral therapy has been documented to lower the risk of HIV-associated TB. Earlier studies have shown that the risk of HIV is very high in the first year of initiating ART. The earlier study in Uganda reported TB rates of 11.25, 6.27, and 2.47 per 100,000 years in 0 to 3 months, 3 to 6 months, and 6 to 12 months respectively. These studies were conducted in urban areas. A few studies have looked at TB incidence among this population in rural areas. We therefore conducted a retrospective cohort analysis to help to assess the TB incidence among the rural cohort population. Incidence TB disease was defined as the occurrence of first-time TB as documented in the TB treatment register. TB incidence was calculated by dividing the number of cases per total follow-up time and expressed as 100 and expected per 100,000 years. Exploratory variables were consisting both in variable and multivariable analysis by postural regression at 5% significance to establish the factors that were associated with TB incidence. Now the results. Between 2012 and 2019, 2,580 patients were initiated on ART. 57% were female. Female were more likely to be less than 35 years, while males were more likely to be between 25 and 44 years. Of the 2,589 patients included in analysis, 87 females compared to 70 males were in the WHO clinical stage 1. There were 61 TB events in the 6,363 person years of observation. Overall incidence of TB occurrence was 0.83 cases per 100 person years. The incidence of TB disease before and after 6 months of ART was 3.3 and 0.58 per 100 person years. We found that TB incidence continued to decrease over time. Our conclusion is incidence of TB among patients on ART is low in this rural cohort. Increasing ART coverage among people living with HIV is a key strategy to lowering the burden of TB. Thank you very much.
I think we are not tapping enough out of this TB-cast program.
I'm wondering whether they have translated materials that can be able to guide the audiences that is actually live TB-free, not live TB-free.
The number of clients we identify and reduce. There is no, you start them with treatment before you realize the next time you are going to check on them, they know where it is.
So we still have that challenge of these people to take this.
If you're having very good results, could it be expensive?
We are strengthening community disease surveillance on all the borders. We are not only targeting TB and leprosy, but we are all identifying diseases.
Tuberculosis is a threat that continues to affect an estimated 10.6 million people around the world. TB takes a huge toll not only on the health of individuals, but on families, economies, and societies. Joint action between affected communities and the health system are critical to bringing this ancient killer under control.
To end TB, meaningful community engagement is necessary to acknowledge the strength and the aspirations.
Welcome back from lunch.
And infected with TB, and even TB.
We are going to begin our next session. And just a reminder to all presenters, let's try to keep time. You have 6 minutes, but if you can do it in 5, better still. But you have 6 minutes, so try to keep time. I'd like to invite our co-chair, Dr. Semitala Fred, And just to confirm if Dr. Nuwagaba Edwin is around. Yeah. So Dr. Fred?
Good afternoon. I hope you've all enjoyed the lunch like I did. And so we are going into our next session, and I'll be inviting the speakers shortly. Yes, I'm Fred Semitala. I work with the Department of Medicine, and I'm also the Executive Director for Makerere University Joint AIDS Program. The next session, which is session 3, is going to focus on TB and comorbidities that include mental health, post-TB lung disease, HIV, diabetes mellitus, as well as undernutrition. And to present in the next session, we have Dr. Joseph Baluku. Please come and join me. Dr. Lilian Tugume, Mr. Shafiq Makumbi, and we have Semwemba Haruna, and then we have Zuninga from United for Global Mental Health. Please come up here. In the interest of time, I will just call up the first presenter, and then, as we've done before, we will ask the questions at the end. We are going to use 6 minutes for each presenter. So, Dr. Joseph Baluku, you are welcome. You will briefly introduce yourself. I may not know all your... Please introduce yourself briefly and then present to us on the cardiovascular risk factors among people with drug-resistant TB in Uganda.
Good afternoon once again, colleagues. I am Joseph Baluku. I'm a research scientist at the Makerere University Lung Institute, but also a respiratory physician with Chirudu National Referral Hospital. I'm glad I'm speaking to you immediately after lunch, now that I'm talking about cardiovascular risk, because I know food is the leading cause of cardiovascular disease. So you will relate to this presentation. Now, in 6 minutes, I can tell you that TB is associated with cardiovascular disease at all stages. whether you have latent TB infection, whether you have active TB, whether you're a TB survivor, you are at risk of cardiovascular disease. We know that active TB increases your risk for stroke, myocardial infarction, DVT, and so on and so forth. And cardiovascular disease is the leading cause of death among TB survivors. And even that aside, almost all cardiovascular risk factors also worsen TB outcomes. We know that smoking, alcohol, diabetes, they worsen TB outcomes. There are studies from Guinea-Bissau that show that even hypertension worsens TB outcomes. So this should interest you. It might be that TB damages the heart directly. It might be that the inflammation that TB causes damages the blood vessels, or that TB affects the kidneys and therefore causing cardiovascular disease, or TB affects the metabolism of blood lipids and therefore causing atherosclerotic plaques to come up. So in this study, we were interested in determining the prevalence of traditional cardiovascular risk factors as I will define them. And what we did, this was a cross-sectional study at 4 sites, and that was to represent the 4 regions of the country. And we recruited people who had drug-resistant TB during their normal clinic days. We asked them for history of smoking. We measured their body mass index. We measured whether they had central obesity by measuring the waist circumference and hip waist ratio. We also measured their blood pressures taken 20 minutes apart. We also did HbA1c and random blood sugars and also measured their blood lipids. Now, believe it or not, 92% had at least one cardiovascular risk factor. 92%, 9 in 10. In other words, cardiovascular risk factors were almost universal. And for context, 56% of Ugandans have at least one cardiovascular risk factor. So you can see that this is almost double in people who have drug-resistant TB. The majority of them had at least 2. And these are young people who are aged 37. Now, to summarize for you, this is the most important slide. The commonest was altered lipid levels. 62% had dyslipidemia. Closely followed is elevated blood pressure. Closely followed is central obesity, smoking, high BMI, and diabetes mellitus. To give you the context, is that all these CVD risk factors were higher than what is reported in the general population in Uganda. We need to integrate NCDK and programmatic TB. In other words, we should not assume that people are getting treatment elsewhere and we go on business as usual. We need to integrate NCDK. We need to score cardiovascular risk. Might statins benefit people with TB? Maybe that's something we could do and study in randomized controlled trials. We also need to intentionally integrate alcohol and smoking cessation programs to hopefully alleviate the risk that these individuals have. I thank you very much, and I'll be glad to take your questions.
Thank you very much, Dr. Baluku, for the succinct presentation. Next to present is Mr. Shafiq Makumbi, who is a public health expert working with the Infectious Diseases Research Collaboration, IDRC, where he coordinates a study that will tell us about. Mr. Makumbi, you're welcome.
Thank you, Dr. Semitala. All right. Welcome, everyone, to the first session on diagnostics. And my talk is going to be about the yield and operational challenges of urine lung testing among outpatients, persons living with HIV, undergoing intensified case finding in Uganda, and was undertaken as part of a larger collaboration. So I'm just here to present on behalf of the larger team. So as an introduction, urine lung is a component of MTB cell wall. It can be detected in patients with TB from their urine. It has favorable operational test characteristics for use in highly endemic areas because the urine lung assay is point of care, it is cheap, and can give you quick results within 25 minutes as compared to methods like the microbiological, the expert text testing and culture. So in 2019, WHO expanded their indications for urine lung testing in the outpatient intestinal case finding to persons living with HIV with TB symptoms, irrespective of their CD4 count. The prior recommendation before that was that urine lung testing was restricted to only symptomatic patients with CD4 less than 100. So that expansion, with that expansion, comes negative and positive consequences. The most obvious positive consequence is that you have more patients who are going to start treatment on the same day, and therefore you reduce treatment delays, and that may improve patient outcomes. On the other hand, you may have more patients with misinterpreted, with false positive results, either misinterpreted or the false positives. So, in line with those, with that, we had two study objectives. One was to determine the lung agreement between expert versus trained readers and the proportion of lung tests that were reclassified by the expert. The second objective was to compare the diagnostic yield between the two screening algorithms. The prior algorithm, where LAM was indicated for only symptomatic patients with CD4 less than 100, compare that with the new algorithm, where LAM is indicated among symptomatic patients, irrespective of the CD4 cell count. So this study was undertaken within a larger study, TB script study, which is a phase 3 randomized control trial comparing to the impact of two WHO-supported TB screening strategies, that is the symptom screening and CRP, C-reactive protein screening. So our participants were recruited from our participants were new to HIV care, and recruited from 4 health centers in Kampala between November 2020 to January 2023. So for all participants at enrollment, we conducted CD4 testing and randomized them to either symptom screening or CRP-based screening. So additional confirmatory TB testing was performed among those who screened positive, that is using the urine lung, irrespective of CD4, and then also sputum expert, if indicated, that is maybe if they had indications for drug-resistant TB, and so on. So we compared the two algorithms. I've already talked about those algorithms, but that's the new algorithm where LAM can be performed irrespective of the CD4 cell count, versus the old algorithm where LAM is only restricted to symptomatic patients with CD4 count less than 100. So in terms of our study procedures for this analysis, so we had a team of trained nurses who performed the urine lung testing, and these were unblinded to the trial arms, so they knew which participant had symptom screening and which participants had CRP-based screening, and they did the urine lung testing following the manufacturer's instructions. So we had two study nurses interpret the lung, but a third person would come in to serve as a tiebreaker, but they were all using the same scale card. So along the way, we put up some additional QA activities where we took digital images of all LAM tests, and these were later reviewed by a TB expert, a microbiologist who is an expert in TB, reviewed the LAM tests and reclassified them, classified them according to the same manufacturer's instructions. And this expert was blinded to the prior prior trained nurse readers' interpretations. So just before I go into the slides, this is, you can see the urine lamb test, and you can see the difference. It's just, it looks just like any other, strip, the HIV strip, the determine strips, if you're already familiar with those. The only difference is with lamb interpretations, when you see a positive line, doesn't necessarily mean that that is a positive result. So the lamb interpretation is done alongside a reference card, a scale card that comes with the manufacturer in the insert. So lamb is supposed to be interpreted, the test is supposed to be interpreted against the scale card, and the scale card will tell you the grade. So they have to be of the same thickness for it to qualify as, for example, grade 4. So there's a line for grade 4 cleared on the scale card, and when you place your positive part, should be as thick as the scale card. If it's less, then it's not a grade 4. Maybe it's a grade 3, so you move to grade 3. If it matches with a grade 3 in terms of thickness, then that's a grade 3. If it's a grade 1, it has to be similarly, equally as thick as the line on the reference card. So that's where our problem comes in. So most of the time, people will interpret any line they see as a positive result. And for those who have worked with several clinics,
Shafiq, you have 2 minutes.
Oh, okay. So this is here our results. This is the table of results. The first part of the table shows you the agreement between the lamb readers and the trained readers. Generally, there was a slight agreement between the expert readers and the trained readers, with a kappa score of 0.38, which represents a slight agreement. There was a bias, and the bias was in the direction of the trained readers overestimating the urine lamb grades. So the trained readers were more likely to overestimate the urine lamb grades. And when the expert reader reviewed the results, they reclassified 12 of the 19 grade 1 positive lambs, which is an equivalent of 63% of all the grade 1 lambs, and about 23% of all the positive tests. So the second part of the table shows you the agreement between the prior algorithm and the new algorithm, and you can see that with the old algorithm, 298 lamb tests would be performed, giving you about 41 true cases of TB and a diagnostic yield of 33%. With the new algorithm, the number of tests tripled to about 862 number of tests performed, giving you an increase of about 13 new cases of TB and a diagnostic yield of 39%. And there was no significant difference between the two diagnostic yields, so it was basically statistically similar. But also in terms of lamb misinterpretations, the old algorithm gave you 7 lamb tests misclassified as positive when they're negative, but with the new algorithm, that number almost doubled to 12. So this is my second last slide about implications. So in summary, we have seen that lamb is prone to misinterpretations, as we have seen that more than 60% of all the positive grade 1 lamb tests were misclassified. They were misclassified, and that highlights a challenge with lamb interpretations. And this calls for rigorous QA/QC procedures to minimize lamb misinterpretation, because we're having patients who don't have TB being initiated on TB because of someone's misinterpretation of a test result. So we recommend rigorous QA/QC procedures to minimize lamb misinterpretations. For all lamb positive results, clinicians should be provided with information on the grades, especially if it's a grade 1, so that they can make better informed decisions. Also, for all positive lamb results, it's important for us to monitor and report the number of positive grade 1 lamb results, because a spike in grade 1 lamb results is the one that is going to indicate to you a problem with lamb interpretations. So we also need to evaluate our plans to implement the recent WHO recommendation to expand outpatient lung testing to symptomatic patients with HIV, irrespective of CD4 count. So our study has shown increased potential of harm with minimal or no benefits. There was no difference between the two diagnostic yield, but that came at an expense of almost 3 times the number of tests performed. That's a lot of money that we're losing. And an increase, almost 2 times increase in the number of misinterpretations. Those are so many patients who don't have TB that we are taking as having TB. So this is just to acknowledge the team that we work with on these studies and also the funding. Thank you.
Thank you. Thank you, Mr. Makumbi. I'll quickly invite the next presenter, and that is Dr. Sulaiman Kawoya, who is standing in for Dr. Haruna Semuemba. Dr. Kawoya is a regional managing director for Uganda Cares, and he will introduce his topic of discussion. Use the lower one, the lower arrow.
Good afternoon, everyone. Sulaiman Kawoya is my name, and I work as the regional medical director for AHF Uganda Cares, and I oversee medical services within 21 facilities. And the case I'm going to be presenting, join me on the journey as I take you to Gombe Hospital. Like I said, we are going to be looking at, I'm standing in for Haruna Semuemba, who has not been able to be with us here today, but we are looking at assessing the impact of HIV/AIDS on TB treatment outcomes at Gombe Hospital, and we used a cohort study. TB remains a global health challenge that claims people's lives annually, with a tune of around 10 million people getting TB annually. In Uganda, Uganda is among the 30 countries worldwide that are listed among the high TB burden countries, and we lose around 240 people per day, and then, 240 people per day get TB infection, and then we lose around 30 Ugandans per day. But of all the 30 that pass on, around just above 50% are HIV infected people. So HIV as a disease continues to have a ripple effect on families, communities, society, in terms of the economy, the economics of it, and with around the lost time while working. So that has a profound effect on the vicious cycle of poverty. We set out to assess the impact of HIV/AIDS on TB treatment outcomes among the patients that were enrolled at Gombe General Hospital. And what did we find? We used the study design of a retrospective cohort study, and with this, all patients that were diagnosed with TB between 2001 and 2002 were included in this study. And then we looked mainly at the social demographics and also the clinical correlates. Our source of data was the medical records, and then the statistical analysis. We used the logistic regression, and then we looked at the odds ratio and the p-value, as you would see. What we observed significantly, we found we had 42% of our study participants were women, and then 57 were men. And 43% of all the 466 clients that were diagnosed with TB were HIV positive, of which 56, more or less 57% were HIV negative. But this demonstrated that there was a higher proportion of what we found out, we found a higher proportion of male patients compared to the female patients, which did suggest a gender disparity in TB incidence. Maybe we thought of maybe health-seeking behavior as one of the issues there. So one of the peculiar key findings within our study was that when we looked at whether sex had an influence on TB outcome, we found that male patients exhibited a statistically significant association with decreased odds of successful TB outcome. So, being a male was associated with a decreased likelihood of successful treatment, TB treatment, with approximately 46%, more or less 50%. So that was unique with our finding. But when you looked at whether HIV status had an impact on TB outcomes, this was not, the association wasn't that significant between HIV status and TB outcomes. So, however, further analysis did reveal to us that the cure rate of TB, cure rate of tuberculosis among HIV positive patients was significantly lower as compared to those that were HIV negative. I mean, that's the statistical, and we looked at 466, and then we looked at those factors. So the key implications for the national TB leprosy response. Visiting Gombe did show us that there was a gender-specific interventions that we need to put in there, because more or less, being a man, you have a risk of 50% not achieving the treatment outcome, which is getting cured. Then it is important to target health education talks and awareness campaigns that will be that need to be target the men. A need for enhanced monitoring and evaluation across the board, and also a strengthened collaboration with HIV/AIDS program partners. I acknowledge the contribution of the listed members there, Dr. Penina Itungu, and then Dr. Lydia and Henry Magara. Thank you so much for listening to me.
Thank you so much, Dr. Kawoya. You note, colleagues, that since morning we are learning that, of course, screening and diagnosing TB is one part, but also after we've diagnosed it, there are many other challenges. And I think the boy child needs a lot of attention lately. Even when it comes to completing TB treatment, going to the healthcare facilities is a problem. In the HIV clinic I lead, we have about 70% women. Then you ask, where are the men? Now, even when they start TB treatment, we are falling off the cascade. So the ladies in this room, I think men need some additional support. We have very little time, so I'm going to give chance to 3 very quick questions. I don't know if there are any online, but if not, are there any online? As they work that out, I'm going to ask those of you who are in the room to ask 3 questions. 3 counting down. There is a hand going up. Okay, Dr. Stavia has a question. The other one. So you'll ask the questions and then we'll get the answers and we'll close so that we can go to the next session.
Thank you so much, Chair. Very quickly to Dr. Baruku on the NCD's presentation. I don't know whether I missed this, whether you were able to find out whether these patients actually had the issues that you saw during treatment before TB, or they developed during TB treatment. And then you recommend that it is important to integrate NCDs in TB programming. I would have loved to see a double recommendation. Thank you.
Thank you. Any other burning question? Is there a hand that I'm missing? Okay, there is one from Dr. Brewer.
Yes, yeah, thank you so much. Mine goes to Shafiq regarding the recommendation, especially to improve utilization of urine lamb. You talked of expert readers. I don't know if I got you well. In your methodology, there are people who were called experts. Is it readers or interpreters of that lamb, a positive lamb? But you realize under program implementation, we do not have that kind of category of people. Or our health workers, I'm not sure if there are some who have that special training to refer to them as that. So what recommendation would you make for the program as we implement LAM? Because we are faced with I'm now seeing two challenges with the LAM implementation. The first challenge is what you bring up. Some of the positive results may actually not be true positives, based on the variability in interpretation. But the second challenge is also the issue of adhering to the eligible people for LAM. Sometimes people test those who are not really eligible for testing. So with that double challenge, I'm seeing a recommendation is needed to optimize LAM use. Thank you.
Thank you, Aldo.
A few questions online.
Thank you. The question is to our doctor from Gombe. Someone called Mansuru Idrisa from Karugutu is asking what interventions you have put in place in Gombe to find patients who do not complete their TB treatment.
Okay, I think that summarizes our three questions. Dr. Kawoya, you have the microphone to answer the two questions.
Thank you so much. Which interventions have we put up to address the issue of TB completion? I spoke to the need of emphasizing that the community integration approach that was taken on recently in the new guidelines brought in an issue or an idea around the dots, the TB dots, using the community structures. We are leveraging on that, and also the partners, Uganda Cares, working together with IDI. We have interested, mapped and got the community peers, and if we identify a TB client, then we do tag that TB client with a community health worker with the instance or the importance of making sure that they do contact tracing and also bring in other services like TPT within the communities. They give us an extra mileage in that area, and we are looking at it, studying and leveraging on that. And also bringing the many people, because after getting this finding, did present to us that we need to do a lot of work around the men, and then making sure that our communication information we pass on is tailored towards interesting and understanding the dynamics or challenges that the men do encounter. So it is work in progress, but one question is that, is it only applying in our context, or we are having it in other areas? That's why it is important for those other people who are listening to me, the M&E, try to tease out the data to see whether we are seeing this kind of picture. Then one thing that stood out was more TB in the men. In terms of incidents, we saw TB in the men. I know it is, and then we were like, there were fewer women. Then on the other side, were like fewer women. It is post-COVID challenges of economics that the women were not getting them. There were quite a number of question marks we're still having. And, you know, by and large, it's thought that men have a poor health-seeking behavior. So if you tend to see more men, when does that translate into where are the women? Those are some of the questions we're still having, but it's work in progress. Thank you so much for that question.
Yes, I think that the issue of men is really global and universal. All of us see that men are more affected, and there are biological explanations, including testosterone increasing your risk, including XY chromosomes and so on and so on. But that's for another discussion. Yeah, Dr. Stavi, I agree with you. It's important to integrate TB even in other NCDs. If you're managing people with hypertension and diabetes, you should be able to screen for TB. Yeah, but the electorate I have here which can vote is a TB electorate. So I must campaign that we must integrate cardiovascular risk management in our TB programming and not assume that the people are managing the hypertension and the diabetes in the different clinics. So this population in our study were people who were established on TB treatment for a median of 8 months in treatment. So we do not know whether these risk factors came before, during. We are not so sure. So it's important for us to have prospective studies for people who are starting TB treatment at baseline, in between, and at the end, to see at what point do these cardiovascular risk factors arise such that we can intervene upon them.
Thank you, Dr. Baluku. Shafiq, you have the mic.
Yeah, I think the first question was about whether we have experts. And yeah, I think we have some experts in the country. For sure, I know that Dr. Lydia Nachingi has done a lot of work on TB. And I know that we also have our team that has done a lot of capacity strengthening for the sites where we are involved. So I think training is one thing that we can do. It's within our means. Although the challenge is, even with training, there will still be misinterpretations because the test is very subjective. And that is where we need to review that recommendation as a country and decide, do we want to proceed that way? That's what I would say. I hope that answers the question.
Okay, I know that our time is fast spent. Why don't you join me to put your hands together so we can thank these able gentlemen for the excellent presentation, and thank you for the opportunity to be part of this. Over to you.
Thank you, our session chair, for chairing so well. Our day is fast spent. We are now to our last session, and I would like to invite our final session chairs for today, Dr. Mary Mudiope from the USAID LPHS TB activity, and Ms. Gertrude Namayanja from the Office of the Prime Minister. Is Ms. Gertrude in? Okay, I guess Dr. Mary will have to chair for both. Okay, Dr. Mary, you're welcome.
Thank you. Good afternoon, members. We came from lunch. Good afternoon, members. Join me in this session. It's not an easy one, but I'm hoping that we shall stay awake. The presenters for this session, please, if you know yourself, you could join in. I've been introduced, Mary Mudiope, the project director for the USAID Local Partner Health Services TB activity, the US government flagship project, the Ministry of Health, TB and Leprosy. We are going into the session for policies and programmatic implementation. And here we are going to be talking policies, civil society, and human rights. I would like to invite Geoffrey Kabale to join me. Dr. Katamba, is he still around? Dr. Katamba, I hope he's still around. I see his computer. Please join me. Jasper, please join me. Dr. Brewer, Aldo, Alphonse, and Zowena from Umbali Hospital. I'm inviting people to join me, not to exit, to come here. We'll make sure that we manage the time. Okay, thank you so much. You are all welcome. We are going into this session, and we have 6 minutes, each of us, to share the learnings that we have. With these presentations, I would like to invite Geoffrey from JCRC to take us through our first presentation. Members, as you are listening, these are policies. We have been talking too much of science, but probably now we are going to hear if the policies are also informed by what we have been hearing today. Some of those, but also probably what we are going to share can also inform the policies. Over to you, Geoffrey. 6 minutes.
Thank you, Dr. Mary. Geoffrey Kabale is my name, and I work with GSCRC. We're implementing the USAID Local Partner Health Services project in Langwa sub-region. Probably to give you a brief background on what I'm going to present. I'm presenting on the lessons from the integrated community awareness, screening, prevention, testing for primary prevention, control, and treatment of tuberculosis, HIV, maternal and child health in a sub-county called Abia, the integrated CAST Plus. Their learnings are with the support from National TB and Leprosy Program and the guidance that we received, we implemented a pilot in Apache district. So from the learnings of implementing in Apache district, we learned that implementing CAST Plus in an underserved community would give better outcomes for TB, case finding, but also with other ailments that come through with. So together with the, I'm not sure if it's, okay, thank you. So together with the district of Alepton district local government, we reached out to a sub-county called Abia. Abia is an underserved sub-county with a health center too. Data from the neighboring sub-county, which happens to be Apala, where we have a diagnostic and treatment unit, indicated that the majority of TB cases were coming from this specific sub-county. And Abia Health Center too had been highlighted to be an AP3 site, AP3 standing for Accelerated Progress on Pediatric Stroke PMTCT service intervention. So we reached out to this specific sub-county and invited the leadership of the sub-county, who were led by the chairman, LC3, health unit staff, and we had first of a district kind of orientation, and then we moved to the facility. So at the facility, we reached out to 63 VHTs whom we oriented at the facility orientation, and we had field activities for 5 days in the month of November. Community sensitization, hotspot screening, contact tracing, referral of pregnant women for antenatal care, early infant diagnosis and immunization were some of the activities that these teams did when they went to the communities. And the activity cost is indicated there. So what findings, or what were the key findings for this specific sub-county when we reached them? 393 households we are reached out to. We screened and were able to reach out to 1,921 individuals who were given basic information and also received the screening. We presumed 456 TB cases, diagnosed and linked 9 cases. We were able to give out TPT to both under 5s and 5+. Self-test kits were also distributed out, and were able to have 5 reactive, but 3 were confirmed and linked to care. 89 pregnant women were referred and received ANC1, and 31 of them were tested for HIV. I want to draw your attention to that graph, which is being displayed there, and specifically for the October-December 2023 period. You see that on a number of indicators in this specific sub-county, we're able to have increment in TB cases, mothers who were linked to care, and also those who were initiated on ERT. Part of the implications for the national TB national response that we want to put forward, we note that the CAS Plus campaign approaches encourages integration, as many of us could agree with me. And this does not only happen like we've seen where different implementing partners are coming together, but even at the district, project level, sub-county level, health facility level, we see that when we did this, that bit of integration helps in leveraging resources and also the support that we provide. The other thing that we also feel that we need to have looked into is the impact of CAS Plus on sustained community uptake for preventive and treatment innovations for layered services, and needs to be studied. And finally, we feel that going forward, we need to study the patient demographics. Yield, we're interested in seeing who are these people that we are reaching out to each time we're having these implementations. Are we reaching the men more? What is the yield and how are the linkages vis-a-vis the different routine community activities that we have? So those are just a few pictures. On the extreme right, you see the chairman LC3 and the DTLS reaching out to or giving out supplies to the VHTs. We want to thank most especially the Aleptong district leadership, the sub-county, National TB and Leprosy Program for the guidance, and USAID. Thank you very much.
Thank you so much, Geoffrey, for sharing the lessons from the CAST Plus, lessons from there, and the need for integration. The earlier session also alluded to that. Let's have the next presenter, Dr. Katamba.
Hello? Hello? Yes. Yeah. After lunch, things are not easy. Actually, even me, I had forgotten also. I thought I would be the last one, but I just realized that now. So I'm going to present something that these are results of contact investigation. This is work we have been doing for the past, I think, 4 or 5 years. But now we are disseminating. These are the first results. It has not yet been published anywhere, but we are presenting to see what we found. And it's implementing patient-centered, a user-centered implementation strategy for TB contact investigation in Uganda. Step-wage cluster randomized trial. Here, we shall talk about the evidence guideline, human-centered design to enhance contact investigation, and then the findings from the trial. Yeah. As you may all recall, a few years ago, we were actually doing passive case finding. There was no active case finding. But after a number of studies which are outlined there, a number of studies have shown that really, depending on the subgroup, there is definitely a yield from contact investigation, which ranges from 1.9% in casual contacts to as high as 3.9 in less than 5 years. So based on a number of the findings from many trials and others, WHO put out those guidelines for contact investigation. How best to do that? It is something that we went to evaluate. Despite that guidelines coming out, it is very clear that if you look at the data that came out, these are many countries, including Uganda here, that if you look at the index TB patients and you look at the contact identification among those who are eligible and you look at contact identification who are identified, you find that it's not 100% that coverage. It is as high in 91, but here in Uganda, you can see contact identification was a problem. But even when you go further to look at the actual contacts who have been identified, if you look at coverage, the data among those who have been identified is not. But even when you go further to look at who are symptomatic, and you look at coverage among the symptomatic, meaning that probably, despite the guidelines being out there, they are not effectively used, and there is need to look at it. The National TB Program has got contact guidelines. The current, I don't know, there may be another current, it's the 2019 guidelines to guide contact investigation. And it's already standard of care. So we went further to say how can we enhance contact investigation, because we could see it is really not capturing, and then we used patient-centered or human-centered design to improve that contact investigation. And to do that, this is work we started, and we looked at trying to get the views of the different stakeholders, healthcare workers, TB program leaders, implementing partners, and other people involved to design an intervention after identifying really loss along the cascade of TB care, to identify how can we improve uptake along the cascade of TB care. And this human-centered design, which is really more of an approach to solve problems, starts with the people who are designing, we are designing for, and ends with solutions that are tailored to suit their needs. And so the need to consult, decision-making together, engage them and others. So this really, it emphasizes making sure we build empathy to the people we are designing for, and so that whatever we put out can appeal to them. So the elements of all that process, which took some time, we designed a package of elements which really, our brand was Tuli Wamu Nawe. This name was actually selected after a number of consultation, Tuli Wamu Nawe, meaning that this person who has been identified with TB, an index patient at the facility, we support him that we are together with you in this journey. So we are going to follow up with you in the treatment, but even supporting your own people. So that brand was based on trying to encourage the people that Tuli Wamu Nawe. And most of the material were branded. And there are a few packages of that. Maybe this next slide will demonstrate it better. So the elements of this brand involves identification of patient identifies contacts. So we came up with at least a way to help people identify who are their close contacts. Because sometimes when you say close contacts, someone may think only the people he sleeps with. But when you also tell him about whom he works with, if it's terms of prayer, who he goes prayer with and other things. So finally you help them identify. So we identified a contact identification, but we also came up with a book, TB011, which was aimed at giving health education awareness. TB is transmitted through the air. You may also have got it from a taxi or something to encourage people. And then, in addition, if people identify their contacts at home, then at the health facility, and those contacts, he takes this book or she takes this book, and these people are willing to be interviewed or screened on the phone, then the community health worker could screen them on phone. But sometimes he may have to go home and screen them from home face to face. But we had a sputum video which had been already translated in the local languages, which helps people to understand how to expectorate and give a good sample. So this sputum video was put on the VHT phone, and then the VHT could demonstrate. But if we managed the VHT to screen someone on phone, then he would have the sputum video on the border rider's phone, and then this border rider would pick the sample after talking to him. So the border rider could transport the VHT, but could also pick the samples depending on the type of people. And so could now this bag, you see, could collect the sputum, had been trained on how to collect sputum and to instruct the people, and then could bring back the sputum. And the next component in that, we are all strong in one way or another, what we call community of practice. It's used many times among clinicians and others. You find Fred Semitara is good in diagnosing this condition. I have a challenge, I can't. Then when we go for lunch or somewhere, we can exchange ideas. I got this person like this. The same thing with VHTs. VHTs, some of them are strong in being able to counsel some people and they give sputum. But if you give them an opportunity every week to meet and share the challenges, it is sort of people who are doing the same work, and how can they support each other? So,
Doctor, 2 minutes.
Okay.
Thank you.
So this used to happen every week to guide them and move forward. So the results really, here what did we compare? The standard of care strategy, which is training using the guidelines, supportive supervision. All of these go on both, but we added on the tree now, to them now, and the community of practice, those components. What did we, this was the 12 districts still, and those 12 districts, there is a period there when we were affected by Ebola in Chiboga and in Mubende and Kasanda had to interrupt the study, and that was the period when we had to stop the study, and that was the randomization. Also districts were asked to choose who comes first, because we were enrolling 2 districts per time, but then we had a randomization ceremony. We called the district administrators and other people to participate and choose, and that was. Then in terms of these groups, they were generally a bit similar in terms of the people. But the findings, which I think are very important for the program, in the standard of care strategy, if you look at this, 800 people had 1 contact plus, and 900 had 1 contact, because you had to have a contact to do contact tracing. Then, if you look at this slide, the emphasis should be that out of the people who had contacts, those who were screened for TB during the standard of care were 99%. Screened were also 99% in the user-centered design. And then when we went further, comparing the standard of care, you see 268 completed TB evaluation, and the 86% completed TB evaluation out of those who are there. If you look at the summary of the key finding, you would find that in terms of implementation, when you look at the standard of care, 48% of the people symptoms completing TB evaluation was 48%, as compared to 86%, which was significant. Effectiveness in terms of contacts diagnosed and treated for active TB, if you compare the two, still the standard of care had more people who were. But in terms of initiating contacts for TB preventive therapy who were eligible, we find that there was no difference between the two, and that was something that, though there were more still, but there were no difference. So in summary, user contact investigation strategy was superior to the standard strategy for evaluation and case finding. User contact investigation strategy did not improve TPT implementation among close contact. Human-centered designs and communities of practice, a promising strategy in improving TB services in Uganda. I would like to acknowledge a number of people who are part of this team, but I would like to acknowledge maybe the National TB Program for working together closely, and also acknowledge the NIH for funding this work, the partner. Thank you very much.
Thank you, Dr. Katamba. You have used the 3 people's time. Yes, so we hope that we can redeem some time with my next presenters. Over to you.
Good evening once again. My name is Dr. Nidoi Jasper. I'm from the LIGHT Consortium. And just to introduce the LIGHT Consortium briefly, LIGHT stands for Transforming Gendered Pathways for TB. We're doing work in several countries, including Uganda, Nigeria, Kenya, Malawi, with our partners in the UK. And as I go through this abstract titled Evaluating a Tracking Tool for TB Screening, a co-designed health system implementation research to improve service coverage, I just want to highlight that the focus under LIGHT in Uganda is trying to introduce gender-sensitive strategies within the healthcare facility. Other partner countries are looking at community and other aspects of gender-sensitive healthcare. So we know that TB is more prevalent among men compared to women. In Uganda, we know that it's about four times more prevalent among men compared to women. Secondly, we estimate that about 2/3 of missed TB cases are among men. And missed TB is important because each person who has undiagnosed TB can spread it to about 5 to 15 people in a year. It leads to poor health outcomes and worse socioeconomic outcomes for the patient. So what we found is that there are no gender-specific policies targeting men in healthcare facilities in Uganda. And that image just highlights the picture that we have right now. We are providing the same healthcare to people with different needs. And that's what we want to do with our gender-sensitive interventions, is to try to address some of these barriers. So what we did, we grounded our work in literature, and as I've highlighted, we found that there are no gender-specific policies targeting men. We then had an intervention co-design process to co-create a gender-sensitive intervention for men. We had participatory research in which we invited 87 stakeholders from 4 facilities. These included healthcare workers, TB survivors, policymakers, and researchers. And we had formative data collection in the health facilities, followed by a co-analysis meeting. In summary, we used the health-seeking pathway, in which our study participants described the steps that people with TB take from the time they have symptoms to the time that they're able to access healthcare. And then we compared what actually happens. How are these patients seeking care? When we compare these two pathways, we're able to identify barriers and challenges that prevent men with symptoms suggestive of TB from utilizing the healthcare pathway. We then used a very visual process called the stepping stones, in which a river represents the barriers to TB access, and these include masculinity. Men prioritize earning income over their healthcare needs. How can my family stay hungry yet I need to work? So all of these were the barriers that we had in the river, and each stone was a solution. So this was able to make this very visual for the study participants, and we identified potential steps and resources that were needed. In the final co-analysis meeting, we prioritized 3 interventions, and these are what we used for our pilot study, which was a quasi-experimental study. And for this, we implemented it in 2 facilities, which is Gombe and Mityana Hospital. I think you heard from the presentation before about increased mortality in Gombe and how really we need gender-sensitive strategies there. So what we focused on were male-friendly services, introducing male-friendly services, in which we had extended working hours, because this was one of the barriers identified, integrating more services, screening for diabetes, hypertension, and another thing that we zeroed down on was enhanced screening at all service delivery points. We know that active case finding was launched in 2018, 2019, but we wanted to see how could we move this further, and what we decided on was using the intensified case finding stamp, which you will see in my next slide, and also information education material to raise awareness in the community. So I'm going to focus on the process evaluation, the way in which we evaluated this intervention with the healthcare workers who were actually involved in its implementation. So we invited 40 of these for participatory review. So at the top right, I think depending on where you're sitting, you'll see the TB screening stamp, which basically summarizes the intensified case finding guide. So with the healthcare workers and through this participatory review process, we evaluated the fidelity. Was the intervention implemented as designed? How frequently were they implementing the components? Was it able to reach the targeted audience? As I've mentioned, our focus was on men. The intervention strategies were open for all. If we extended working hours, the clinic wasn't open for only men, for men and women, but our target was to address the barrier among men. If any adaptations were made, and the usefulness of the training that they received. So that the figure B shows the way in which we're able to deliberate on the factors that were influencing implementation. And for this, we actually looked at the health system framework, and we looked at the different building blocks of the health system, the 6 building blocks, to try to explore these factors. So on the table, you can see that the fidelity score was 3 in both facilities. The healthcare workers noted that it was easy to use. They were also able to report that they were able to see increased notification in the healthcare facilities, and this was more among men. However, when we look at the dose, we see it had an average score of about 3.5. There was inconsistent usage, with healthcare workers citing challenges such as limited knowledge, because the training was for 30 participants within the health facility. So there was lack of knowledge it did not reach all healthcare workers, and also sometimes they cited the heavy workload. The training identified about a clinician from each department plus other stakeholders. So ultimately, few clinicians were included in the training. So if a nurse stamps a form, let's say the medical form 5, and then the clinician has to use it, there was that knowledge gap between the nurse and the clinician. So few clinicians attended the training, and overall male participation or male attendance in the facility was lower. One adaptation that was noted was healthcare workers started only stamping records of patients who had cough, so patients who are presumed to have TB, and this was used to identify patients who are presumed to have TB. And we noted that this could potentially increase stigma as it became easy to identify patients presumed to have TB. So implications and finalizing, gender-responsive strategies are needed. We've highlighted that. And systematic screening can enhance notification. Participatory approaches do facilitate dialogue between different actors, and this should include all healthcare workers, including clinicians, through clinician meetings or other areas in which we can easily access them if they're not available for training. And our further research will highlight the effectiveness and cost-effectiveness of male-responsive intervention. I'd like to thank my co-authors, the Light Consortium, UK8, who funded this work, MLI, and the staff at Gombe and Mityana hospitals. Thank you.
Thank you so much, Jasper. We are not managing time well, and I'm next. You want to take my chair? Okay. So, good afternoon or good evening once again. I'm also part of the presenters, and I would like to share something about the children, the work that we have been doing in Kampala. We are still doing it, and today this work has been shared in another forum, and I believe that as we listen from here, we can also expand this work to where we are. So I'm presenting the assessment of the prevalence of TB among school children in Kampala, Mukono, and Wakiso districts, which are directly supported by the local partner health services TB activity. And this is work that is coming out from routine work. It's learning from what we have been doing. I recognize all those that we worked with to put up this work. So in line with what we had observed as we were starting the implementation of the project, we noted that there was a growing concern about the spread of TB in children in schools who are picking up cases within our health facilities. So as part of the engagement of the different sectors and also ensuring that awareness is high, over 90% of our population, and in line with the multi-sectorial accountability framework, we went ahead to engage schools, starting with those that had notified a case, a child that had been diagnosed with TB, to follow up and conduct TB awareness and request to actually screen the children in those schools. So we carried out this within the 3 districts. And those are some of the pictures where we have been able to engage with the schools. So from that time, over a year, we engaged around 33 primary and secondary schools within the 3 districts over that time. And from, as I mentioned, the case that was identified led us to the schools that would target. And within that, we made sure that the schools are within the areas where we're also finding more TB cases. The intervention was extended without discrimination of gender, whether male or a boys' school or a girls' school or a mixed school. We went there, whether day or boarding. We also reached all ages from 6 to 18 years, meaning primary and secondary, and we made sure that most of the samples that we got accessed a gene expert test. And from that, those that were unable to produce sputum underwent a clinical examination, evaluation, with additional support from the health workers. The engagement of these schools, we had health worker teams that went with the VHTs that serve those communities where the schools are located. So from the results, we would also engage the caregivers again in consultation with the school administration. Over that period, from the 33 schools, we were able to reach over 5,700 students who were screened for TB, and 12 of them were identified from that screening. The table provides the detail from each of the districts. We note that in Wakiso, the schools that we targeted, we never got a confirmed TB case from the children that were reached. We also note that Kampala had a higher presumption of cases being identified from those that were reaching out. And all the children that were diagnosed were able to start treatment. We did start treatment, but we had delays in treatment initiation because we needed to gain consensus from the caregivers and all parents from for these children. We also noted that TB prevention became harder to actually provide for those that were identified as close contacts for these children in the schools, because prevention is to those that don't have any symptoms. So we needed to again make sure that we have consent from the caregivers. These are children that did not have any symptoms and were eligible for prevention. So it was quite hard. We never managed to provide TB prevention to the children that were identified as close contacts, those that were diagnosed. We think that TB is a significant problem among the school children, and we really need to increase our efforts to improve prevention and treatment in the schools. We also need to emphasize, there should be emphasis placed on educating the masses and screening in schools, screening for TB. Most of these also, we had the delays accessing the schools, the administration accepting us to actually carry out the screening, because they knew with the lessons from COVID, finding the way that TB is spread, diagnosing a child with TB would raise an alarm to the parents, but also it would also raise an alarm around business, because some of these schools were actually private schools. We also think that we need to engage more sectors to ensure that the education sector can actually take up this as part of the school health program to screen for TB, and also be able to build capacity among the school nurses and matrons and administration to know what to do when they get a TB patient or a child that is diagnosed with TB. This was learning from what we are doing routinely. We would appreciate if we could do operations research to better understand the prevalence of TB across the country in schools. So we acknowledge all those. We had to engage the education departments in the different districts, the different district leaders, and also the health workers, and also those that provided us the funding to do this work as we operate within these 3 districts. Thank you so much. Yes, so thank you so much. I hope we shall have comments. I would like to invite our next speaker for this, and that is none other than Dr. Aldo.
Yeah, thank you so much, our chair, who has also been a speaker. So I'm going to share with you work that we've been working on with the team from the program. As has been introduced earlier, I'm called Dr. Aldo Brewer. I work with the National TB Program, and I coordinate a TB case finding, seconded by the said local partner health services TB activity. So I'm here to discuss a policy brief that we're working on to enhance community tuberculosis case finding and prevention strategies to reduce the TB burden in Uganda. And I would like to recognize the colleagues I've worked with to come up with this policy brief. Let's go on. I'm going to move it, okay. Okay, as a background to my brief, we appreciate that Uganda is a high burden country for TB and HIV, and there have been efforts to enhance TB case finding through various strategies that have been implemented, and this has led to increase in TB notification. If you see in that image over there, in the last 3 or 4 years, there has been a trajectory upwards towards improving TB case finding. However, what we note is that despite the improvement in case notification, this has not impacted significantly on the TB incidence. As you can see, the incidence has more or less remained stagnant in the last 3 or 4, 5 years. So there was a study which was undertaken that realized that we had achieved 2.7% reduction in the TB incidence by 2021. This is against our goal for the strategic plan to reduce the incidence by 20% by 2024-25. So we have just hardly a year to this period, but the progress has not been in line with what we aspire to achieve. So this policy brief aims at identifying and analyzing the existing evidence to recommend effective strategies to improve case finding and prevention so as to reduce on the TB burden. So how we did this, we basically undertook to review any available evidence, both from published studies and also from non-published reports. So for the published studies, we basically looked at the various search engines, and basically our search terms were mainly around work to do with tuberculosis and incidence of TB. So we had to look at which interventions were implemented at community level that would impact on the TB incidence at that level. So through that, we were able to identify articles that were relevant for consideration to inform our policy brief. In addition, we also looked at the non-published reports, like last year, the National TB Program conducted the midterm review of the strategic plan and came up with some recommendations, which also informed our proposed recommendations for this policy. So, from our review, this is what these are our findings. One of them is that through an intensive initial case finding intervention, followed by serial case finding campaigns, we are able to achieve, first of all, a reduction in the diagnostic yield of TB. This was a study from work done in Uganda, here in Kampala, and the team, I want to acknowledge the team that is in this room. We are part of, I think, Dr. Katambal is fully behind this study also. So they conducted this intervention in one of the communities within Kampala, which is high burden for TB, and they were able to demonstrate a reduction first of all, in the diagnostic yield of TB over a period of implementation of the intervention, and also a 45% reduction in the prevalence of TB. Then the other intervention, which also we found was significant, is that sputum tuberculosis test for every one. This is, I think, what most of you are familiar with, especially through the prevalence surveys, in which when we conduct active case finding based on sputum TB test for everybody, like is done in the surveys, over time we're able to achieve a reduction in the TB prevalence. And this is based on a paper that was a study which was conducted in Vietnam, in which they conducted the survey which was done. After repeating it, after a certain period of time, they were able to realize a reduction in the TB prevalence. So we think that this is an intervention. If it can be incorporated in our implementation, we should be able to achieve that. Then the other intervention is the community TB case finding and prevention package integrated in high-risk populations. Okay, I take note of that. Then lastly, community-wide active case finding for TB using the mobile van approach. Again, this is based on a paper which, a study which was conducted in Zimbabwe, in which they compared door-to-door screening with the screening using a mobile van approach, and found the higher yield of TB from mobile van approach. So with these findings, we have these recommendations, implications for the national TB program. One of them is that we say that by integrating community-based TB case finding and prevention approaches involving serial TB screening campaigns, because we believe if these campaigns can be done repeatedly, using mobile X-ray approach, since you're able to, they are sensitive tools and able to reach a large number of communities at the same in a short time, and then targeting well-defined communities. So the communities should be defined based on the data, based on the TB burden and mapping of those communities. If we can target those communities and make sure that when we do the campaign, we're able to collect sputum samples from everyone in that intervention, then we are likely to achieve a reduction in the prevalence of tuberculosis. So as a recommendation, we want the Ministry of Health and the partners to support these interventions and also invest more resources to expand coverage and intensity of these interventions to achieve the impact on the TB incidence. So this is just a summary of, a detail of the policy brief that we have come up with, and it's still under development, but we want to share our experience in coming up with how do we translate research into action through informing programming. So I would like to thank you all, and I acknowledge the different organizations, including the Ministry of Health, the partners, and specifically AFIDEP that oriented the team from the national program on the development of policies. And it's something which we are now trying to put into practice, and want to continue to thank the team, MLI, the other district and local community partners that have supported this work. Thank you.
Thank you, Dr. Aldo, for sharing that. We are getting there. Please stay with us. Yes, Alphonse, we want to hear from you. Thank you.
Thank you. Yeah, my name is Alphonse Kwizera. I work with the USAID Local Partner Health Services Ankole and Acholi activity implemented by TASO in Acholi and Ankole. And I work as the manager for quality improvement and knowledge management in that activity. But I also want to acknowledge a colleague that led part of this work that I'm going to present to you, Ali Kasibula is the regional TB technical lead for the LPHS Ankole is over there. Yes, so we did some work using a QI approach, using root cause analysis to improve TB treatment success rate in Ankole region, and we looked at about 130 facilities in that region. Yeah, so globally, TB treatment success rate is a very critical component because if it's not improving or if you not doing well, we will not realize the TB treatment outcomes. So Ankole region for quite some time was stagnating between 84 to 86% for TB treatment success rate for a number of quarters between 2021 and 2023. So we realized this problem, and working with the USAID Local Partner Health Services TB activity, we designed a root cause analysis tool to identify barriers to TB treatment success rate. And the aim of this was to see that at least we are able to push the TB treatment success rate for this region from 84 at least to 90% and above, because that's the target for TB treatment success. Yeah, so how was this done? I already talked about the RCA tool that was developed with support from the TB activity. We reviewed records and selected about 27 facilities to act as pilot based on low performance, but also the volume based on high volume sites, and also we line listed TB patients that had interrupted treatment. So we had a team, we selected a team of district coaches who were oriented, and also we supported them to orient the facility teams to be able to administer the RCA tool. And from that activity, we were able to see that some of the barriers that were affecting treatment success in Ankole region included transport costs, distances, forgetfulness, frequent travels by different people who do work in different areas. There was also an element of stigma and discrimination. So those were seen as the greatest contributors to TB treatment success. So we were able to attach TB patients to community health workers, and TB linkage facilitators and cough monitors for support in terms of follow-up, but also provide treatment at community level. We also conducted pre-treatment literacy sessions before deciding if one has to take medicines. And also we did improve TB appointment through improvising a register, a TB appointment register at the clinics to capture details and also enable follow-up whenever someone misses treatment. There are other interventions that also boosted, including putting specific TB clinic days and also making calls to TB clients and update the locator forms, because some of the information given before was actually not adequate and was not leading to follow up. So some of the results that we saw, we saw that treatment success was able to improve from 86.8% to 92.4%. And some of the other findings that we're able to observe was that health workers never minded about the convenience of the clients when they are selecting appointment dates. There was also an issue of health workers would write appointment on client files only and leave the client books, and so the clients was not able to pick the appointment. But also some of the clients would forget, and other things. So that the graph you see there, it is showing that we are able to surpass the 90% mark for TB treatment success in Ankole after starting a TSR campaign in which the root cause analysis was done to identify barriers and target the interventions. So we are observing that attaching health workers and community volunteers to patients helps to track TB patients, especially treatment monitoring, and also home-based drug delivery helps to clients to adhere to treatment and contributes to the treatment success outcome. We also see that I think it is important to conduct a root cause analysis for us to be able to identify barriers to treatment success. We also see, which is a known fact, that focusing on a few facilities that create impact where the biggest problem is, but also facilities that contribute to the highest numbers of the patients that you have, is also something that can be able to help you identify and close the gap in care. The picture there is one of those pictures where the TB coaches were doing line listing of clients and also entering that data in the RCA tool in some of the coaching sessions where the TB coaches were being supported by the LPHS Ankole and LPHS TB activity.
Alphonse, you already over?
Yes, so we want to acknowledge PEPFAR and USAID for the support, government of Uganda and TASO, but also the USAID LPHS TB activity that we together did this work. Thank you.
Thank you so much, Alphonse. We are having the last lap. Our last presenter from Mbale, who's going to take us through the lessons learned from improving HMIS 106A TB reporting rates.
Good afternoon.
Good afternoon.
Protocol observed. Things are now changing. Those days it used to be ladies first. Now I'm seeing men first and ladies last. Things are changing. Okay. I'm called Namuche Zowena from Mbale City, not from Mbale Regional Referral Hospital, as the chair said. Mbale Regional Referral Hospital is part of Mbale City. I'm the TB Leprosy supervisor from Mbale City. I think I'm the only TB focal person in the house. So, since I'm the last chair, I think you will add me more minutes. So it was supposed to be a band to be last. So we are looking at lessons learned from improved HMIS 106A reporting rates and timelines from Mbale City. Everyone here was talking about data. Because without data, we would not be here speaking about our researches we are doing in the field. Am I right? Yeah. Yes, I'm right. Okay. Okay. Those are my co-authors. Damari Waiswa, my regional supervisor. Loy Monje, my biostatistician, Mbale City. Then the remaining, those are IPs, that is Beira in Eastern. Okay. Introduction and research objectives. We realize that Ministry of Health uses data to map hotspots of TB infection, monitor and curb the disease progress. You realize that districts support health facilities by feeding data into the health management information system on a weekly basis, monthly and quarterly basis. Between October to December 2022, Mbale State TB reporting rates for HMIS 106A stood at 77%. When you see the problem which made us to be at 77%, you realize that we there was no reporting reminder messages to the health facilities. You also see that there was inadequate knowledge on reporting into the HMIS 106A by our HIAs. Then you also see that no performance reviews, data validations, and teamwork in most of the facilities. Then there was inadequate computers in the Mbale City Health Office. Okay, design and methods and analysis. We had to start the continuous quarterly data collection, validation, support supervision, coaching, and mentorship. So here we would bring HIAs on board. When we go to facilities, we ensure that the data people, the art clinic, TB team, lab team, they're all on board. So as we are doing support supervision and mentorships, we ensure that all these people are on board. So in that process, we encourage teamwork. We are showing them that we are supposed to work as a team in order to achieve what we want. Then the next, facility in charges. Okay, in Mbale City, we also do performance reviews, both facility and district level. You realize that performance at the facility level, here in charges, HIAs, and other staffs sit and they review their data in the facilities. So in charges on their PHC, they provide these HIAs some little data to report this data they collect in their facilities on time. So when they review their data and they realize that their reporting rates are low, in charge will have to ask the HIA to explain why they are reporting late and yet is being provided some data to collect the data in the facility and report on time. Then for the Mbale City performance reviews, here all stakeholders come on board. One day we had our RCC in Mbale City when we were performing our performance review. So when they projected the reporting rates, some of the facilities were in red. RCC had to make one of the in-charges stand up and tell him, can you please tell us the reason why you should remain in-charge when you're failing to report on time? So that one also helped us to improve on our reporting rates as Mbale City. So TB and Leprosy supervisor received a computer that was given by Beila, our IP in Mbale City. So this one helped me to support facilities enter data into the DHIS2 on time. On a quarterly basis, my BISAT ensures that I'm on a team which is going to support facilities in Mbale City to collect the data, quarterly data, HMIS 106A. So as we collect this data, different teams come on board. We sit, they update their registers, we collect the data together. Facilities which, like HIAs complain they don't have data, I ensure I carry these reports because I usually move with 2 copies. One copy is retained at the facility, another copy I go with it at home. So when we have like 2 facilities, I go with my copy at home and ensure that the TB HIV section is entered and completed and ensure that I run the validation to ensure that I minimize the queries which will come up during data cleaning. So that one also helps me to enter that data on time and ensure that the reporting rates are doing well in Mbale City. Because those days, I could not have a laptop, so I could collect the data and give the HIAs I'm moving with. So by the time you realize they are ranking your district in red that you have not reported, yet the HIA you've given is sitting with those reports and not entering them on time. Mbale City Biostatistician created a WhatsApp group with the HIAs. Here they share their strategies on reporting. They also share those facilities which are not reporting on time. So they, as a team on that WhatsApp, they share the ways of ensuring that they report on what? On time. That one has also helped us as Mbale City to improve on the reporting rates. Then the technical focal persons team up to promptly update their registers before entering the DHIS2 final reports. So as we are doing this support supervision, I told you, we bring everyone on board and show them that this one, you have to work as a team in order to achieve what you want. So they sit, update the TPT register, because when we come to that section of TPT, all those ones who are eligible, people living with HIV, sometimes you realize that they update the HIV care card and the TPT register is empty. So when you come to collect that quarterly report, it gives you a challenge. When they sit and do that before the data collection, it becomes easy. You come collect on time and enter that data on time. These things of .com. So those are the key findings. You see the graph is describing what I've been talking about. October, December 2022, we're at 77%. So when we started those quarterly data collections, validations, review meetings, and mentorships, things slightly changed to 86% by January, March. When a Biostat also created a WhatsApp group, they shared their things there. So again, we increased a bit to 91% by April, June. When I received a laptop, this time I said, I'm not going to leave you with the reports. We shall make together the reports. I retain your copy at the facility. I will go and enter this report myself. I don't want to be below 90 this time. So there, we stood at 100%, and we maintained up to October, December 2020, and I'm sure this Jan, Feb, March, we shall maintain 100%. The implications for the national TB and leprosy response.
2 minutes.
I said, since I'm the last, you have to add regular performance reviews at both district and facility level can improve on most of our indicators. Provision of computers to DTLSs can help to improve the timely reporting rate through monitoring and flagging non-reporting sites. Then peer sharing challenges in the safe space helps adaptation and performance improvement. As I said, Biostat created a WhatsApp group for only HIS, so they used to share their things, their problems there. So when they share them in privacy, things can also improve than bringing in other people, like the DHO can start quarreling and people shy away from contributing to their challenges. So there are the actions. Okay, like when you look at that gentleman, okay, among the ladies there is a gentleman on the other side, that is my HSD Northern Division City. In pink, that is the TB focal person in Amanyonyi. So we are looking through the data. So as I do that, I make sure I go with my laptop they gave me. I make sure weekly reporting in that quarter, for example, January, February, March. I ensure that week 1 to week of that reporting period I'm visiting that facility, I ensure that I clean that data from week 1, 2, 3 up to where I'm stopping. Because I realized last year, ministry ranked us according to the weekly reporting. And I was number 36 because of PBCs accessing GeneXpert. Yet in the registers, all of my PBCs were accessing GeneXpert. But because they send samples, then people report and they forget to go back and update after the results, we were able to stand at number 36 position. So this time when I move, I make sure I validate the data from primary tools and weekly reporting, monthly, then we support the quarterly also. So I acknowledge all that you're seeing. Thank you very much. I submit.
Thank you so much, Zoena, for representing the district supervisors and sharing your lessons. I know the house there is a high loss to follow up. And we are here deliberating on how we can improve treatment success rate in Ankole. So we would like to get views. I would like to thank our team, the presenters that have been able to share. I'm also thanking myself for sharing what the implications we might have and what we have noted We need some feedback. We don't know what we shared, if it can inform policy. We have proposals. What do you think? Yes, Dr. Semitala.
SC asked how many we have online. I think the last follow-up is universal because we've gone from 97 to 34.
I hope the boy children are still online. Well, thank you so much for the very eloquent presentations. Dr. Brewer, just a quick validation question. I've had you quoting some studies from South Asia and many other places that you are using to make a policy. How much validation have you done to make sure that what has worked in those setups actually works, is going to work here, and the best way to for us to move forward? Because in implementation science, we know that context matters and should be given the due consideration. Thank you. And maybe to the chairperson, I noted the number of people you screened and tested. And did you say, is it in Wakiso or Kampala where you didn't get any positive? As we run into a stage where resources are very scarce and very limited, how do we improve the return on investment in such campaigns so that we don't spend the mega resources where there is no yield, but rather try to make sure that we spend those resources in a targeted manner? Thank you.
Thank you so much for that feedback. Do we have any other person who would like to speak to us? Civil society.
We have a question at the back. As I go with the question, Chair, I would like to give a thought that the TPT uptake in our schools was very low, and understandably, because the schools have to ask the parents for permission, which you don't see in the community. You have very high TPT uptake. So do you think that if we had the TB skin tests, this would be a good place to deploy them? If you found one positive child in a hospital, it would be a good place to deploy the TST to help convince the parents of the children who have latent TB that they would benefit from TB preventive therapy. Okay.
Yeah, thank you very much. I'm Freddie Bill, Fellowship of TB Survivors, Uganda. This one goes actually to the DTLS Mbale City. I do actually appreciate your presentation. It was quite okay. And this is actually basically what I wanted to find out. You have done a lot in Mbale City towards health department, but I wanted to find out in all that you have done, how have you involved the TB survivors in much of the community activity as you get some of this report? Because I believe they could be the right people actually to give you more data. So I wanted to find out how have you involved the TB survivors basically towards the community work.
Thank you. Do we have any other person that listened with interest? Yes.
Yeah, Samson again, my preferred. Yeah, we've been listening, and the whole issue of men, it it is puzzling me. And I was like, is there any strategy that we will use to get the men to test? I wanted to direct it to maybe my sister Jasper. I don't know with your whatever. What is it that we can really do? But also, as you're talking about policy, we've always been, it has always been spoken that our policies are only written, but we are not putting them into action. So what strategies, even as a program, maybe this is general, do we really want to put in place that our policies will become functional?
Thank you. We have a hand with Keith. Here.
Thank you very much. I particularly listened to Dr. Jasper's presentation with interest. There was a complex tool used. Is it a Likert scale with parameters like fidelity, dose, adaptation? How did you break this down for the health workers you are involving? And then it sounded like you are making adaptations along the way to ensure that gender-sensitive services were offered. Thank you.
The last hand. Did you have your hand up? Shafiq. Mm-hmm. Oh. Okay, we need to move faster.
Thank you. This is Moses from Uganda Stop TB. I appreciate the presentation, and I'm particularly reaching my observation to the presentation by the city TB focal person from Mbale City. I know she's one of the person who has been leading the mentorship to increase the case finding in the public health, private health facilities. So I'm wondering, in our areas of support, in the case findings she presented, she did not say anything about the private facilities. Was it an error, or she could say something? Why did you cite some of the successes that Mbale City got in engaging with private health facilities? Thank you.
I think the last question is mine. Thank you very much for the wonderful presentations. My question goes to the chair about the school campaign. I was wondering whether we have some data on any history of TB, recent history of TB for those children, with the opinion that some of those that were diagnosed maybe were already in TB treatment, or there was some recent, that's my question.
Yeah, so Chair, before they answer, just two comments from participants online. Dr. Joseph Kauma encourages people working with men to make bold statements, communicating to men with TB, and also to men who think they don't have TB. Then Dr. Joseph Imuko says that my comment is for Aldo and the program as a whole: achieve and sustain high case finding and treatment success for at least 6 years, and then you are likely to see a higher impact on TB incidence. So those are the comments from online.
Thank you, the online participants, for staying with us. Would like to appreciate you for the feedback, and I will hand it over to Dr. Aldo to just make sure that your questions are covered.
Okay, yeah, thank you so much. I want to appreciate the feedback. As I said, it's still a work in progress, so we take note of the feedback. However, just to respond to Dr. Fred, regarding the evidence that we looked out, you realize as we are searching for evidence, we wanted to see which interventions for case finding have impacted on incidents. So most of the papers that we came across did not report on impact on incidents. But there are quite a lot of work done around case finding. that really led to increase in case notification. So within Uganda and East Africa, there are quite limited evidence that we found, apart from the one which I mentioned, that was done in Kampala here. But also, I mentioned that for the study that was done in Asia, in Vietnam in particular, it was actually a prevalence survey, and that is an approach which is used almost globally in many countries. So it is still applicable in our setting here. Yeah. So, but there is need to, of course, look for more evidence to enrich the recommendations. Then the other comment from Dr. Imoko, I want to appreciate. I think it was not a question, but he was contributing that if we can sustain the case notification for some time, we are likely to achieve reduction in incidence. Probably this is also another evidence that we need to have it documented. So I believe we shall be able to synthesize that information and include it in our brief if it's already out there in the public domain. That's all I can. Thank you.
Thank you so much. Damain.
Yes. Thank you for the questions. I'll start with Samson's question. He asked what can be done for policy to become functional. So policy is a very big term, and sometimes it's not broken down, but policy is not only what's in documents, it's also the actions that you find in the health facility. So what Light wants to do is build an evidence of research to support the interventions that we'll finally recommend. We're in year 4, I believe, moving into year 5. So at the end of this entire project, we hope to have evidence that we can recommend. And I know that ministry and the NTLP have so many mechanisms in which they're trying to support this facility, so that findings that we discuss in forums like this, through mentorship and support supervision, get translated into what is actually done, and that's where policy will start to really have impact. And that dually answers the question on how do we find men. We're really doing a lot. As I mentioned, we're doing research in several countries, trying to find men in community, trying to find men who try to access the healthcare facility. We hope to answer this question, and I know we're not the only ones working on this. So we hope to build evidence for that. About the tool and the Likert scale. So the way we did this is that healthcare workers who are actually involved, we had 3 components. So if you're involved, I'm going to focus on the intensified case finding. Stamp if you're actually involved either in OPD, stamping patients' records and the like. Following the training, we told them we would like this tool to be used in this way. Stamp all patients' records, ask them these questions. If they're presumed to have TB, the investigations that we're supposed to do. We had Aldo and the team from NTLP who participated in this training. So when we went back, for fidelity, we'd ask them, was it implemented as planned? And as planned was already defined. So we didn't use the word fidelity. We used the plan that we had used. For those, how frequently were you doing it? Was it being done on all days of the week? Was the intensified case finding stamp left in a place that was easily available? And we used a pie chart where they were able to shed. So we first were able to shed, and then after shedding, based on the extent which you've put it, that's when we'd bring in the Likert scale, just so that we could have a quantitative measure, so that we could interpret the extent that the healthcare workers have assessed themselves. So yes, I agree we need to make bold statements about men and how to involve them into care, because this is one of the things that we really need to reach the 90, 95, and 0 targets to NTB. Thank you.
Thank you very much, Odong and your colleague, for the questions. To put myself right, I presented on the land improvement on the HMIS 106A reporting rate and timeliness from Bali City. Actually, when I'm collecting data, when I'm doing support supervision, when we are collecting quarterly data, we don't involve the TB survivors. Those ones come in like a cough monitor. I have one of the facilities which is having a cough monitor as a TB survivor, works as a cough monitor in that facility. We also engage them in the community activities, but when you are collecting the data, we don't involve them. That is the HMIS report, which we collect and feed in the DHIS2. So TB survivors are not involved. Then for Odong, you asked me about the case finding. So in this presentation, the case finding was not part. I was actually looking at the good reporting rates in Mbale City. But for private facilities, me and a team in the city, we are supporting them. Actually, most of them are doing well. They are getting cases. We are on the ground supporting them. They are contributing to our cases in Mbale City. Thank you.
Thank you so much for the feedback. The first question was about the return on investment for where we didn't find a child confirmed with TB. When we are doing community work, the first thing we are looking at is awareness. So yes, we didn't pick a child who had TB, but remember, there was a child that came from there. All those schools we went to, there was somebody that was coming from that school. So there are other ways, other benefits for us going there. If you are comparing only the case as the return, then it is not a good choice. But if you are looking at what the children are going to learn and take back home, and maybe what they are going to practice, there's something probably we shall see in due course. That was the first time, and definitely contact tracing is critical. I think there's still return on investment, but if you are looking at it on the case, then there was no return on investment on that particular area. Take note also as well, we went to 33 schools, but the numbers reached were around 5,000. This is Kampala Mukono Wakiso. There was a little bit of targeting also, just to make sure that we don't just spend so many days in the school reaching everyone, and when actually those people are unlikely to have been in contact with that particular index case. So there was a little bit of also targeting on those that needed to be screened. Yeah, so we think that even when we didn't find a case in Wakiso, there was health education and awareness, and the children got the message. So that message goes beyond even the school, it also reaches in the household, which is in line with the CAST and CAST Plus that we are talking about these days. The other area was the TB skin test. I don't want to be very stamp it that it's possible or not. I think something that we can try out and see, the reception of that, if it could be accepted in the schools. Definitely for anything that is health that needed to be introduced in the school, we need to engage the Ministry of Education. All these messages, and when you go there, they are vetted to see if they are in line with the curriculum, what they are teaching. Is it going to help the child learn, and also emphasize those skills that they expect them to pick up as they go through the levels of education in the schools. And again, and even when it comes to immunization, which is supposed to be universal, you still have to get consent from the teachers and from the parents. So I think it's something that we can try out and see the reception of that test, and if it will also help us to actually scale up the TPT or improve the TPT uptake in the school children or school-going adolescents and children. Shafiq, around the exposure. Some of these schools that we went to, the index case was actually a teacher, an adult. So those led us to the schools. So some of them were children, others were teachers, or somebody who is within the staff, the staffing structure of the schools. So we used that to identify the people that needed to be screened or contact traced. So if that teacher was teaching certain classes, then those classes would be prioritized for that. If the school population was less, then we could also have an opportunity to talk to them at assembly to raise awareness before you deep down into screening. So we did use that index case to list for us the people that could be screened. With our intervention, some of them could be linked, some of them could not be associated with the index case. So I don't think I can objectively tell you that we ascertained all the information on the index, on the exposure for the children that we identified. Some of them, yes, we could infer if there was an adult, but others were only using the information available to actually expand. What, as I mentioned, we had to deal with disclosure to the parents. Because you know, when you say that that child has been identified with TB, diagnosed with TB from the school, it's unlikely that the parent would accept that actually this exposure could have been from home. So there is more that needed to be dealt with to ensure that it is well received and they consent. So our primary objective was to ensure that you identify and start treatment and offer TPT. Those TPT, there was low acceptance on that because we needed to deal with other parents now, meaning that you needed to disclose who is the index, why my child, not the other one, something like that. You needed more time of engagement and also convincing that they needed to take TPT. So that issue around disclosure, because as in schools, word moves. If you approach more parents, you have to explain. The administration has to explain, even beyond the health workers. So I don't think that we did enough around going back to identify if the exposure was not even in school. Yeah, thank you. Would like to, I think we have exhausted the questions and the clarification. Thank you so much for staying with us. And Evelyn wants to close the session with some remarks. Okay, thank you so much. So when we are recognizing you for being part of my panel. Thank you so much for showing interest to write what you do, to share what you do. I think that's why we are appreciating you, and I believe the Assistant Commissioner was very interested in what you are presenting. Please encourage more people on your team to write. And I believe the scientific committee was available to also see that they mentor more people to share what works for them, in their world what works, or in your world. So thank you so much. Take back our appreciation to the team you worked with as well. And for the rest of us, thank you so much for sharing. I would like to take it back to Dr. Stella and Chairperson to advise us on the next steps. Thank you, everyone. We can take our seats the other side.
Thank you so much, all our session chairs for the day, all our presenters, all our delegates. Thank you so much for coming. Today, day one, we will not end. We will just adjourn, but we will ask our Assistant Commissioner. All right, we'll ask Dr. Stavia to come and adjourn the day. The evening tea is downstairs.
Okay, she's going to confirm. All of us, very committed participants of today, all protocol observed. Good evening. Yes, today I was the happiest person in the room. These people always have their researches there, they publish. I meet them in conferences. Today I met them here. So I'm the happiest person of the day. Thank you so much. The academia for leading us in today. And also, we know you are going to open more and more tomorrow. We are eagerly waiting for what you are doing in those behind the tables and the computers and so on. So we'll continue with our conference tomorrow. Summit, now I've changed it to a conference, I'm sorry. Yes, like we had in the morning, this is the start, and we want to continue to make sure that we have this interaction with the researchers, with the innovators, at least more regularly in a more formalized way. This summit will stay in the coming years as well. So those of you who are trying to write more abstracts for us to take on your evidence, please do so. We'll start at 8. We'll start actually early tomorrow. I've asked the people who are online, the IT team, you need to open the links very early and start posting our posters throughout the morning. Then by the time we come at 8:30 to start the oral abstracts presentation, at least people who will be online are already following on what the posters are saying. So let's all come back tomorrow and we continue this very vibrant use of evidence to inform our policies and program. Thank you. That said, day one closed. The tea is outside. Please grab a cup of tea and you go and brave the potholes and the jam.